airway malicious esophageal atresia hypertrophic pyloric stenosis tin Meckel diverticulum ce midgut volvulus and intestinal malrotation Hirschsprung disease tin AI congenital visceral malformations equals congenital visceral malformations abdominal hernias, congenital umbilical hernia, congenital anomalies of the kidneys polycystic kidney disease megauritor bladder exstrophy, abnormalities of the male urethra, and webbed penis anomalies of the female genital tract at GQ if home library lists settings. X neural tube defects. Neural tube defects, NTDs, are the most common congenital malformations of the central nervous system, CNS. They develop between the 3-degree and 4-week-old pregnancy and are often caused by folate deficiency. Most commonly, a deficiency in folate results in improper closure of the neural tube in the embryo, mainly at the caudal or cranial ends. The formation of defects at the caudal end is more common and is known as spina bifida. Spina bifida may occur without any apparent clinical features, spina bifida occulta, or manifest with protrusion of the meninges and, potentially, the spinal cord, myelomeningocele, through a gap in the vertebrae. Myelomeningoceles predominantly cause symptoms of sensory and motor function loss, such as bladder dysfunction and paraplegia. NTDs at the cranial end can cause cranial fissure malformations. The most severe manifestation of this, anencephaly, is incompatible with life. The diagnosis of NTDs is often established during pregnancy via ultrasound and detection of elevated alpha-fetoprotein levels in the maternal serum or amniotic fluid. Treatment involves prophylactic administration of antibiotics and rapid surgical closure of the defect to avoid CNS infections. Supplementation with folate is an important preventative measure and should ideally be initiated 4 weeks prior to conception. OCE. Definition. Neural tube defects, NTDs, are congenital malformations of the central nervous system, CNS, spine, and cranium. NTDs are caused by incomplete closure of the neural tube during neurulation, which takes place during the 3 and 4 week after conception. Copyright cranial defects, incomplete closure of anterior neuropores cranial cleft formation, mostly open defects, with involvement of the skull and brain copyright spinal defects, incomplete closure of posterior neuropores bone defects of the vertebral arches, mostly lower lumbar or sacral region possible herniation of spinal neural tissue and meninges NTDs can be classified according to affected structure and degree to which the defect is covered by tissue. Open NTDs, meninges and/or neural tissue are uncovered and, therefore, freely exposed to the surrounding, example amniotic fluid. 1 copyright closed NTDs, defect is covered by skin and/or connective tissue. VA. 6. Epidemiology. 3-2 NTDs are among the most common severe congenital malformations. Spina bifida and anencephaly are the most frequent NTDs with a combined prevalence of approximate 6.5:10,000 live births per year in the U.S. 3 Epidemiological data refers to the U.S., unless otherwise specified. WA. CE. Etiology. Most NTDs are isolated malformations with multifactorial etiology. Maternal risk factors folate deficiency during pregnancy due to insufficient folate supplementation, see prevention below, drugs that interfere with folate metabolism methotrexate anticonvulsants, valproate, carbamazepine sulfonamides, trimethoprim gestational diabetes mellitus obesity fever/hyperthermia during the first trimester fetal causes chromosomal aberrations, example trisomy 13, trisomy 18, and other genetic factors amniotic band syndrome copyright Chiari 2 malformation 4. Overview. Spinal defects, subtypes of spina bifida, MA =AQL. Collapse fine text outline. Spinal defects, subtypes of spina bifida, A. 4. Condition description, clinical features, diagnosis. Closed spinal dysraphism. Most commonly affects the lower lumbar or sacral region. See often asymptomatic, may be an incidental finding in imaging, possible symptoms at the level of the vertebral defect. Normal, most common closed NTD spina bifida occulta ascent vertebral bone defect without herniation. The spinal cord, meninges, and overlying skin remain intact. Lumbar skin dimple AFP copyright collection of fat degree patch of hair. Asterisk myelomeningocele that also contains fat tissue and is covered by plus often asymptomatic skin. Normal subcutaneous mass in the lumbar or sacral region. Lipomyelomeningocele AFP possibly skin dimple and slash or patch of hair. Lipomeningocele asterisk meningocele that also contains fat tissue and is covered by skin. Degree YP4. Open spinal dysraphism law. Asterisk meninges, without neural tissue, herniate through vertebral bone. Asterisk most commonly affects the lower lumbar and slash or sacral region. Meningocele, ZETAFP defect. Asterisk neurological symptoms vary depending on the location and extent of neuronal damage. Asterisk meninges and parts of the spinal cord herniate through the vertebral. Copyright motor loss, flaccid paralysis, rare, Y7 bone ETSA H underscore. Copyright sensory deficits TAFP-scent feature of Chiari-2 malformation. O bladder anaboal dysfunction asterisk associated with maternal diabetes and folate deficiency. RL scent additional symptoms. OC asterisk portions of the neural tube completely fail to fuse, leading to bare. Copyright hydrocephalus, common. 7 Hishicil D neural tissue without coverage of meninges, bones, or skin. Degree associated skeletal malformations, especially of the spine and lower. Degree 7 AFP, rachitis, asterisk most severe subtype underscore extremities, example clubfoot, sacral dimpling, joint contractures, back pain. Velocell scent parts of the spinal cord, without meningeal coverage, herniate. Copyright developmental delays, cognitive impairment, progressive neurological plus AEP. Elacele Y through the vertebral bone defect. Symptoms. Cranial defects for condition description, clinical features, diagnosis. Anencephaly, rostral neuropore remains open leading to the absence of the forebrain and a open cranial vault. Polyhydramnios Baudiatsmings plus TAFP incompatible with life. Malformations and neurological deficits that vary in brain tissue. Herniates through occipital or frontal bone defect. 9Y plus normal AFP, usually not encephalocele severity usually covered. D by ski skin lethal in severe cases. Elevated, A. Failure of cranial bones to form acrania incompatible with life asterisk TAFP often associated with anencephaly. Co. The most common NTDs are spina bifida and anencephaly. O. OE. Diagnostics. Prenatal period. Plus screening test, 16 to 18 weeks gestation. TAFP in maternal serum, MISAFP. MISAFP is only elevated in open NTDs. MISAFP is not elevated in spina bifida occulta. Usually part of the quad screen test. Plus ultrasonography, 18 to 20 weeks gestation. Copyright characteristic findings depend on the specific defect. 1. Equals findings in anencephaly. Equals cranial vault and brain tissue are absent. Residual, disorganized cerebellar and slash or brainstem tissue may be present. Equals bulging eyes and underdeveloped forehead. B equals a CD. Elapsed spine text outline. Equals associated with polyhydramnios. Copyright screen for malformations of other structures, example abdominal wall defects. Copyright rule out other causes of elevated MISAFP, example miscalculated gestational age, multiple gestations, fetal death, amniocentesis, TAFP and PTA in amniotic fluid, increase in open NTDs only. Used as confirmation test when MISAF is elevated but ultrasound findings are inconclusive. O when both AFP and AIC are elevated, an open NTD is very likely. O amniocentesis may also be used to test for chromosomal abnormalities associated with NTDs, example trisomy 13, trisomy 18. At AFP is only elevated in open NTDs. Postnatal period, 1. Send complete physical examination. Copyright lumbar skin dimple or tuft of hair, often seen in spina bifida occulta. Copyright associated malformations, example abdominal wall defects. Copyright extent of neurological deficits, example muscle weakness, spasticity, abnormal reflexes. Copyright signs of elevated intracranial pressure, example bulging fontanelle. Send imaging. Copyright cranial ultrasonography, to monitor hydrocephalus A. Copyright CT scans /or MRIJ equals monitor hydrocephalus equals evaluate bone defects and/or neural tissue. Lesion. Imaging is especially important to plan surgery. FOOE. Differential diagnoses. Tethered cord syndrome/LEL. Scent definition, a functional neurologic disorder caused by abnormal stretching of the spinal cord as a result of adhesions or obstructions attaching the caudal spinal cord to the spinal canal. Etiology: myelomyelingocele/lipomyelomyelingocele, most common cause, copyright lipoma, dermoid cysts. Meningeal adhesions, example after surgery for myelomyelingocele or spinal trauma. Adhesion or thickening of the phylum terminal degree tumors. Scent clinical features: lower back pain, aggravated by flexion of lower spine. Copyright sensory and motor deficits of the lower limbs, example muscle weakness, spasticity, abnormal reflexes. Copyright bladder/bowel dysfunction. Skeletal malformations, example foot deformities, scoliosis. Visible tumors or skin lesions on lower back, example discoloration, hairy patch, dimple, lipoma. Scent diagnostics: MRI may show abnormally low position of the conus medullaris, thickening of the phylum terminal, meningeal adhesions, lipomas, dermoid, cysts, or tumors. Scent treatment: removal of structure tethering the spinal cord, example adhesiolysis, resection of lipoma. Congenital dermal sinus. Scent definition: mostly lumbar or lumbosacral fistulae that extend from the surface of the skin to the spinal canal and frequently end in a dermoid or epidermoid cyst. Scent etiology: incomplete or lack of separation of the neural ectoderm from the dermal ectoderm. Scent clinical features: copyright visible ostium, dimple, possibly hyperpigmentation of the skin, and hypertrichosis. May manifest with clinical features of tethered cord syndrome, see above. Copyright complications: intradural infections, recurring meningitis, abscesses. Scent treatment: neurosurgical exploration and potential resection of the dermoid or epidermoid cysts. The differential diagnoses listed here are not exhaustive. 7*CE. Treatment equals QAL. Collapse. Fine text outline. X neural tube defects. Scent clinical features: copyright lower back pain, aggravated by flexion of lower spine. Copyright sensory and motor deficits of the lower limbs, example muscle weakness, spasticity, abnormal reflexes. Bladder/bowel dysfunction. Copyright skeletal malformations, example foot deformities, scoliosis. Copyright visible tumors or skin lesions on lower back, example discoloration, hairy patch, dimple, lipoma. Scent diagnostics: MRI may show abnormally low position of the conus medullaris, thickening of the phylum terminal, meningeal adhesions, lipomas, dermoid, cysts, or tumors. Scent treatment: removal of structure tethering the spinal cord, example adhesiolysis, resection of lipoma, congenital dermal sinus. Definition: mostly lumbar or lumbosacral fistulae that extend from the surface of the skin to the spinal canal and frequently end in a dermoid or epidermoid cyst. Scent etiology: Incomplete or lack of separation of the neural ectoderm from the dermal ectoderm. Scent clinical features. Copyright visible ostium, dimple, possibly hyperpigmentation of the skin, and hypertrichosis O may manifest with clinical features of tethered cord syndrome, see above. Copyright complications, intradural infections, recurring meningitis, abscesses, scent treatment, neurosurgical exploration and potential resection of the dermoid or epidermoid cysts. The differential diagnoses listed here are not exhaustive. AACE. Treatment. Scent prenatal. Copyright after counseling, patients should be referred to specialized clinics for continuation or termination of the pregnancy. Myelomyelingocele, fetal surgery may be indicated, depending on fetal and maternal risk factors. Scent delivery. Copyright should take place in a specialized center, providing neonatal ICU and pediatric neurosurgery. Copyright birth mode, usually cesarean delivery, prelabor. 7I8 Scent postnatal. O general management equals cover defect with sterile, wet compresses, avoid pressure on defect, prophylactic administration of broad-spectrum antibiotics. Copyright surgical treatment equals open NTDS, surgery should be performed within 72 hours after delivery, to reduce the risk of CNS infection. Equals closed NTDS, monitoring and possibly elective surgery equals hydrocephalus, consider placement of a ventriculoperitoneal shunt. Copyright long-term care equals complex treatment. Equals may involve physical therapy, rehabilitation programs, and specific treatment of neurological disorders, example neurogenic bladder dysfunction. 7. ORO. Prevention. Plus folate supplementation in pregnancy, according to the U.S. Preventive Services Task Force 5. Copyright 400 to 800 gigs/day for all women planning or capable of pregnancy, at least 4 weeks prior to conception. Copyright women with a history of a previous pregnancy resulting in an NTD equals 400 to 800 gigs/day when no pregnancy is planned equals 4 mg per day when pregnancy is planned, at least 4 weeks prior to conception. 9O intake should be continued through the first trimester. At supplementation of 400 to 800 Wg of folate per day is recommended for all women who are planning for pregnancy. Equals QAL. Collapse. Fine text outline. Neural tube defects, 1/5. Unfused dimple with dash. Laminate. Vertebral arch plus sal, USSWO, Duramater /7W147X spinal cord OLK, ion, SI /CQ Uvarachnoid space. Spinal defects VV. Copyright on Boss. Neural tube defects, 2/5. Open spina bifida V. A large cystic structure has herniated through the vertebrae at the level of the thoracolumbar junction. This finding is consistent with open spina bifida. Subtyping will require further diagnostics. Source, copyright IMPP. Neural tube defects, 3/5. Open spina bifida. Lumbar region of a neonate. The protruding cystic lesion with concurrent hypertrichosis is consistent with open spina bifida. Subtyping requires further diagnostics. Source, copyright IMPP. Neural tube defects, 4/5. Open spina bifida VV. Back of a neonate. The two protruding cystic lesions are consistent with open spina bifida. Subtyping requires further diagnostics. Source, copyright IMPP. Neural tube defects, 5/5. Forebrain absent. Forebrain midbrain open. Cranial vault hindbrain TAFP levels. Polyhydramnios. Anencephaly VV. Copyright on Boss. Dermal sinus VV. There is a lumbosacral fistula that extends from the surface of the skin to the spinal canal, terminating as a dermoid or epidermoid cyst within the spinal canal. There is hypertrichosis in the region of L5. These findings are consistent with a dermal sinus. Source, copyright IMPP. Craniosynostosis. Craniosynostosis, CS, is the premature fusion of one or more cranial sutures. It is caused by a mutation in genes that code for fibroblast growth factor. Most affected infants are asymptomatic. CS is usually recognized based on an abnormal head shape in the first year of life. The shape of the skull is determined by which suture is prematurely fused, of which the sagittal suture, scaphocephaly, is the most commonly affected. When multiple sutures are involved, CS may cause hydrocephalus and/or cerebral constriction. Diagnosis is clinical, with skull X-ray and CT scan helping to assess the extent of fusion. Surgery is recommended in all infants for cosmetic reasons and to treat/prevent intracranial complications. OC and B shared note manage. Epidemiology. Cent incidence, 1/2500 births plus potential risk factors, O hereditary, positive family history, E advanced maternal age, O nicotine use during pregnancy, O use of clomiphene citrate, used for infertility treatment, references. 22I3. Epidemiological data refers to the U.S., unless otherwise specified. 6. Etiology. E mutation in genes which encode for the fibroblast growth factor, FGF receptor, and/or transforming growth factor beta, TGF, scent altered FGF receptor, or TGFB signaling between the dura mater and mesenchyma of the suture, premature fusion of the skull suture, S, references, SIL 4LL5. Pathophysiology. The skull is composed of 5 separate bones, 2 frontal bones, 2 parietal bones, and the occipital bone. In a newborn, these bones are separated by patent sutures and fontanelles. Function of patent sutures and fontanelles. Copyright allow compression and/or overlapping of the skull bones during childbirth. Copyright allow for growth of the brain. Premature closure of one or more sutures. Craniosynostosis. See the article on skull. References, 3il. ES. Clinical features. Usually asymptomatic. Recognized as an abnormal head shape within the first year of life. 1. Skull deformity due to premature fusion. Suture/S involved features. Most common type of CS, 45%, sagittal suture, sagittal synostosis, long, narrow skull, boat-shaped. 1. Anterior plagiocephaly. +2D most common type of CS * unilateral coronal suture, J on ELYLISY laterally twisted/oblique skull and face. Back collapse. Fine text outline. Rare type of CS posterior plagiocephaly. Twisted/oblique skull J * unilateral lambdoid suture 1A equals, lambdoid SY is, occipitoparietal flattening on the affected side, low set ears on the affected side. Common type of CS, 25% of cases. Triangular shaped head, trigonocephaly. Metopic suture. 3-5P prominent occiput and parietal eminences. Close set eyes, hypotelorism, brachycephaly. Bilateral coronal sutures. Short, broad, flattened skull. Oxycephaly. F. Bilateral coronal sutures, if left untreated, long skull, increased craniocaudal dimension. 4. Pterocephaly, rare, but most severe type. Cloverleaf skull. Multiple cranial sutures, especially the metopic, coronal, and lambdoid sutures, +_trilobar skull, prominent forehead and temporal bulging, often associated with hydrocephalus and elevated intracranial pressure. References Li 7 ISL 91 L10111. WA Diagnostics. Mainly a clinical diagnosis. Skull X-ray, AP and lateral views. Bony suture bridges or lack of suture clarity. Cranial CT, with 3D reconstruction, Copyright to assess extent of CS. Copyright to identify hydrocephalus. E helps plan surgical reconstruction. References, LL9L. WA4 Notes of Craig and Note QO shared N. Differential diagnoses. The following conditions show patency of sutures similar to craniosynostosis on skull X-ray or ultrasound. Asterisk positional plagiocephaly. 1 Infant torticollis. References, 14. The differential diagnoses listed here are not exhaustive. OR Notes. EB shared note. Man. Treatment. Stent surgery, indicated in all patients either to minimize cerebral constriction or for cosmetic reasons. Copyright strip craniectomy or cranial vault remodeling. A copyright timing, controversial, mostly recommended at 3 to 9 months of age. References to IL3. GE. Sources. Last updated January 21, 2022. Back collapse. Fine text outline. Frontal suture. Anterior fontanelle. Coronal suture. L. Sagittal suture. Posterior fontanelle. Lambdoid suture. Cranial sutures and fontanelles. VV skull of an infant, cranial view, anterior fontanelle, diamond-shaped structure located at the junction of the frontal, sagittal, and coronal sutures between the two frontal and two parietal bones. Normally closes between 12 to 18 months of age. Posterior fontanelle, triangular-shaped structure located at the junction of the sagittal and lambdoid sutures between the occipital and two parietal bones. Normally closes between 2 to 3 months of age. Copyright Boss. Scaphocephaly, plagiocephaly, brachycephaly, trigonocephaly, oxycephaly. AE \_O \_6 /8 @ EE 7P1 by B7CBAEESBA NEF CA 8 \I 1s2 /Pilia /A /G /Li ed AEOAVL Craniosynostosis VV Scaphocephaly / dolichocephaly, fusion of the sagittal suture. Plagiocephaly, unilateral fusion of the coronal suture. Brachycephaly, bilateral fusion of the coronal sutures. Trigonocephaly, fusion of the metopic suture. Oxycephaly, fusion of multiple sutures, i.e., bilateral fusion of the coronal and the lambdoid suture. Copyright Boss. X craniovertebral junction anomalies. The craniovertebral junction, CVJ, is composed of the occiput, the foramen magnum, and the first two cervical vertebrae, encompassing the medulla oblongata and the upper cervical spinal cord. Anomalies of the CVJ may be congenital or acquired. CVJ anomalies that decrease the volume of the posterior cranial fossa, example platybasia, cause Chiari malformations, while erosion of the cervical vertebrae causes basilar invagination, cranial migration of the odontoid process, and anomalous fusion of the cervical vertebrae causes Klippel-Feil syndrome. Clinical features of CVJ anomalies are due to compression of the brainstem and the spinal cord and may include recurrent occipital headaches, neck aches, bulbar palsy, and upper and lower motor neuron palsy. CVJ anomalies can also obstruct the flow of CSF, resulting in syringomyelia and/or hydrocephalus. Diagnostics include neck X-ray and CT/MRI of the head and neck. Surgery is often indicated to prevent or treat neurological symptoms. WA OOIEEE Overview. Basic anatomy. The CVJ is composed of the occiput, the foramen magnum, and the first two cervical vertebrae, the atlas, and the axis. It encompasses and protects the medulla oblongata and the upper cervical spinal cord. Etiology. Congenital anomalies of the CVJ. Copyright occiput, condylar hypoplasia, fusion of the atlas to the occiput, atlanto-occipital assimilation, platybasia, abnormal flattening of the base skull, OE atlas, atlanto-occipital assimilation, atlantoaxial fusion, aplasia of the arches O-axis, hypoplasia of the odontoid process, DENS, acquired anomalies of the CVJ copyright trauma, to the bones or the supporting ligaments of the CVJ copyright inflammatory, rheumatoid arthritis, ankylosing spondylitis o genetic syndromes, Down syndrome, achondroplasia, osteogenesis imperfecta o malignancies, chondrosarcoma, multiple myeloma, metastatic deposits. References L. O. CE. Chiari malformations. Scent definition, caudal displacement of the cerebellum with/without the medulla oblongata, through the foramen magnum, due to CVJ anomalies. Scent epidemiology. Copyright incidence, type Chiari malformation is the most common anomaly, 1 in 1,000 live births. O sex, 2a scent associations. O neural tube defects, especially meningomyelocele, O syringomyelia. Eo hydrocephalus. Copyright Klippel-Feil syndrome. O basilar invagination. Scent pathophysiology, multiple theories. O fluid theory, neural tube defect, cerebrospinal fluid leakage. Decreased volume of the posterior cranial fossa. Compression and downward displacement of the cerebellum with/without the medulla oblongata through the foramen magnum. E molecular genetic theory, congenital defects of the posterior brain and bony structures. Copyright growth abnormality theory, poorly coordinated cranial and cervical growth. Copyright crowding theory, small posterior cranial fossa crowding of neural tissue at the foramen magnum. Scent clinical features and diagnostics. Clinical and DI, of Chiari malfor. Type CM, Chiari malformation. Type ILCM, Arnold Chiari malformation. Type ILCM, Chiari 3 malformation. 7ZI = scent herniation of parts of the cerebellum and brain stem. Ectopic extension of cerebellar tonsils through the scent protrusion of cerebellar tonsils, vermis, and medulla. Definition = through an abnormal opening in the back of the skull. Foramen magnum oblongata into the foramen magnum, encephalocele. Usually symptomatic in adolescence/young adulthood, usually symptomatic in infancy. Copyright occipital headache, exacerbated by Valsalva. Copyright obstructive hydrocephalus, displacement of brain maneuvers and physical activity, tissue into the foramen magnum. Results in stenosis of scent, mostly fatal in early infancy. Copyright neck pain, the cerebral aqueduct. Scent for those that survive, _copyright radicular pain in the shoulders and arms. Degree breathing difficulties, including apneic episodes. Copyright upper and lower motor neuron palsies. Paid 2-hour cranial nerve disorders. Copyright feeding difficulties. Copyright cranial nerve disorders. Back collapse. Fine text outline. Clinical features and DI, of Chiari malfor. Type CM, Chiari malformation. Type ILCM, Arnold Chiari malformation. Ectopic extension of cerebellar tonsils through the protrusion of cerebellar tonsils, vermis, and medulla. Definition 3 Foramen magnum oblongata into the foramen magnum. Usually symptomatic in adolescence/young adulthood, scent usually symptomatic in infancy. Copyright occipital headache, exacerbated by Valsalva. Copyright obstructive hydrocephalus, displacement of brain maneuvers and physical activity, tissue into the foramen magnum. Results in stenosis of copyright neck pain, the cerebral aqueduct. Radicular pain in the shoulders and arms. Copyright breathing difficulties, including apneic episodes. Size. Copyright lower cranial nerve disorders. Copyright feeding difficulties. Degree cerebellar symptoms, example dysarthria, ataxia, downbeat nystagmus. The eyes pathologically drift upwards followed by a quick downward. Degree muscle weakness or numbness. Degree always associated with myelomeningocele, manifests with motor and/or sensory deficits at and below the level of the lesion. Some patients develop syringomyelia saccade. Some patients develop syringomyelia and/or hydrocephalus. Features of type CM. In addition, caudal displacement of a beak, dorsal midbrain, and, possibly, the fourth ventricle. CT/MRI of the brain * caudal displacement of cerebellar tonsils * small posterior cranial fossa. Scent treatment. Copyright surgery, indicated in all patients with type 2 and 3 CM and in symptomatic type CM degree surveillance. Indicated in asymptomatic type CM annual MRI of the brain to look for development of syringomyelia and/or hydrocephalus. References to IISIL4I. WA. OCE. Basilar invagination. Scent definition, abnormal protrusion of the odontoid process, dens, of the axis into the foramen magnum. Scent etiology, CVJ abnormalities, mostly acquired CVJ. Clinical features. Copyright recurrent occipital headache, neck pain or breathing difficulties, including sleep apnea or bulbar palsy or downbeat nystagmus. Copyright commonly associated with Chiari malformations, hydrocephalus, and/or syringomyelia. Scent diagnostics. Neck X-ray, lateral view protrusion of the odontoid process by = 3 mm above of Chamberlain line. Copyright CT, confirm X-ray findings. Type IL CM, Chiari 3 malformation. Scent herniation of parts of the cerebellum and brainstem through an abnormal opening in the back of the skull, encephalocele. Mostly fatal in early infancy for those that survive. Degree upper and lower motor neuron palsies. Degree cranial nerve disorders. Cerebellar symptoms. Epilepsy. Intellectual disability. Degree. Features of type CM. In addition, caudally displaced cerebellum and/or medulla protrude through an osseous defect in the skull, encephalocele. MRI, indicated in patients with neurological symptoms, can demonstrate brainstem/spinal cord compression, hydrocephalus, or syringomyelia, if present. Scent treatment, surgery. References, SI Lilly 7LL8. WA. CE. Klippel-Feil syndrome, congenital synostosis of the cervical vertebrae. Scent definition, congenital fusion of = 2 cervical vertebrae. Scent etiology. Copyright genetic mutation, sporadic/inherited, copyright associated with Chiari malformations, scoliosis, spina bifida occulta, or Sprengel deformity, a congenitally elevated scapula. Scent clinical features. Copyright classic triad, short neck, restricted cervical mobility, and low posterior hairline. Copyright hearing loss, genitourinary abnormalities, and cardiovascular abnormalities are also common. Back. VNA collapse. Fine text. AO. Outline. Scent features of type CM. Scent. In addition, caudal displacement of a beak dorsal midbrain, and, possibly, the fourth ventricle. CT/MRI of the caudal displacement of cerebellar tonsils. Brain * small posterior cranial fossa. Scent treatment. Copyright surgery, indicated in all patients with type 2 and 3 CM and in symptomatic type CMO. Surveillance indicated in asymptomatic type CM annual MRI of the brain to look for development of syringomyelia and/or hydrocephalus. References, 2 IISI4I. WA. RO, XO. Basilar invagination. Scent definition, abnormal protrusion of the odontoid process, dens, of the axis into the foramen magnum. Scent etiology, CVJ abnormalities, mostly acquired CVJ. Scent clinical features or recurrent occipital headache, neck pain or breathing difficulties, including sleep apnea or bulbar palsy. Degree downbeat nystagmus. Copyright commonly associated with Chiari malformations, hydrocephalus, and/or syringomyelia. Scent diagnostics. Copyright neck X-ray, lateral view protrusion of the odontoid process by = 3 mm above of Chamberlain line. Copyright CT, confirm X-ray findings. Features of type CM. Scent. In addition, caudally displaced cerebellum and / or medulla protrude through an osseous defect in the skull, encephalocele. OMRI, indicated in patients with neurological symptoms, can demonstrate brainstem / spinal cord compression, hydrocephalus, or syringomyelia, if present sent treatment, surgery. References I6 I728. O. OE. Klippel-Feil syndrome, congenital synostosis of the cervical vertebrae. Sent definition, congenital fusion of equals two cervical vertebrae. Sent etiology: O genetic mutation, sporadic / inherited, O associated with Chiari malformations, scoliosis, spina bifida occulta, or Sprengel deformity, a congenitally elevated scapula. Sent clinical features: copyright classic triad, short neck, restricted cervical mobility, and low posterior hairline. Copyright hearing loss, genitourinary abnormalities, and cardiovascular abnormalities are also common. Sent diagnostics: copyright cervical spine X-ray, AP and lateral views, cervical vertebral fusion, scoliosis, Sprengel deformity, and spina bifida, if present can be seen on X-rays. OCT, useful in planning surgery. OMRI, indicated in patients with neurological symptoms / deficits, can demonstrate cord compression and / or Chiari malformation, if present sent treatment. Copyright conservative management, cervical collars / braces / traction in mildly symptomatic patients without cervical spine instability. Copyright surgery, indicated in patients with cervical spine instability or neurological symptoms. References. 4 ACE. Sources. Last updated September 21, 2022. V. Back collapse. AO. Fine text outline. Craniovertebral junction anomalies, 1/5. Normal. Ventricles brainstem cerebellum. Chiari type 2, Chiari type 3. BA. Tectal plate deformation. Caudal displacement of cerebellum, brainstem, and foreventricle. Chiari malformations. Copyright Boss. Chiari type. K. Caudal displacement of cerebellar tonsils. Syringomyelia. 4 * ventricle enlargement, occipital lobe herniation. I. /BB plus cerebellar WWW, herniation / spinal cord herniation. Overlay. Chiari malformation. MRI head, T2 weighted, sagittal plane, low-lying cerebellar tonsils, green overlay, extend below the foramen magnum, white line, to C2 level and abut the medulla oblongata. The finding is consistent with a Chiari malformation. There is no evidence of a syrinx or hydrocephalus. Source: Chiari 1 malformation 13 WMRT2 sagittal, 001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Chiari 1.5 malformation. MRI brain, T1 weighted, sagittal section, the cerebellar tonsils protrude through the foramen magnum, red arrow. This results in crowding of structures in the posterior fossa and caudal herniation of the brainstem. These findings are characteristic of the bulbar variant of Chiari malformation, also known as Chiari.5 malformation. Source: Figure 1 in, type Arnold Chiari malformation with bronchiectasis, respiratory failure, and sleep-disordered breathing, a case report by Raffaele Campisi, Nicola Ciancio, Laura Bivona, Annalisa Di Maria and Giuseppe Di Maria, Multidisciplinary Respiratory Medicine Journal, Biomed Central, licensed under CC by 2.0. Modifications: in-image text removed. Craniovertebral junction anomalies, 4/5. Overlay. Chiari 2 malformation VV MRI head, T2 weighted, sagittal plane, of a neonate the brainstem, red overlay, is elongated. The medulla, M, fourth ventricle, yellow overlay, and cerebellum, green overlay, are displaced caudally through the foramen magnum, white dashed line. Source, Chiari malformation MRTT2 sag.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by 3.0. Craniovertebral junction anomalies, 5/5. Copyright overlay. Non-communicating hydrocephalus VV MRI head, T2 weighted, 2 slices in the axial plane, of a young child with known Chiari-2 malformation. The ventricles are markedly enlarged, green overlay, due to the obstructed passage of CSF at the craniocervical junction. The subarachnoid space appears unremarkable. Source, copyright IMPP. XXX diseases of the lacrimal apparatus. The lacrimal apparatus consists of the lacrimal gland, which secretes the aqueous layer of the tear film, the lacrimal sac, into which the tears drain, and the nasolacrimal duct, through which the tears drain into the nose. Inflammation of the lacrimal gland is called dacryoadenitis and is commonly caused by viral or bacterial infections. The condition typically presents with conjunctival hyperemia, S-shaped ptosis, mucopurulent discharge, and discomfort. Dacryostenosis refers to the congenital or acquired obstruction of the nasolacrimal duct, NLD, and presents with excessive tearing. NLD obstruction can cause stasis of tears in the lacrimal sac, which predisposes to secondary bacterial infection of the sac, known as dacryocystitis. The diagnosis is usually clinical, and may be supported by bacterial cultures, imaging, CT, X-ray, and probing of the nasolacrimal duct. Treatment is often conservative, example NSAIDs, warm compresses, but may also require antibiotics in cases of bacterial infections or invasive procedures to remove obstructions, example NLD dilation. See also lacrimal duct laceration. WA. A5. Dacryoadenitis. Definition. Etiology. Clinical features. Diagnostics. Treatment. Acute dacryoadenitis. Acute inflammation of the lacrimal gland. Infection, most common, copyright viral, mumps, EBV, CMV, herpes zoster, copyright bacterial, S. aureus, streptococcus, gonococcus, mycobacterium tuberculosis, degree fungal, histoplasmosis, blastomycosis. Inflammatory. Rapid onset and progression sent unilateral pain/discomfort over the lacrimal gland, lateral upper eyelid, asterisk characteristic S-shaped ptosis dash, possibly proptosis 1 asterisk palpebral conjunctival hyperemia and chemosis, possibly mucopurulent discharge, limitation of eye movement, diplopia, indicates orbital cellulitis, ipsilateral preauricular lymph node enlargement and fever may be present. Eye swabs, in patients with ocular discharge plus complete blood count, blood culture, viral serologies, in patients with fever CT scan, to look for evidence of orbital cellulitis 1. Viral dacryoadenitis may be self-limiting. Broad-spectrum 4 antibiotics, in febrile patients, presence of purulent discharge, positive blood/eye swab cultures. OI references is IL-4-LCIL6. Dacryostenosis. Congenital dacryostenosis. Chronic dacryoadenitis. Chronic inflammation of the lacrimal gland. Inflammatory/granulomatous conditions, most common sarcoidosis, granulomatosis with polyangiitis, autoimmune conditions, Graves' disease, Sjogren syndrome, neoplastic, lacrimal gland tumor, lymphomas. Chronic infections, less common. Can be unilateral or bilateral. 1. Insidious onset with painless swelling over the lacrimal gland, OAS-shaped ptosis, proptosis. Rare features of underlying disease may be present, see etiology above. Eye swabs, in patients with ocular discharge, screening for chronic infections, example tuberculosis, chlamydia trachomatis, gonorrhea, CT scan, to rule out a malignant etiology. Fine needle/incisional biopsy of the lacrimal gland, indicated only if imaging/blood tests are inconclusive investigations based on the suspected etiology. Treatment of the underlying disease. Definition: nasolacrimal duct, NLD, atresia/obstruction in an infant caused by a developmental anomaly and characterized by epiphora, excessive tearing, incidence, up to 6% of live births, common condition, clinical features. OE epiphora within 2 to 4 weeks of birth. Copyright palpation of the lacrimal sac may cause tears to leak from the lacrimal punctum. Diagnostics, clinical diagnosis. Copyright syringing or probing of the duct to determine the site of obstruction and remove the obstruction, if necessary. Copyright lacrimal syringing, reflux of saline irrigated into the lacrimal punctum indicates NLD obstruction. See lacrimal duct probing equals to determine the site of the obstruction and recanalize the duct. A diagnostic and therapeutic procedure indicated in infants with persistent epiphora despite lacrimal duct massage. See below. Equals the lacrimal punctum is dilated and a flexible metallic probe is inserted into the NLD. If the probe encounters an obstruction, this confirms the diagnosis. Back. V. Fine text. O. Outline. Degree lacrimal oct probing. Equals to determine the site of the obstruction and recanalize the duct. A diagnostic and therapeutic procedure equals indicated in infants with persistent epiphora despite lacrimal duct massage. See below. Equals the lacrimal punctum is dilated and a flexible metallic probe is inserted into the NLD. If the probe encounters an obstruction, this confirms the diagnosis. Equals light pressure on the probe breaks through any obstruction and recanalizes the NLD. Equals presence of ocular infection is a contraindication to probing. Scent treatment. Copyright lacrimal sac massage equals copyright dilation or stenting of the duct. Copyright dacryocysterinostomy, DCR if other measures fail. A surgical procedure in which a direct connection is created between the lacrimal sac and the nose to allow for unimpeded drainage of tears. Equals can be performed either through a skin incision or endoscopically through the nose. Scent complications of untreated dacryostenosis, acute/chronic dacryocystitis. Acquired dacryostenosis. Scent etiology. Copyright concretions in the NLD. O. granulomatous sarcoidosis, granulomatosis with polyangiitis, tuberculosis. Copyright punctal stenosis, due to chronic conjunctivitis, reaction to eye drops. Degree post-traumatic stenosis, nasal fracture/surgery. Scent clinical features, diagnostics, and complications are similar to those of congenital dacryostenosis. Scent treatment. Copyright treatment of the underlying disorder. Copyright lacrimal duct probing/intubation, in all patients. ODCR, in refractory cases. References, 2L7 Ilcid OLL 11112. Dacryocystitis. Acute dacryocystitis, chronic dacryocystitis. Definition ** acute or chronic inflammation of the lacrimal sac. 1. Etiolo, SY dacryocystitis can be caused by pneumococci, H. influenza, and Pseudomonas. Lacrimal sac inflammation. Erythema, edema, warm, and significant pain below the medial canthus of the eye. Persistent epiphora. Clinical ** pressure on the swelling causes pain and purulent discharge from the punctum. _IA ** glucopurulent discharge from the punctum. Fa features ** epiphora. No signs of acute inflammation. No fever. May be present. ESSS. Clinical 4. Pus culture. Blood quart yeast, in patients with systemic symptoms, fever, diagnostics * dacryocystography, DCG, clinical culture of the discharge. Copyright A contrast imaging of the lacrimal sac and NLD-MA copyright performed in patients with dacryostenosis secondary to trauma, altered anatomy, or suspected tumors, to locate the tumor. Symptomatic, warm compresses, NSAIDs. On-scent antibiotics, culture-specific systemic antibiotics, oral clindamycin, 4 or oral amoxicillin plus clavulanic acid, and LV vancomycin canamubuse, P, OAA. DCR, to prevent recurrence, treatment be used empirically. Culture-specific antibiotics are used once the report is ready. OE incision and drainage if lacrimal sac abscess occurs of congenital dacryostenosis above. DCR, treatment of the NLD obstruction after treating the infection. Congenital / acquired dacryostenosis stasis of tears secondary bacterial infection. Acute dacryocystitis is often caused by streptococci or staphylococci. Chronic. Investigations to confirm / locate NLD obstruction, NLD probing / sirening. See diagnostics of dacryostenosis above, DCG. Feedback. Manage. Children. Copyright The lacrimal gland should not be probed during acute infection, since this may cause bacteria to spread to other locations. References, 21L10LL13I14115. Back collapse. Find text. X diseases of the lacrimal apparatus. Acute dacryocystitis definition: acute or chronic inflammation of the lacrimal sac. Etiology: erythema, edema, warm, and significant pain below the medial canthus of the eye. Pressure on the swelling causes pain and purulent discharge from the punctum. Epiphora. Clinical features: fever may be present. Clinical eye pus culture. Blood culture in patients with systemic symptoms, fever, DI** dacryocy high, DCG. Copyright A contrast imaging of the lacrimal sac and NLD-I copyright performed in patients with dacryostenosis secondary to trauma, altered anatomy, or suspected tumors, to locate the tumor. Symptomatic, warm compresses. Compresses, NSAIDs. Treatment be used empirically. Culture-specific antibiotics are used once the report is ready. Incision and drainage if lacrimal sac abscess occurs. DCR, treatment of the NLD obstruction after treating the infection. Systemic antibiotics, oral clindamycin, 4 or oral amoxicillin plus clavulanic acid, and 4 vancomycin can. Chronic dacryocystitis. Congenital / acquired dacryostenosis stasis of tears secondary bacterial infection. Acute dacryocystitis is often caused by streptococci or staphylococci. Chronic dacryocystitis can be caused by pneumococci, H. influenza, and Pseudomonas, lacrimal sac inflammation. Persistent epiphyromucopurulent discharge from the punctum. A. No signs of acute inflammation, no fever. Clinical culture of the discharge. Investigations to confirm / locate NLD obstruction, NLD probing / sirening. See diagnostics of dacryostenosis above, DCG. Scent antibiotics, culture specific, scent DCR, to prevent recurrence, children. Copyright The lacrimal gland should not be probed during acute infection, since this may cause bacteria to spread to other locations. 13-14-15, references to IL-10. WA. Lacrimal gland tumors. Etiology. Copyright Benign tumors, pleomorphic adenoma or malignant tumors. Adenocystic carcinoma equals mucoepidermoid carcinoma. Copyright Inflammatory tumors, pseudotumor / inflammatory dacryodenitis. Idiopathic inflammation of the lacrimal gland. Scent. Clinical features. Age equals benign tumors manifest between 20 to 40 years of age equals malignant tumors manifest 40 years of age. Copyright Unilateral swelling of the lateral orbit. CAO unilateral proptoses, painless in benign tumors and painful in malignant tumors. Restricted eye movement and diplopia. See eye scent diagnostics. Copyright CT and/or MRI scan equals benign tumors, well encapsulated. No bony destruction equals malignant tumors equals poorly defined lesions with areas of calcification equals destruction of adjacent bones and perineural invasion equals pseudotumor, diffusely enlarged lacrimal gland and inflamed surrounding tissue. Copyright biopsy of the lacrimal gland plus treatment of benign tumor, complete removal of the lacrimal gland malignant tumor, equals complete removal of the gland in early disease, equals enucleation of the eye and radiotherapy in advanced disease. Pseudotumor, steroids and radiotherapy. Radiotherapy. References to IL-16 LL17B. Back collapse. Al. Find text outline. Overlay. Acute dacryoadenitis BV swelling and hyperemia of the left lateral upper eyelid can be seen, resulting in the characteristic S-shaped ptosis, green line. This is the typical appearance of acute dacryoadenitis. Source: Copyright IMPP. Overlay. Acute dacryoadenitis BV swelling and hyperemia of the left lateral upper eyelid can be seen, resulting in the characteristic S-shaped ptosis, green line. This is the typical appearance of acute dacryoadenitis. Source: Copyright IMPP. J. SS lacrimal gland of equals percent lacrimal ducts. Cornea and tear film valve of Hasner inferior turbinate. Congenital dacryostenosis, valve of Hasner. Illustration depicting the lacrimal apparatus in an infant with congenital dacryostenosis. The valve of Hasner is seen as a mucosal fold obstructing the distal third of the nasolacrimal duct. See enlarged image. This valve obstructs the drainage of tears and causes congenital dacryostenosis, the most common cause of epiphora in infants. Copyright Boss. Diseases of the lacrimal apparatus, 2 halves. Lacrimal sac massage, Krigler massage, VV. Illustration depicting the technique of lacrimal sac massage for congenital dacryostenosis. Gentle pressure is applied to the region below the medial canthus of the eye in a downward direction in order to increase the pressure within the nasolacrimal duct and cause the obstructing valve of Hasner to rupture. This process should be repeated 3 to 4 times per day. Lacrimal sac massage is the first line of treatment for congenital dacryostenosis. Copyright Boss. Diseases of the lacrimal apparatus, 1/1. Dacryocystitis. Right eye of a 54-year-old male patient. A solid and immobile mass can be seen in the right fossa lacrimalis. There is no discharge of pus or other secretions. These findings are typical of dacryocystitis, which can result from chronic inflammation of the lacrimal sac and/or chronic stenosis of the tear duct. Source: Figure 1, in clinical, radiological, microbiological, and histopathological aspects of acquired dacryocystoceles by Selamyekta Sendul, San Masoner, Haloglycine Kagate, Mehmet Demir, Berkudarim, Dilek Gubin, Indawi, licensed under CC by 3.0. X. Choanal-atresia. Choanal-atresia is a congenital condition characterized by a bony and/or membranous obstruction of the posterior nasal passage. This obstruction may occur either unilaterally or bilaterally. Unilateral choanal-atresia often presents late with chronic inflammation, example rhinorrhea, congestion, of the affected nasal passage. Bilateral choanal-atresia manifests as obstructed nasal breathing with intermittent cyanosis immediately after birth. Breathing improves when crying, as it allows the infant to breathe through his or her mouth. The diagnosis is confirmed with contrast rhinography or CT imaging. The definitive treatment is surgery, in which the obstructive membrane or bony portion is perforated. OAS. Definition: congenital condition characterized by a bony, 90% of cases, and/or membranous, 10%, obstruction of the posterior nasal passage. References: WAO. Shared note Vienage. Epidemiology. Copyright Sex, Hashtag app, 2:1. Sent unilateral choanal is twice as common as bilateral choanal. Sent frequently associated with other anomalies, Charge syndrome, coloboma, heart defects, atresia coanae, also known as choanal retardation of growth, genital abnormalities, and ear abnormalities. References to epidemiological data refers to the U.S., unless otherwise specified. Etiology. Choanal has a positive association with paraconceptional maternal exposure to thyroid medications, methimazole, carbamazole, cigarette smoking, scent, caffeine, 2-3 cups per day, elevated levels of vitamin B12, zinc, and vitamin B3, niacin. References to Nat 8 shared notes. Manage. Pathophysiology. That's been hypothesized that the condition is due to 3. Copyright persistence of the buccopharyngeal membrane during the embryonic period, copyright persistence of the oronasal membrane beyond the embryonic period, outgrowth of the palatine bone, atypical mesodermal adhesions, incomplete mesodermal resorption, copyright altered local growth factors, abnormal neural crest cell migration. Back collapse. Fine text outline. Clinical features. Sent bilateral choanal atresia. Early presentation. Infants are only able to breathe through the mouth, immediately postpartum. 1. Copyright cyanosis that worsens when feeding and improves when crying. Upper airway obstruction, example noisy breathing, dyspnea. Copyright food intake impossible. Complete airway obstruction is a life-threatening condition immediately following birth because of the worsening dyspnea associated with feeding. Sent unilateral choanal atresia. A copyright typically presents later in life. Copyright chronic rhinitis in the affected nasal passage with purulent nasal discharge over several weeks. References, 2IL4. OSID shared note. Diagnostics. The inability to pass the catheter through the nasal cavity is an indication of choanal atresia. Unilateral or bilateral narrowing of the posterior nasal passage. Copyright airway width. Your note. AE shared note. Treatment. Sent bilateral choanal atresia. Copyright urgent insertion of an oropharyngeal airway, or even intubason, as a temporary airway until surgery. Copyright surgical perforation, example endoscopic resection of the posterior nasal septum. Copyright local use of chemotherapeutic agents, example mitomycin C, may reduce the need for stenting, dilatations, and second surgery. Unilateral choanal atresia. Copyright observation and subsequent surgery when the infant is 1 to 2 years old. In suspected cases of bilateral choanal atresia, do not feed. A feeding tube is required due to the increased risk of aspiration. References for LL7. 001. Mana. Prognosis. With appropriate management, full recovery occurs in most cases. Sent periodic dilatations may be needed, as stenosis can recur postoperatively. WAOO. Sources last updated March 24, 2022. Choanal atresia, 1/1. Coloboma of the iris VB. Slit lamp photography of the right eye. The pupil shows a characteristic keyhole shape due to an inferior opening in the iris, coloboma. Colobomas may be congenital, due to incomplete closure of the embryonic fissure, or acquired, example from trauma or surgery. Depending on the location and extent of a coloboma, it may be asymptomatic or lead to visual impairment, example increased light sensitivity, diplopia. Source, Coloboma of the Iris by J. March, Wikimedia Commons, licensed under CC by SA 3.0. A choanal atresia, 1/1. Choanal atresia. Retropalatal endoscopic view. Unilateral choanal atresia can be seen. Source, Unilateral CA page 0001 by Jaspinder Kaur, Wikidoc, licensed under CC by SA 3.0. Modifications, text removed. X cleft lip and cleft palate. Cleft lip, CL, and cleft palate, CP, are the most common congenital orofacial deformities. A combination of genetic predisposition and in utero exposure to teratogens, nicotine, alcohol, anti-epileptic drugs, can arrest the fusion of the facial processes required for normal facial development. Failure of fusion of the maxillary prominence with the medial nasal prominence causes cleft lip, CL. Failure of fusion of the palatine prominences causes cleft palate, CP. Cleft lip and/or palate may be unilateral or bilateral and complete or incomplete. In addition to facial deformity, infants with CL and CP have feeding, hearing, speech difficulties, and defects in the dentition. Infants with cleft lips and/or palate require special feeding techniques, feeding in upright position, special feeding bottles, since they cannot effectively create negative sucking pressure. Treatment should be initiated as early as possible and may involve an interdisciplinary team of plastic surgeons, oral maxillofacial surgeons, otolaryngologists, pediatricians, and speech therapists. Nasoalveolar molding and lip taping are non-surgical techniques used to decrease the size of the lip/palatal defects and should be initiated early, at 2 weeks of age. Repair of the cleft lip is done at 3 months of age and of the cleft palate at 6 months of age with the aim of optimizing feeding and speech development without interrupting normal maxillofacial growth. WI. CE. Epidemiology. E-incidence copyright cleft lip with/without cleft palate is common. 1 case in 1,000 live births. CG copyright isolated cleft palate is less common. 1 case in 2,000 live births sent unilateral CL/CP. CP is more common than bilateral CL/CP. 1 cent. Majority of cases are non-syndromic. References, 2 ILSIL4. Epidemiological data refers to the U.S., unless otherwise specified. OCE. Etiology. The development of CL/CP is dependent on the interaction of environmental factors and genetic predisposition. 5 cent. Genetic predisposition. Family history, multifactorial inheritance pattern. Mendelian inheritance is rare. 1 copyright part of chromosomal abnormalities, Pierre-Robin sequence, Patau syndrome, trisomy 13, Edwards syndrome, trisomy 18, copyright biped uvula, Louis-Dietz syndrome. Cent. Environmental factors, exposure to teratogenic substances in utero. Copyright nicotine and/or alcohol drugs, anti-epileptics, example phenytoin, sodium valproate, carbamazepine, phenobarbital, folate antagonists, example methotrexate, trimethoprim, and excessive vitamin A intake during pregnancy. Pathophysiology. Cleft lip and palate involves a disrupted fusion of the 5 embryonic facial prominences, the midline frontinasal prominence, the bilateral maxillary prominences, and the bilateral mandibular prominences, and 1 results in congenital orofacial deformities. 6 cent. Cleft lip. Partial or total failure of primary palate formation during the 6 to 7 week of development. Copyright failed fusion of the maxillary prominences and medial nasal prominences at the midline. Cent. Cleft palate. Failed formation of the secondary palate during the 8 to 12 week of development. Copyright failed fusion of either the lateral palatine processes, palatine shelves, or of the palatine shelves with the nasal septum and/or primary palate. B. Partial or total failure of primary palate formation leads to cleft lip. Failed formation of the secondary palate leads to cleft palate. /B. 2A2. Back collapse. Fine text outline. Clinical features. Facial features 227. CL/CP may be unilateral or bilateral, complete, or incomplete. Cleft lip. Cent. Microform cleft lip, slight, incomplete cleft characterized by a notch on the vermilion border of the upper lip, Unilateral, 1 cent incomplete cleft lip, cleft on the upper lip that does not extend into the nostril, unilateral/bilateral, cent complete cleft lip. Copyright cleft on the upper lip that extends into the nostrils, unilateral/bilateral. Copyright cleft palate is more commonly associated with complete than incomplete cleft lip. Cent unilateral cleft lip, the orbicularis oris inserts into the nasal ala on the cleft side and the columella on the unaffected side. Cent bilateral cleft lip, the orbicularis oris inserts into the nasal ali bilaterally. A DH. Cleft palate. Cent incomplete cleft palate, clefting only of the secondary palate, anterior or posterior to the incisive foramen. Cent complete cleft palate. Copyright cleavage of the entire hard palate, soft palate, and the uvula, anterior and posterior to the incisive foramen. Copyright often associated with cleft lip. Cent bifid uvula. A split or forked uvula, typically containing less muscle tissue than a normal uvula. Least severe form of cleft palate. Submucosal cleft palate, occult cleft palate. Muscular and / or bony palatal defect that is masked by intact palatine mucosa. Other features. 8 degree L. Cent feeding difficulties, depends on the type and severity of the cleft. Bifid uvula, may cause nasal regurgitation. Copyright cleft lip equals sucking difficulties may occur. Equals minimal feeding difficulties. Copyright cleft palate equals sucking difficulties equals nasal regurgitation of milk equals choking / coughing during feeds equals excessive aerophagia. Speech difficulties, hypernasal, unintelligible speech due to velopharyngeal insufficiency, a structural disorder that causes the inability to form a seal between the nasopharynx and oropharynx and that is characterized by hypernasal speech, which may impair intelligibility. Cent dentition defects, in CP due to clefts creating gaps in the maxilla. Hearing loss, due to recurrent / persistent otitis media with effusion, OM. IEEE. Diagnostics. Cent prenatal OCL/CP may be diagnosed on prenatal ultrasound, after 12 weeks of gestation. 1 copyright if detected prenatally. Amniocentesis for karyotyping is offered, to detect other chromosomal abnormalities. Cent postnatal, clinical diagnosis, children with a submucosal cleft palate may present in later life with abnormal speech and / or OM references. 14. Back collapse. Fine text outline. X cleft lip and cleft palate. Other features. 8 degree L. Cent feeding difficulties, depends on the type and severity of the cleft. Copyright bifid uvula, may cause nasal regurgitation. 1 copyright cleft lip equals sucking difficulties may occur. 1 equals minimal feeding difficulties. Copyright cleft palate equals sucking difficulties equals nasal regurgitation of milk equals choking / coughing during feeds equals excessive aerophagia. Speech difficulties, hypernasal, unintelligible speech due to velopharyngeal insufficiency, a structural disorder that causes the inability to form a seal between the nasopharynx and oropharynx and that is characterized by hypernasal speech, which may impair intelligibility. Cent dentition defects, in CP due to clefts creating gaps in the maxilla. Cent hearing loss, due to recurrent / persistent otitis media with effusion, OM. IEEE. Diagnostics. Cent prenatal. Copyright CL/CP may be diagnosed on prenatal ultrasound, after 12 weeks of gestation. Copyright if detected prenatally. Amniocentesis for karyotyping is offered, to detect other chromosomal abnormalities. Cent postnatal, clinical diagnosis, children with a submucosal cleft palate may present in later life with abnormal speech and / or OM references. 4. OE. Treatment. Approach 11112. Interdisciplinary management is required. Oral maxillofacial surgeons, plastic surgeons, otolaryngologists, pediatricians, and speech therapists. Cent all cleft lips and palates should be surgically repaired. Sent speech assessment at 12 to 14 months and therapy of velopharyngeal insufficiency. Conservative measures before surgery 113. Sent proper feeding techniques, feeding in upright position to prevent nasal regurgitation, use of specialized feeding bottles, frequent burping FH sent nasoalveolar molding, use of a custom-made orthodontic prosthesis to bridge and reduce the palatal gap and passively mold the maxillary, palatal, and nasal structures into a normal shape, sent nasal stent, to lift the drooping nostril and shape the nose sent lip taping, use of adhesive tape to reduce the defect, makes definitive surgery. Easier sent lip adhesion, suturing the edges of the cleft lip, in conjunction with NOM can be done in infants with complete CL/CP who are not responding well to lip taping. FA surgical repair, 141. Sent cleft lip repair, chyloplasty, copyright goals, achieving normal lip contour and nose, improve oral competence. Copyright timing, at age 3 months. Surgery is usually staged with cleft lip being the first surgery and cleft palate done at a later time due to risk of surgery to infant. Copyright tympanostomy tubes are placed at the same sitting, in children with OM causing hearing loss/recurrent infections. Cleft palate repair, palatoplasty. 5. Copyright goals, closure of the defect, optimal speech development, and normal maxillofacial growth. Copyright timing, at age 6 to 9 months. One further surgery is often required as the child grows older. Back collapse. Fine text outline. Euro cleft lip and cleft palate, 1/2. Hard palate nasopalatine nerve. Palatine glands. Soft palate. Greater palatine nerve tensor veli palatinae, R palatine nerve, within the palatine aponeurosis. Lesser palatine nerves. Levator veli palatini, within palatine aponeurosis. Palatine aponeurosis. Palatopharyngeus. Palatoglossus uvula. Neuromusculature of the hard and soft palate. VV. Copyright Boss. Nasal placode. Nasal pit philtrum. Optic vesicle. Stomatidium. 5 week, 6 week, 7 week, 10 week. Y1 primitive BS palate XA. Horizontal palatine processes. Secondary palate. Nasal septum. Incisive foramen. Frontonasal process. Medial nasal process. Lateral nasal process. Maxillary process. Mandibular process. Development of the face and palate. VV. Top, in the 5 week, the stomatidium is surrounded by the unpaired frontal process, pink, the paired upper jaw, yellow, and the paired lower jaw, blue. 2 olfactory placodes form at the frontal process and develop into 2 olfactory pits, each bounded by the medial, green, and lateral nasal bulge, purple, in the 6 degrees week. The medial nasal cavities merge to form the bridge of the nose, the philtrum, the nasal septum, and the primitive palate. The lateral nasal cavities develop later to form the sides of the nose, 7 and 10 week. Bottom, the secondary palate develops from the 2 palatal plates of the maxillary bulge. These eventually merge medially with each other and ventrally with the primitive palate. Copyright Boss. Euro cleft lip and cleft palate, 1/2. Incomplete, complete, partial, unilateral, bilateral. Incomplete versus complete cleft lip. VV. Copyright Boss. Fetal palate. Incomplete, complete. Unilateral / primitive palate. LZAELMA / submucosal. Secondary palate. Bilateral. Separated palatal muscles. Cleft palate comparison. Copyright Boss. X. Congenital neck masses. Congenital neck masses are developmental anomalies that can manifest either at birth or later in life, usually following a respiratory infection. The most common congenital neck masses are thyroglossal duct cysts, bronchial cleft cysts, and cystic hygromas. These malformations manifest as painless neck masses that, as they grow, can cause dysphagia, respiratory distress, and neck pain by compressing surrounding structures. The location of the mass depends on the embryological structure the cyst arises from. Diagnosis is based on clinical findings and imaging results, ultrasound, CT, MRI, which also help in surgical planning. Treatment consists of complete surgical resection to prevent recurrence and complications such as infection or abscess formation. WA. OE. Thyroglossal duct cyst. Scent definition: a remnant of the thyroglossal duct, which forms during the embryonic development of the thyroid gland and normally regresses before birth. Epidemiology. Copyright incidence: 7% of the population. Second most common neck abnormality after lymphadenopathy plus pathophysiology. Copyright: the thyroid gland originates from the foramen cecum at the base of the tongue and descends caudally into the neck, forming the thyroglossal duct. If the thyroglossal duct fails to obliterate, midline neck cysts or ectopic thyroid tissue can develop anywhere along its path. Scent clinical features: the cyst is present from birth and is usually detected during early childhood. Copyright: painless, firm, midline neck mass that elevates with swallowing and tongue protrusion. Usually located near the hyoid bone. May cause dysphagia or neck/throat pain if the cyst enlarges. Scent diagnostics: neck and thyroid examination. Ultrasound of the neck to evaluate the cyst and confirm the location of the thyroid. Copyright = patients with thyroglossal duct cysts can have an ectopic thyroid gland. In the absence of ectopy, it is important to assess the anatomical relation of the cyst to the thyroid for preoperative planning. Contrast enhanced CT of the neck, preferred imaging modality. Thyroglossal duct cysts are demonstrated as well-defined lesions with homogeneous fluid attenuation and surrounding rim enhancement, typically close to the hyoid bone. Allows for assessment of anatomical location, relation, and extent of the cyst as well as its relation to normal orthotopic thyroid tissue. Copyright: TSH levels. If an infection is suspected, fine needle aspiration should be performed for gram stain and culture, including AFB and mycobacterial culture. Plus treatment. Copyright: elective surgical excision, cyst Runc procedure, to prevent infection, includes removal of the cyst, a portion of the hyoid bone, and excision of tissue comprising the path of descent from the foramen cecum. Copyright: treatment of any active infection with antibiotics before surgery. Scent complications. 13. Copyright: infection of the cyst with possible abscess formation. Copyright: sinus tract formation with persistent drainage. Copyright: ectopic thyroid tissue. Malignancy arising from ectopic thyroid tissue. And thyroglossal duct cysts manifest as a painless, firm, midline neck mass that moves with swallowing and tongue movement. WA. CES. Bronchial cleft cyst. Scent definition: remnants of the embryological second bronchial cleft or cervical sinus, which normally regresses before birth. Scent epidemiology: accounts for 20% of pediatric neck masses. Copyright: 95% of all bronchial cleft malformations are anomalies of the second bronchial cleft. Scent pathophysiology: formed due to incomplete obliteration of bronchial clefts and pouches. Scent clinical features: usually diagnosed in late childhood or in adulthood after a previously undiagnosed cyst becomes infected. 3. Back collapse. Fine text outline. Clinical features: usually diagnosed in late childhood or in adulthood after a previously undiagnosed cyst becomes infected. BS. Copyright: history of upper respiratory infection. Copyright: painless, firm mass located lateral to the midline, usually anterior to the sternocleidomastoid muscle. Does not move with swallowing. Copyright: there may be a small draining opening if a fistula is present. Diagnostics: neck examination. Copyright: ultrasound 1, cohort or MRI to further assess anatomical structures for surgical planning. Treatment: complete surgical excision of both the cyst and any associated tracts. 2 complications: infection of the cyst, tract, or sinus, with possible abscess formation. And bronchial cleft cysts manifest as a painless, firm neck mass lateral to the midline. Cystic hygroma. Definition: a congenital lymphatic cyst, macrocystic lymphangioma, in the posterior triangle of the neck caused by malformation and obstruction of the fetal lymphatic system. 04. Epidemiology copyright 1:6,000 live births 1 copyright strongly associated with fetal aneuploidy, example Turner syndrome, trisomy 21, and congenital malformations, example congenital heart defects, clinical features copyright present at birth as a soft, compressible, painless, posterior triangle neck mass degree can cause dysphagia or airway compromise. O positive transillumination test, diagnostics copyright prenatal ultrasound, 7, fluid-filled neck mass with or without septations, 5O ultrasound to identify mass in infancy. OCT or MRI may be used to further assess anatomical structures for surgical planning treatment. Small masses may regress spontaneously, but surgical excision is usually indicated to prevent infection or airway compromise, as well as for cosmesis. Re2RLL. Prognosis, recurrence is common following surgical excision of extensive hygromas. GS. Differential diagnoses. Unilateral cervical lymphadenopathy, fistula, hemangiomas, cervical teratoma, 1 dermoid cysts, midline cervical cleft cyst. The differential diagnoses listed here are not exhaustive. OD no. OE. Sources. Back collapse, find text outline. Path of thyroid gland descent. Foramen cecum dietential thyroid /IND develop, RT / roars, potential locations of NAPM thyroglossal duct cysts or / at lingual thyroid _ I ectopic thyroid tissue, RL // if persistent thyroglossal duct suprahyoid thyroglossal cyst. 4N hyoid bone VN // thyrohyoid membrane YB thyroglossal duct cyst or FQF on ectopic thyroid. N / F thyroid cartilage FALFWWWIFYEY _+ _ pyramidal lobe / thyroid eye /J / trachea Y mediastinal thyroid eye / AB thyroglossal duct. Copyright Boss. Overlay. Thyroglossal duct cyst NACT head, without contrast, A. Axial plane, B. Sagittal plane, a hypodense mass, green overlay, with a fluid density value, mean 20 Hu, is present anterior to the hyoid bone, arrows. Source, Figure 3, in, ectopic thyroid tissue in the head and neck, a case series by Adelchi, CETAL, Biomed Central, BMC Research Notes, licensed under CC by 4.0. Modifications, removed the arrows and arrowheads from the original. Overlay. Thyroglossal duct cyst VVCT head, without contrast, A. Axial plane, B. Sagittal plane, a hypodense mass, green overlay, with a fluid density value, mean 20 Hu, is present anterior to the hyoid bone, arrows. Source, Figure 3, in, ectopic thyroid tissue in the head and neck, a case series by Adelchi, CETAL, Biomed Central, BMC Research Notes, licensed under CC by 4.0. Modifications, removed the arrows and arrowheads from the original. Urocongenital neck masses, 2/4. Overlay. Thyroglossal duct cyst neck ultrasound, transverse section, a circular, sharply demarcated, hypochoy lesion, green overlay, is visible dorsal to the thyroid gland. Source, Thyroglossal duct cyst 150117131348265 by Nevitt Dillman, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital neck masses, 2/4. Overlay. Thyroglossal duct cyst neck ultrasound, transverse section, a circular, sharply demarcated, hypochoy lesion, green overlay, is visible dorsal to the thyroid gland. Source: Thyroglossal duct cyst 150117131348265 by Nevitt Dillman, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital neck masses, 1/4. Thyroglossal duct cyst. There is a mass located in the patient's midline anterior cervical area near the thyroid cartilage. Source: Thyroglossal duct cyst by Klaus D. Peter, Wikimedia Commons, licensed under CC by 3.0. Embryo, 6th week, lateral neck fistula, lateral neck cyst. Ion. T. Senate Sinus, New York. AD_bronchial cleft, AD bronchial arches. 1 hyoid bone, B12 thyroid cartilage, 7D3 sternocleidomastoid muscle, 4 thyroid gland, 5 trachea. Bronchial cleft cysts and fistulas. The cervical sinus is formed during embryogenesis by the proliferation of the second bronchial arch, which covers the 244th bronchial clefts. The cervical sinus typically degenerates. However, bronchial cleft cysts and fistulas may arise if these epithelial ducts persist. Copyright Emboss. Urocongenital neck masses, 1/3. Cystic hygroma VV. A mass is visible anterior to the sternocleidomastoid muscle in the superior carotid triangle. Source: Late Roll Halzeist 1 by Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital neck masses, 2/3. Overlay. Cystic hygroma VV. Right lateral region of the neck, 1, a massive, lobulated swelling, green overlay, is visible in the posterior triangle. This is the most common location of a cystic hygroma. 2. Patient after surgical excision of the hygroma, posterior triangle, blue overlay, copyright Emboss. Urocongenital neck masses, 2/3. Overlay. Cystic hygroma VV. Right lateral region of the neck, 1, a massive, lobulated swelling, green overlay, is visible in the posterior triangle. This is the most common location of a cystic hygroma. 2. Patient after surgical excision of the hygroma, posterior triangle, blue overlay, copyright Emboss. Surgical excision of cystic hygroma VV. A cystic hygroma is visible in the middle of the incision. The internal jugular vein can be seen right above the cystic hygroma. If the cystic duct reaches up to the ipsilateral tonsil, the tonsil is also excised in surgery. Source: Late Roll Halzeist 2 by Wells Chick, Wikimedia Commons, licensed under CC by SA 3.0. Cyanotic congenital heart defects. Cyanotic heart defects, CHDs, are congenital cardiac malformations that commonly affect the atrial walls, example the right atrium, RA, or left atrium, LA, ventricular walls, example the left ventricle, LV, or right ventricle, RV, heart valves, or large blood vessels. Common causes include genetic defects, example DiGeorge syndrome, maternal conditions, example diabetes, and spontaneous genetic mutations. Pathophysiologically, cyanotic heart defects are characterized by a right-to-left cardiac shunt, which leads to deoxygenated blood entering the systemic circulation. The resulting hypoxemia manifests clinically as cyanosis, which may occur as acute, life-threatening episodes. Other symptoms include failure to thrive, characteristic heart murmurs, and symptoms of heart failure. Diagnosis is confirmed through visualization of the defect on echocardiography. Further diagnostic findings include low oxygen saturation and characteristic X-ray findings. Heart defects requiring treatment are repaired. via catheter procedures or surgery. Supportive medical therapy is required in patients with heart failure, example diuretics, inotropic agents, or if surgery cannot be performed, example prostaglandin. If untreated, most cyanotic heart defects are fatal within the first year of life. OE. Overview of cyanotic congenital heart death. Commonly associated conditions and risk factors of cyanotic congenital heart defects. Most common associated conditions and risk factors: DiGeorge syndrome, Down syndrome. Maternal risk factors: tetralogy of Fallot, degree alcohol consumption, OE phenylketonuria, copyright diabetes. Transposition of great vessels, maternal risk factors, diabetes. Tricuspid valve atresia, Down syndrome. Epstein anomaly. Prenatal lithium exposure. Total anomalous pulmonary venous return heterotaxy syndromes. Persistent truncus arteriosus, DiGeorge syndrome. Trisomy 13, trisomy 18, Turner syndrome, Jacobson syndrome, high-elastic left heart, SYND. General pathophysiological processes. SEND CHDs result from the disruption of the normal cardiac morphogenesis sequence. CHDs may lead to the formation of connections between the right and left heart, i.e., shunts. In cyanotic CHDs, right to left cardiac shunting, blood flow from the right to the left heart, deoxygenated blood entering the systemic circulation, cyanosis. 7. General clinical features. Plus blue babies, pale gray or blue skin color caused by cyanosis, feeding problems and failure to thrive, exertional dyspnea, tachypnea, and fatigue plus hypoxemia. 2. IL-2 symptoms of heart failure, c. acyanotic congenital heart defects, scent nail clubbing may occur later in life. Copyright in approximately 50% of infants with CHDs, a routine newborn physical examination reveals no abnormalities. A normal physical examination does not rule out CUP. IL-4. PZ. General treatment considerations. 5. Scent ductal dependent CHDs, a group of CHDs that require the patent ductus arteriosus, PDA, which supplies either pulmonary or systemic circulation, to sustain life until surgery can be performed. 6. EPDA supplies systemic circulation in the following. Back collapse, fine text outline. General treatment considerations. Scent ductal dependent CHDs, a group of CHDs that require the patent ductus arteriosus, PDA, which supplies either pulmonary or systemic circulation, to sustain life until surgery can be performed. 6. OPDA supplies systemic circulation in the following, equals transposition of the great arteries, hypoplastic left heart syndrome equals coarctation of the aorta equals critical aortic valve stenosis. OPDA supplies pulmonary circulation in the following, equals tricuspid atresia equals critical pulmonary valve stenosis. Tetralogy of Fallot, copyright treatment, administration of prostaglandin E1 infusion equals example, 4-alprostadile infusion. Mechanism of action, prevents the ductus arteriosus from closing, creating an intentional shunt to allow mixing of deoxygenated with oxygenated blood plus in patients with heart failure. 7. O. Decrease fluid volume and lower pulmonary vascular resistance with diuretics or ACE inhibitors. 1. O. Improve the contractility of the heart with inotropic agents, example digoxin. Plus antibiotic prophylaxis for bacterial endocarditis during dental procedures. 1L11 copyright for all patients with unrepaired cyanotic CHDs. Copyright during the first 6 months after surgery. Scent surgical repair is required in most cases. At the 5 Ts of cyanotic CHDs, tetralogy of Fallot, transposition of the great vessels, tricuspid valve anomalies, total anomalous pulmonary venous return, and persistent truncus arteriosus. WA. CE. Tetralogy of Fallot. Overview. 12. Scent definition. Tetralogy of Fallot, TOF, is the simultaneous occurrence of the following four defects: copyright right ventricular outflow tract obstruction, Ravato, due to pulmonary infundibular stenosis, copyright right ventricular hypertrophy, RVH, O ventricular septal defect, VSD, copyright overriding aorta, the aorta is displaced above the VSD, * other cardiac defects associated with TOF, 1. 3O atrial septal defect, ASD, OPDA copyright anomalous coronary arteries 1, 14. And Ravato, right ventricular hypertrophy, ventricular septal defect, overriding aorta are the characteristics of tetralogy of Fall-OT. Epidemiology. Prevalence, 45/10,000 live births in the U.S. 15 * the most common cyanotic CHD 16 etiology. Plus typically sporadic, 17 associated with the following genetic disorders: copyright DiGeorge syndrome, 8LL19EO Down syndrome, 2021 maternal exposures during pregnancy, copyright alcohol consumption, O phenylketonuria 221I23, copyright diabetes 24IL25. Pathophysiology. Scent during fetal development, anterior and superior deviation of the infundibular septum, misaligned VSD with overriding aortic root and subsequent Ravato. Physiologic blood flow is determined by the severity of Ravato. A large VSD equal pressures in the right and left ventricles, blood flow along the path of least resistance degree, severe Ravato flow from RV to LV, desaturated blood entering the circulation via the aorta. Back collapse, fine text outline. Clinical findings. Infants with mild TOF may be asymptomatic on initial examination, and mild to severe cyanosis, which depends on the severity of the Ravato. Copyright mild obstruction, more pronounced left to right shunt via VSD, little or mild cyanosis 1 degree, severe obstruction, more pronounced right to left shunt via VSD, severe cyanosis. Scent TET spells, intermittent hypercyanotic, hypoxic episodes with a peak incidence at 2 to 4 months after birth, 26-27. Copyright associated with psychological and physical stress, example crying, feeding, defecation, copyright caused by either an increase in pulmonary vascular resistance, PVR, or a decrease in systemic vascular resistance, SVR, intermittent worsening of Ravato and F right to left shunting, 281L29, OE spells occur suddenly and are potentially lethal. Plus untreated children tend to squatting TSVR, right to left shunt T, blood flow to pulmonary circulation, hypoxemia, relief of symptoms. Scent cardiac examination findings. Copyright harsh systolic ejection, murmur at the left upper sternal border. Copyright single S2, copyright possible RV heave and systolic thrill. Scent CHF symptoms, see overview in heart failure. Registered in patients with TOF. The auscultated murmur is determined by the amount of blood flow across the Ravato. Therefore, during TET spells, the murmur may disappear. Scent. Diagnostics. Scent prenatal diagnosis. Most cases are now diagnosed before birth due to improvements in fetal echocardiography. 30 Scent imaging, copyright echocardiography, confirmatory test, equals detection of the main features of TOF equals quantification of right ventricular outflow tract pressure gradient equals supplementary cardiac catheterization may be performed. O chest X-ray equals boot-shaped heart, due to upturned cardiac apex and RVH, equals normal or decreased pulmonary vascular markings equals concave pulmonary artery segment ECG. Copyright right axis deviation O prominent anterior R waves, V1 V2, copyright prominent posterior S waves O right atrial enlargement and RVH, P pulmonal, pulse oximetry, SPO. Scent hyperoxia test, helps to distinguish cardiac from pulmonary causes of cyanosis. Treatment 5I31. Severe Ravato, PGE1 infusion until surgery, 8, acute hypoxia, TET spells, 732. Copyright initial interventions equals administer oxygen. equals knee to chest position, squatting equals IM morphine E. Subsequent interventions, consider if no improvement. 4. Sodium bicarbonate to correct metabolic acidosis I equals 4. Fluid resuscitation equals vasopressors, example phenylephrine, equals V beta blockers, example propranolol, scent heart failure copyright inotropic agents, example digoxin and loop diuretics, example furosemide, copyright ACE inhibitors are not recommended in patients with TOF because they may decrease SVR and promote TET spells. Scent surgical repair, performed within the first year of life. 33-34 OVSD repair, patch closure of the ventricular septal defect ensuring correct aortal positioning above the left ventricle. Copyright enlargement of the ruvato, resection of the obstructive infundibular musculature. Back collapse. Fine text outline. Plus surgical repair, performed within the first year of life. 83 LL34 IOVSD repair, patch closure of the ventricular septal defect ensuring correct aortal positioning above the left ventricle. O. Enlargement of the ruvato, resection of the obstructive infundibular musculature. Copyright if early surgical management is not possible. Palliative shunts equals Blaylock Thomas Taussig shunt, a palliative surgical procedure for TOF that connects the subclavian artery to the pulmonary artery with an interposed graft equals central shunt equals others, example Potts shunt, Cooley shunt, Waterston shunt, Sano shunt, scent follow-up care, to prevent long-term complications, such as heart failure, arrhythmias, example ventricular tachycardia and neurodevelopmental impairment. Prognosis. Without surgery, 50% of patients do not live past the first 3 years of life. 37% with corrective surgery, over 90% of patients live to 25 years of age. 38. VA. CE. Transposition of the great vessels, TGV. Overview. Plus definition, anatomical reversal of the aorta and the pulmonary artery. 1 * Other cardiac defects associated with TGV _ Copyright left ventricular outlet obstruction 1410 abnormal valves and/or coronary arteries. Epidemiology. * Prevalence 2-4/10,000 live births in the US, 15 IL-16 * accounts for 20% of all cyanotic CHD cases. 1-4. Etiology. Scent often multifactorial or unknown intrauterine risk factors, infants born to mothers with diabetes. 7 Blah, scent genetic syndromes, seen in 1% of patients with DiGeorge syndrome. 41 Pathophysiology. 42. Scent failed spiraling of the aorticopulmonary septum. RV emptying into the aorta and LV into the pulmonary artery. Complete isolation of the pulmonary and systemic circuits. Oxygenated blood entering the systemic circulation. Fatal, unless mixing occurs via an intracardiac shunt, example PFO, VSD, ASD, or via an extracardiac connection, example PDA. GG. Clinical findings. Plus postnatal cyanosis, not affected by exertion or supplemental oxygen, * tachypnea. 1 Scent cardiac examination findings. Copyright single, loud S2. Copyright there is often no murmur. Copyright diminished femoral pulses. Scent if concurrent VSD is present, systolic murmur at the left sternal border. Diagnostics. 5. Plus prenatal diagnosis, TGV is difficult to diagnose with fetal ultrasound. E-imaging. O echocardiography, confirmatory test, equals pulmonary artery arising from the left ventricle equals aorta arising from the right ventricle. O chest X-ray equals egg on a string. Appearance of the heart equals the enlarged, globular heart resembles an egg lying on its side. Equals the string represents the superior mediastinum that appears narrow due to stress-induced thymic atrophy. Equals T pulmonary vascular markings. O MRI, rarely done, showing the aorta arising from the right ventricle and the pulmonary trunk originating from the left ventricle. A. Back collapse. Fine text outline. EEUG. Olin normal scent pulse oximetry, SPO. Treatment for 41. Sent initial postnatal management, initiate mixing between the two parallel circulations to ensure adequate systemic oxygenation. Degree infusion of PGE1 to prevent closure of the PDA45 copyright balloon atrial septostomy, 461L47. Objective, to enhance atrial mixing if PGE1 administration is insufficient, and to alleviate hypoxemia. 48 procedure, right heart catheterization with the creation or enlargement of an existing ASD stent surgical repair, recommended within the first 2 weeks of life, 14950. Degree arterial switch procedure, reversal of the aorta and pulmonary artery with insertion into the anatomically correct ventricle as well as correction of coronary artery supply, 1LS2L. Degree Rast-Eli procedure S3-S4 indication, TGV with concurrent large VSD and levato repair procedure, creation of a conduit from the levato through the VSD to the aorta, and creation of a conduit from the RV to the pulmonary artery tie. Prognosis. Stent without treatment, 90% of patients with TGA die within the first year of life. 58% long-term survival beyond 15 to 20 years of age is 90%. 51. OOCSI. Tricuspid valve atresia. Overview. Stent definition: O absent or rudimentary tricuspid valve resulting in no blood flow between the RA and the RV. Patient survival is only possible if there are interatrial and interventricular communications. See other cardiac defects below. 56% other cardiac defects associated with tricuspid valve atresia: OASD, OVSD, ORV, hypoplasia. Copyright other defects, example pulmonary outflow obstruction, aortic stenosis, aortic coarctation. Epidemiology. Plus prevalence, 0.2-1.2/10,000 live births in the US4L stent. Third most common cyanotic CHD pathophysiology. Stent tricuspid atresia is accompanied by RV hypoplasia and RA dilation due to volume overload, univentricular heart. Stent circulation depends on the presence of interatrial and interventricular communications. Blood in the RA flows through the ASD into the LA. Venous blood mixes with arterial blood in the left heart. Cyanosis. Copyright blood can only reach the RV and pulmonary system via OVSD. Clinical features. Stent central cyanosis occurs within days after birth. Tachypnea. Stent cardiac examination findings. Degree holosystolic murmur at the lower left sternal border, 1. Back collapse. Fine text outline. Stent central cyanosis occurs within days after birth. Tachypnea. Stent cardiac examination findings. O holosystolic murmur at the lower left sternal border. Copyright single S2O jugular venous distension with a prominent A wave. O diminished peripheral pulses. Diagnostics. Stent prenatal diagnosis, fetal echocardiography at 18 to 22 weeks gestation, S7. Stent imaging. Copyright echocardiography, confirmatory test, equals absent tricuspid valve ASD equals RV hypoplasia. O chest X-ray equals mild cardiomegaly equals abnormal pulmonary markings, ECC cell. O LVH with left axis deviation. Copyright tall P waves. O minimal R waves in precordial lead. Stent pulse oximetry, SPO, treatment. Stent initial postnatal management, cardiopulmonary stabilization until surgical palliation. OPGE1 infusion. Copyright cardiorespiratory support, example inotropes, mechanical ventilation, supplemental oxygen. Stent surgical repair, 3-stage surgical palliation to isolate both pulmonary and systemic circulations. See surgical repair in hypoplastic left heart syndrome. Stent optional temporary measures. Copyright in cases with concurrent pulmonary valve atresia or severe stenosis, systemic to pulmonary shunt. Blalock-Taussig shunt, to improve perfusion. O risk of pulmonary hypertension, pulmonary artery banding to control pulmonary hyperperfusion. Prognosis. Stent with surgery, 90% of patients live to the age of 1 year and the 10-year survival rate is 80%. 56. WA. CE. Epstein anomaly. Overview. Scent definition: malformed tricuspid valve leaflets that are displaced into the right ventricle with subsequent tricuspid valve regurgitation and right heart enlargement, known as RV atrialization. Scent. Other cardiac defects associated with Epstein anomaly. Copyright interatrial communication, example PFO, ASD seen in 90% of patients. 59 O conduction disorders, example Wolff-Parkinson-White syndrome, supraventricular tachycardia. 60. Epidemiology. Plus prevalence, 0.5-1/10,000 live births in the US. 61 * accounts for. Etiology. Multifactorial, most cases are sporadic. 621 Scent associated with prenatal lithium exposure. 63-64 Isolated genetic defects, example MYH7 which encodes B-myosin heavy chain. Pathophysiology. 5 degrees. Scent. Incomplete delamination, i.e., separation of valve tissue from the myocardium, during valve development can lead to one or more of the following: O. Incomplete closure of the right atrioventricular valve and reduction in RV volume. Tricuspid regurgitation. RA dilation. Right heart failure. Copyright RV atrialization. Reduced function of the RV. Insufficient systolic contraction. Functional pulmonary valve atresia. Pulmonary flow. J. Cardiac output. Systemic hypoperfusion, dyspnea, and fatigue. Copyright bulging of the large sail-like anterior tricuspid leaflet into the RV equals Ravato equals 7 right heart pressure 1 flow through the patent foramen ovale right to left shunt cyanosis. Back collapse. Fine text outline. Clinical findings, degree. Scent. The clinical presentation of Epstein anomaly varies according to the severity of the abnormality. 65 Copyright mild apical displacement. Asymptomatic presentation throughout adulthood. O. Moderate tricuspid leaflet displacement. Cyanosis or heart failure in infancy or childhood. O. Severe displacement equals in utero heart failure. Non-immune hydrops fetalis death. Neonates and children. Copyright cyanosis. O. Severe cardiomegaly and heart failure. Copyright respiratory distress. Scent. Adolescents and adults. O. Arrhythmias. Example Wolff-Parkinson-White syndrome. O. Exertional dyspnea and fatigue. Copyright palpitations and sudden cardiac death. Scent. Cardiac examination findings. O. Loud $1 Jo. Widely split S1 and S2. Copyright hollow systolic murmur at the left sternal border. Diagnostics. Scent. Prenatal diagnosis, fetal echocardiography. Scent. Imaging. O. Echocardiography, confirmatory test, equals enlarged right heart equals tricuspid regurgitation. 1. Chest X-ray equals mild to severe cardiomegaly equals RA enlargement. O. MRI_1, apical displacement of the septal and posterior tricuspid leaflets. ECG. Copyright tall and broad P waves. O. First degree atrioventricular block, degree right axis deviation. JOE right bundle branch block. Copyright findings specific for WPW syndrome, example delta wave, pulse oximetry, SPO. Treatment. Scent. Initial postnatal management, stabilization of cardiorespiratory status until PVR decreases and surgery can be performed. Copyright PGE1 infusion, copyright inhaled nitric oxide or infusion of milrinone. 1. Scent. Surgical repair. Copyright objective, creation of a systemic pulmonary shunt, repair of the tricuspid valve, and reconstruction of the right ventricle. O. Age-related considerations. Neonates and infants should be avoided in infancy and delayed as long as possible. 66 equals children and adults. Recommended if concomitant heart failure or progressive RV dysfunction is present. 67 Scent. Arrhythmias, catheter ablation of the aberrant pathway. 68 Prognosis. Scent. Varies according to the severity of disease. Around 30% of patients die within the first year of life. 65 WA. OE. Total anomalous pulmonary venous return, TAPR. Overview. Scent. Definition: all four pulmonary veins drain into the systemic venous circulation, example SVC, sinus venosus, RA, IVC, instead of the left atrium. Cent other cardiac defects associated with TAPR, allow for right to left shunting and the mixing of deoxygenated and oxygenated blood O and N7. Back collapse. Find text outline. Total anomalous pulmonary venous return, TAPR. Overview. Cent definition: all four pulmonary veins drain into the SYIC venous circle, example SVC, sinus venosus, RA, IVC, instead of the left atrium. Cent other cardiac defects associated with TAPR, allow for right to left shunting and the mixing of deoxygenated and oxygenated blood OASDCA, OPDA. Epidemiology. Asterisk prevalence, 0.6-1.2/10,000 live births in the US, 61. Etiology. Cent multifactorial, may be associated with genetic alterations, 69E associated with heterotaxy syndromes that involve asplenia, 70, 71 pathophysiology. The severity of symptoms and clinical presentation is determined by the following factors: venous mixing, oxygenated pulmonary venous return mixes with the systemic venous system, right to left shunting of partially oxygenated blood via an interatrial connection, example ASD, PFO, rarely PDA, into the systemic arterial circulation, cyanosis, pulmonary venous obstruction, obstruction of pulmonary venous return 1, pulmonary venous pressure T, pulmonary edema TPVR/RVH, ventricular dilation, and heart failure. Clinical features 721. Cent cyanosis, cent respiratory failure, cent poor feeding and failure to thrive, hepatomegaly -1 * cardiac examination findings O fixed split $2, or loud $2 1 copyright systolic ejection murmur with diastolic rumble J or mild to no murmur. Diagnostics. Cent prenatal diagnosis, fetal echocardiography to detect abnormal pulmonary venous return 173. Cent imaging, copyright echocardiography, confirmatory test, equals malposition of pulmonary veins equals enlarged right heart equals right to left interatrial shunting chest x-ray equals snowman sign, seen in supracardiac TAPR. The orientation of the heart and superior mediastinum appear as the shape of a snowman equals pulmonary hypervascularity equals right heart enlargement ECG/72. Copyright nonspecific findings E. Right axis deviation due to RVH. Cent pulse oximetry, SPO. Treatment. Cent initial postnatal management, stabilization of cardiorespiratory status until surgery is performed, example mechanical ventilation, supplemental Oz, inotropes. Cent surgical repair, recommended in all patients regardless of the severity of disease, 74, prognosis. Cent with surgical correction, the long-term survival rate is 80 to 90%. 75, cent without treatment, 80% of patients die within the first year of life. 76. 7ES. Persistent truncus arteriosus. Back collapse. Find text outline. Steer persistent truncus arteriosus. Overview. Cent definition: underdevelopment of the aorticopulmonary septum, failure of the truncus arteriosus to divide into the aorta and pulmonary trunk, a single trunk that receives output from both ventricles. Cent other cardiac defects associated with persistent truncus arteriosus, EOVSD. Copyright interrupted aortic arch, 77, copyright coronary artery anomalies, 78, epidemiology. Plus prevalence, 1/10,000 live births in the US, 16. Etiology. Cent the failure of neural crest cells to migrate during the development of the cardiac outflow tract results in incomplete AP septum formation. 79, plus associated with DiGeorge syndrome, 8° LL81 pathophysiology. Deoxygenated and oxygenated blood mix via the VSD, the truncus arteriosus, receiving both RV and LV output blood flow to both pulmonary and systemic circulation. The severity of disease is determined by pulmonary vascular resistance, PVR. Clinical features. Cyanosis, respiratory distress. 1 failure to thrive. Cardiac examination findings: bounding peripheral pulses. Harsh systolic murmur at the lower left sternal border. Loud. $2 diagnostics. Plus prenatal diagnosis: fetal echocardiography _821. Imaging copyright echocardiography. Confirmatory test: single overriding great vessel arising from the heart. Copyright chest X-ray = right-sided aortic arch. T pulmonary vascular markings = absent thymus, if associated with DiGeorge syndrome. ECG, often normal and nonspecific findings. 4 pulse oximetry, SPO, treatment. Initial medical management: stabilization of cardiopulmonary function, example diuretics, dopamine, ventilation, correction of metabolic acidosis. 9 surgical repair: surgical correction is recommended in the neonatal period. 831L84I prognosis. With surgical repair, the 30-year survival rate is 70%. 85. Hypoplastic left heart syndrome, HLHS. Overview. Definition: spectrum of disease consisting of severe hypoplasia of the left ventricle with possible stenosis and/or atresia of the mitral valve, aortic valve, or aortic arch. 861 Epidemiology. Plus extremely rare, 2-3/10,000 live births in the US, 6187. Back collapse. Find text outline. Hypoplastic left heart syndrome, HLHS. Overview. Definition: spectrum of disease consisting of severe hypoplasia of the left ventricle with possible stenosis and/or atresia of the mitral valve, aortic valve, or aortic arch. 86 Epidemiology. Plus extremely rare, 2-3/10,000 live births in the US, 1687. Copyright sex, 72, 1.5:1, 88. Although rare, HLHS is responsible for 25 to 40% of all neonatal cardiac deaths. 89. Etiology. Multifactorial, associated with single gene polymorphisms, altered blood flow patterns, and intrauterine infection. 1997. 192. Syndromic associations: trisomy 13, trisomy 18, Jacobson syndrome, and Turner syndrome. 93-94. Pathophysiology. The hypoplastic left ventricle is nonfunctional, resulting in the RV becoming the primary supply for pulmonary and systemic circulations. Survival depends on the presence of a PDA, right to left shunt, J, and an ASD. Clinical findings. May be asymptomatic at birth if the open PDA provides adequate systemic perfusion. Aggravation of symptoms following closure of the PDA plus postnatal cyanosis, not corrected by supplement. 02, tachypnea, BPJ peripheral pulses, and cool extremities. 1, heart failure and cardiogenic shock. Cardiac examination findings. Copyright typically no murmur. 1 copyright loud, single. $2 1 diagnostics. Plus prenatal diagnosis, fetal echocardiography. 195 imaging echocardiography, confirmatory test visualization of absent or hypoplastic LVO chest X-ray, variable and nonspecific findings. ECG, typically normal. Pulse oximetry, SPO. Treatment. Initial medical management: continuous PGE1 infusion prior to heart surgery. 96 surgical repair, palliative surgery is used in single ventricular cardiopathologies. 88, 03-step staged surgical correction. 1 Norwood procedure, stage performed while the patient is a neonate. 971 L98 = Glenn procedure, stage 2 performed at 3 to 6 months of age. 99 = Fontaine procedure, stage ill performed after 2 to 3 years of age 100 copyright alternative, heart transplant 01 prognosis. Plus even with surgical correction, the 5-year survival rate remains low, 65%. 97 plus for patients that survive to 1 year of age, long-term survival, up to 18 years of age, is 90%. 702 IL 103. OI. OIEEE. Sources. Last updated January 29, 2024. Back collapse fine text outline. Fetal circulation postnatal circulation. Aorta fetal ductus arteriosus pulmonary trunk ligamentum arteriosum, obliterated ductus arteriosus, foramen ovale pulmonary veins. Foramen ovale, closed. E-lung, inflated, lung, not inflated. Ductus venosus ligamentum venosum A, obliterated ductus venosus, umbilical vein navel ligamentum teres ave, obliterated left umbilical vein, portal vein umbilical vessels, ligated. Umbilical medial umbilical ligament cord, umbilical artery, obliterated portio. Common iliac artery external iliac artery internal iliac artery. Umbilical artery, open portion artery to the ductus deferens C superior vesicle artery blood oxygen content low het. Fetal and postnatal circulation. Fetal circulation, left, is connected to the maternal circulation via the placenta. The umbilical vein delivers oxygen-rich blood from the placenta to the fetus, and the umbilical arteries return the blood to the placenta for oxygenation. Blood bypasses pulmonary circulation entering from the right to the left atrium via the foramen ovale. Deoxygenated blood entering the right atrium through the superior vena cava bypasses pulmonary circulation via the ductus arteriosus, which connects the pulmonary trunk to the aorta. Postnatal circulation, right, is formed under the influence of postnatal pulmonary ventilation and the disconnection of umbilical vessels. These alterations cause a change in pressure within the circulatory system, leading to the opening of the pulmonary circulation and obliteration of the umbilical vessels and bypass structures. Blue, deoxygenated blood; red, oxygenated blood; pink, mixed blood. Copyright Boss. Urocyanotic congenital heart defects, 2 halves. Digital clubbing VV. There is bulbous enlargement of the distal phalanges and the nail curvatures are markedly increased. Source: Congenital Heart Case 133 by Herbert Alfred MD and Hendrik A. van Dijk, OpenStack CNX, licensed under CC by SA 3.0. Urocyanotic congenital heart defects, 1/4. Tetralogy of Fallot VV. Tetralogy of Fallot is the simultaneous occurrence of a. Pulmonary stenosis, b. Right ventricular hypertrophy, c. Ventricular septal defect, VSD, d. An overriding aorta, above the VSD. The hemodynamic effects depend on the extent of right ventricular outflow tract obstruction. With mild obstruction, 1. A left to right shunt is more pronounced and there is mild cyanosis. With severe obstruction, 2, a right to left shunt is more pronounced, which results in severe cyanosis. Pulmonary circulation may be supplied via a patent ductus arteriosus. Copyright Boss. TET spell in TOF knee to chest positioning. JE hypernia _IJ pair normalization of /SE breathing and equals a blood oxygenation / 7. Cyanosis plus J / AEI. Psychological or PPJ blood flow to the EAE physical stress scale legs and Y on. Yen JSVR and / or TPVR TSVR. Equals T Ravato J Ravato 8 pounds ZT right to left J right to left shunting. J. Blood flow to pulmonary circulation. T. Blood flow to pulmonary circulation as TET spell in tetralogy of Fallot VV. TET spells, hypercyanotic spells, are caused by a sudden decrease in systemic vascular resistance, SVR, or increase in pulmonary vascular resistance, PVR, leading to intermittent worsening of right ventricular outflow tract obstruction, bravado, and increased right to left shunting. The resulting decrease in blood flow to the pulmonary circulation results in decreased blood oxygenation. Knee to chest positioning or, in older children, squatting relieves symptoms by increasing SVR, which in turn reduces right to left shunting and improves blood flow to the lungs. Copyright Boss. Urocyanotic congenital heart defects, 3/4 equals SS and EE *H, may know me, SI. Right ventricle. Aorta. Left ventricle / AE / OTL plus ventricular / septal. Defect left atrium. Ad ER YAT. Tetralogy of Fallot. Echocardiography, transthoracic, modified parasternal long axis view, the ascending aorta overrides a large ventricular septal defect. The right ventricular wall is notably thickened from hypertrophy. These are characteristic findings in tetralogy of Fallot. Source, Figure 8 in, Tetralogy of Fallot by Frederic Bale-Liard and Robert H. Anderson, Orphanet Journal of Rare Diseases, licensed under CC by 2.0. Modifications, added illustration. Urocyanotic congenital heart defects, 4/4, I. S. Overlay. Boot-shaped heart in tetralogy of Fallot VV. X-ray chest, PA view, of a patient with a history of tetralogy of Fallot. The cardiac apex is upturned from right ventricular hypertrophy, and the pulmonary artery segment is small and concave in appearance as a result of pulmonary stenosis. These findings produce a characteristic boot-shaped heart, green overlay, cf. Illustration, seen in some patients with tetralogy of Fallot. Pulmonary vascular markings are diminished as a result of reduced blood flow to the lungs. White dashed outline, normal size and shape of the heart source, boot-shaped heart by Medicalpool, Wikimedia Commons, licensed under CC by SA 4.0. Normal. Transposition of the great vessels, TGV, VV. TGV is a cyanotic congenital heart disease in which the pulmonary artery arises from the left ventricle and the aorta from the right ventricle, resulting in the formation of parallel circulatory systems. The left ventricle pumps oxygenated blood into the pulmonary circulation, red, and the right ventricle pumps deoxygenated blood into the aorta, blue, resulting in cyanosis. TGV is fatal unless a shunt between the two circulations is present, i.e., a patent ductus arteriosus or a patent foramen ovale, or a surgical intervention is performed in the neonatal period. Copyright Boss. Urocyanotic congenital heart defects, 2/5. Patent ductus arteriosus. Atrial septal defect. Intracardiac shunt in the transposition of the great vessels. In transposition of the great vessels, deoxygenated blood enters the systemic circulation. Survival after birth is only possible via an intracardiac shunt, example across a patent ductus arteriosus and / or a patent foramen ovale. The shunt diverts oxygenated blood from the pulmonary circulation into the systemic circulation, white arrows. Copyright Boss. Interventricular foramen C. Aorticopulmonary D. Membranous FF septum. Interventricular septum B. Muscular interventricular PP septum. Ventricular septation VV. Development of the muscular interventricular septum and interventricular foramen. The primary ventricle is a single cavity that is separated from the atrial cavity by the endocardial cushion. Ventricular septation begins with the formation of a muscular interventricular septum, which arises from the floor of the primitive ventricle and grows cranially toward the endocardial cushion. The interventricular foramen is the space between the endocardial cushion and the growing edge of the muscular interventricular septum, and it allows for interventricular communication. Development of the aorticopulmonary septum. The aorticopulmonary septum develops from ridges of tissue derived from neural crest cells within the ventricular outflow tract, truncus arteriosus. These ridges are continuous with the bulbar ridges of the bulbar cordis, not shown here. Development of the membranous interventricular septum and closure of the interventricular foramen. The membranous interventricular septum develops from the bulbar ridges and the endocardial cushion. The caudal end of the aorticopulmonary septum fuses with the muscular interventricular septum and closes the interventricular foramen. Urocyanotic congenital heart defects, 3/5. Interventricular foramen C. Aorticopulmonary D. Membranous FF septum. Interventricular septum B. Muscular interventricular PP septum. Ventricular septation V. Development of the aorticopulmonary septum. The aorticopulmonary septum develops from ridges of tissue derived from neural crest cells within the ventricular outflow tract, truncus arteriosus. These ridges are continuous with the bulbar ridges of the bulbar cordis, not shown here. Development of the membranous interventricular septum and closure of the interventricular foramen. The membranous interventricular septum develops from the bulbar ridges and the endocardial cushion. The caudal end of the aorticopulmonary septum fuses with the muscular interventricular septum and closes the interventricular foramen. 4. Division of the ventricular outflow tract. The aorticopulmonary septum fuses and rotates 180 degrees, dividing the outflow tract into the aorta, from the left ventricle, and pulmonary trunk, from the right ventricle. Copyright Boss. Cyanotic congenital heart defects, 4/5. Copyright. Overlay. Transposition of the great vessels. MRI cardiac, oblique sagittal plane. The aorta, AO, arises from the right ventricle, RV, while the pulmonary trunk, pulmonary artery, PA, originates from the left ventricle, LV. Source, Figure 5a. In The Role of Cardiovascular Magnetic Resonance in Pediatric Congenital Heart Disease by Hopewell N. Sanjana, Marina L. Hughes and Andrew M. Taylor, Journal of Cardiovascular Magnetic Resonance, Biomed Central, licensed under CC by 2.0. Modifications, removed an balloon atrial septostomy VV. IHE heart with transposition of the great vessels, 1 GV. Slight oxygen saturation of the blood occurs via the ductus arteriosus as well as a small atrial septal defect. This left-to-right shunt is enlarged using balloon atrial septostomy. 1. A balloon catheter is advanced into the right atrium through the inferior vena cava, then through the patent foramen ovale into the left atrium. 2. The correct positioning of the balloon is controlled via ultrasound. The balloon is expanded with a saline solution. 3. The balloon is pulled back through the foramen ovale into the right atrium, resulting in the fossa ovalis of the atrial septum tearing and creating an enlarged left-to-right shunt. 4. This results in an increase of oxygenated blood in the systemic circulation and a corresponding rise in saturation, usually directly following the procedure. However, balloon atrial septostomy is only a temporary measure. Patients with TGV will undergo an arterial switch surgery, which will result in a normal circulation of blood in the body. Urocyanotic congenital heart defects, 1/1. Normal heart tricuspid atresia patent ductus arteriosus. Patent foramen ovale tricuspid atresia ventricular septal defect underdeveloped right ventricle. Tricuspid valve atresia VV. A. Ascending aorta PT, pulmonary trunk PV, pulmonary valve RA, right atrium SVC, superior vena cava TV, tricuspid valve. Copyright Boss. Patent ductus arteriosus. Patent foramen ovale. Epstein anomaly VV. In the Epstein anomaly, the tricuspid valve is displaced into the lumen of the right ventricle, resulting in atrialization of the right ventricle. The remaining ventricle is small and hypocontractile. Because tricuspid valve regurgitation is also usually present, there is retrograde flow in the right atrium, which is dilated by the volume overload, in addition to antegrade pulmonary blood flow. Blood flows through the patent foramen ovale or, commonly associated, atrial septal defect from the right atrium to the left atrium, right to left shunt, and then via the left ventricle into the circulation, resulting in pronounced cyanosis. The pulmonary circulation system may also be perfused through blood from the aorta, via the ductus arteriosus. Copyright Boss. Urocyanotic congenital heart defects, 2/3. Epstein anomaly. Photograph of an autopsied heart, left, ultrasound image of the heart, right. AL, elongated anterior leaflet of the tricuspid valve, ARV, right ventricle, FRV, functional right ventricle, RA, right atrium, SL, septal leaflet of the tricuspid valve, asterisk, tethering of the septal leaflet of the tricuspid valve to the ventricular wall, LA, left atrium, LV, left ventricle, dotted lines, black in the autopsied heart, white in the ultrasonographic image. Identify the division between the RA and the RV. Tha loschflate AF Tha trineonid walla arid tatharad ta Tha ventricular wall and dienlanad inferior into Tha lyman AF Tha rent. Urocyanotic congenital heart defects, 3/3. Copyright. Overlay. Cardiomegaly in Epstein anomaly. X-ray chest, PA view, of a neonate with Epstein anomaly. The cardiac silhouette is markedly enlarged. Prominent convexity of the right heart border, green line, is the result of caudal displacement of the tricuspid valve with atrialization of the right ventricle and tricuspid regurgitation. The central pulmonary arteries, green arrowheads, and aortic knob, red arrowhead, are diminutive in appearance. An endotracheal tube is present, along with an umbilical venous catheter and nasogastric tube. Radiographic findings in Epstein anomaly may vary with the severity of the condition. Source: Figure 1, in Pure duplication of the distal long arm of chromosome 15 with Epstein anomaly and clavicular anomaly by R. O'Connor A. Al-Marani, S. Aftamose et al., Hindawi, Case Reports in Genetics, licensed under CC by 3.0. Normal heart total anomalous pulmonary venous return. Connecting vein. Pulmonary veins do not connect to left atrium. Atrial septal defect. Total anomalous pulmonary venous return. A congenital heart defect in which the pulmonary veins merge to form a connecting vein that drains into the systemic venous circulation, example the vena cava, rather than the left atrium. Without return of blood to the left heart, there is no systemic circulation. Survival after birth depends on the presence of a right to left shunt, usually an atrial septal defect, to allow for blood to enter the left heart, then systemic circulation. Copyright Boss. Urocyanotic congenital heart defects, 1/1. Normal heart persistent truncus arteriosus. Persistent truncus arteriosus ventricular septal defect. Persistent truncus arteriosus VV. Persistent truncus arteriosus, PTA, is a congenital cyanotic heart defect in which the truncus arteriosus fails to divide into the pulmonary trunk and aorta and instead remains as a single trunk that receives blood from both ventricles. The pulmonary circulation and systemic circulation are not separated from one another, therefore, deoxygenated and oxygenated blood mix. After birth, the pulmonary vascular resistance, PVR, drops, resulting in blood being shunted to the pulmonary circulation, leading to pulmonary congestion and subsequent heart failure. Copyright Boss. Urocyanotic congenital heart defects, 1/1. Normal heart hypoplastic left heart syndrome. Underdeveloped aorta patent ductus arteriosus. Atrial septal defect, underdeveloped mitral valve, underdeveloped aortic valve, hypoplastic left ventricle. Cyanotic congenital heart defects, hypoplastic left heart syndrome VV. Hypoplastic left heart syndrome is a cyanotic congenital heart defect in which the left ventricle, LV, does not form properly, resulting in an absent or hypoplastic LV stenosis and/or atresia of the mitral valve, aortic valve, and/or aortic arch are also possible. The left ventricle is non-functional, resulting in the RV becoming the primary supply for the pulmonary and systemic circulations. An atrial septum defect ensures that oxygenated blood from the lungs flows from the left atrium into the right atrium. A right-to-left shunt across the patent ductus arteriosus then ensures that blood flows from the main pulmonary artery to the aorta, to reach the systemic circulation. Copyright Boss. X. Acyanotic congenital heart defects. Acyanotic congenital heart defects, CHDs, are cardiac malformations that affect the atrial or ventricular walls, heart valves, or large blood vessels. Common causes include genetic defects, example trisomies, maternal infections, example rubella, or maternal use of drugs or alcohol during pregnancy. Acyanotic heart defects are pathophysiologically characterized by a left-to-right shunt, which causes pulmonary hypertension and right heart hypertrophy. The symptoms depend on the extent of the malformation and the resulting impairment of cardiac function. Infants may be asymptomatic or present with exercise intolerance, failure to thrive, and symptoms of heart failure. Characteristic heart murmurs are important clues for establishing the diagnosis, which is typically confirmed by visualizing the defect on echocardiography. Chest X-ray, MRI, or cardiac catheterization may also be required to determine indications for surgery and plan the procedure. Acyanotic heart defects requiring treatment are repaired via catheter procedures or surgery. Supportive medical therapy is required in cases of heart failure, example diuretics, inotropic agents, or if surgery cannot be performed, example prostaglandin. Complications are more likely the longer treatment is delayed, and include arrhythmias, embolisms, infective endocarditis, and reversal of shunt physiology, i.e., Eisenmenger syndrome. OE. Overview. Common acyanotic CHDs. Overview of acyanotic CHDs. ILF2 description, associated conditions and risk factors. Defect in the interatrial septum, Down syndrome. 4 atrial left to right shunt, RA and RV volume overload. Atrial septal defect, ASD, fetal alcohol syndrome. I, intrauterine infections, example Torch, 6LT7. Defect in the interventricular septum, ventricular left to right shunt, RV and LV volume overload can cause pulmonary hypertension. Maternal diabetes, ventricular septal defect, VSD, 8 Down syndrome. 4 intrauterine infections, example Torch, L7. Variable deficiency in atrioventricular, AV, septa, atrioventricular septal defect plus AV left to right shunt possible, AVSD, AV valve regurgitation complete form associated with pulmonary hypertension. Down syndrome. 4 persistence of the foramen ovale cordis after 1 year of age, often asymptomatic, may be associated with other congenital heart diseases and syndromes, example Lewis in adults, may precipitate embolic strokes or be diagnosed Dietz syndrome, incidentally. Patent foramen ovale, PFO, 9. Fetal alcohol syndrome, patent ductus arteriosus, PDA, Asterisk persistence of the ductus arteriosus postnatally congenital rubella 4 left to right shunt from the aorta to the pulmonary artery 13 Down syndrome. Asterisk narrowing of the aortic arch plus LV outflow tract obstruction coarctation of the aorta 15 asterisk collateral circulation differential blood pressures Turner syndrome 16. Distal systemic hypoperfusion in long segment coarctation. Narrowing at the pulmonary valve stenosis, 7 to 18 plus RV outflow tract obstruction RV hypertrophy congenital rubella. And the 3DS of acyanotic CHDs, in order of frequency VSD, ASD, PDA. Pathogenesis, 19. Principles. Congenital heart defects, CHDs, are caused by the disruption of the normal sequence of cardiac morphogenesis. CHDs may lead to the formation of pathological connections, shunts, between the right and left heart chambers, allowing blood to flow along the pressure gradient from high pressure to low pressure. Asterisk the shunts are classified according to the direction of the blood flow as either left to right or right to left. Shunt types. Sent left to right shunt. Back collapse fine text outline. Shunt types. Sent left to right shunt copyright oxygenated blood from the lungs is shunted back into the pulmonary circulation via an atrial septal defect, ASD, ventricular septal defect, VSD, or patent ductus arteriosus, PDA, pulmonary hypertension, right ventricular pressure overload right-sided heart hypertrophy, cardiomegaly on X-ray, and heart failure but no cyanosis plus right to left shunt. Blood flows from the right to the left heart via a shunt deoxygenated blood entering the systemic circulation cyanosis - Sent see Eisenmenger syndrome for details on how a left to right shunt can develop into a right to left shunt over time. And left to right shunts equals later cyanosis. Right to left shunts equals early cyanosis. General clinical features. For specific features, see clinical features in the respective subsections. Nonspecific findings. Sent failure to thrive, sent recurrent bronchopulmonary infections 1, sent normal skin tone 1, exercise intolerance, copyright fatigue, pallor and diaphoresis, sweating, copyright tachycardia, copyright dyspnea I, copyright grunting, nasal flaring, retractions, and / or head bobbing may be seen 20. Heart failure. Sent right heart failure or hepatic venous congestion with hepatomegaly, copyright peripheral edema is rarely seen in infants. 21 Sent left heart failure, copyright tachypnea, pulmonary edema or low cardiac output, blood pressure, pallor, sweating, cool extremities, syncope. Medical management of acyanotic CHDs / degree I. Sent nutritional support and routine vaccinations, ductal dependent CHDs, prostaglandin E1 infusion to prevent PDA closure, sent manage heart failure. O respiratory support as needed, copyright diuretics to decrease fluid volume, ACE inhibitors to lower systemic vascular resistance, copyright inotropic agents, example digoxin, to improve cardiac contractility, determine the need for surgical repair and postoperative antibiotic prophylaxis. Manage Eisenmenger syndrome if it develops. Cardiac septal defects. Comparison of Phi of VSD and ASP1. Ventricular septum defect, VSD, MSS atrial septum defect, ASD, M. Trademark epidemiology. Most common congenital heart defects, sent third most common CHD 22. Holt-Oram syndrome * intrauterine infections, example Torch, L7 etiology. Down syndrome, 4, Down syndrome, 4, plus maternal diabetes degree fetal alcohol syndrome. Small defect usually asymptomatic. Clinical failure to thrive features medium-sized or large * recurrent bronchopulmonary infections * exertional dyspnea, fatigue defect, exercise intolerance, sent recurrent bronchopulmonary infections, sent CHF. Sent harsh hollow systolic murmur over the left lower sternal border. A copyright typically louder in small defects. Asterisk systolic ejection murmur auscultation degree maneuvers that increase left ventricular afterload. Example asterisk widely split second heart sound, S2, over the second left ICS, which is fixed, does hand grip, 7 intensity not change with respiration. Back collapse fine text outline. Auscultation. Small defect ECG, medium-sized or large defect echocardiography. Chest X-ray. Lee atrial septal defect, ASD. Description. Harsh hollow systolic murmur over the left lower sternal border. Copyright typically louder in small defects. O maneuvers that increase left ventricular afterload, example hand grip. 7 intensity mid-diastolic murmur in case of pulmonary hypertension, loud pulmonic SP. Normal ECG findings. Signs of LV hypertrophy and RV hypertrophy. Pathological left to right blood flow, enhanced pulmonary vascular markings, left atrial and ventricular enlargement. Later stages, enlarged right ventricle and pulmonary artery. Systolic ejection murmur, widely split second heart sound, S2, over the second left ICS, which is fixed, does not change with respiration. Signs of RV hypertrophy. Supraventricular arrhythmias. Interatrial communication. Enlarged right atrium and ventricle, enhanced pulmonary vasculature. Sent a defect in the atrial wall that may result from impaired growth or excessive resorption of the atrial septum. Epidemiology 1. Plus third most common CHD, 1/2,000 live births, 221 cent sex, 20 cent etiology. Asterisk Down syndrome 4. Cent fetal alcohol syndrome 5 cent intrauterine infections, example torch, LOL 7 plus Holt Oram syndrome, hand-heart syndrome, IO autosomal dominant disorder. OFX 1/100,000 children. Copyright characterized by ASD, a first-degree heart block, and abnormalities of the upper limbs, example absent radial bones, pathophysiology. Impaired growth or excessive resorption of the atrial septa in utero leads to atrial septal defects, absent atrial septa tissue. O ostium primum atrial septal defect, ASD 15 to 20%, usually accompanied by other heart defects. Copyright ostium secundum atrial septal defect, ASD 270%, usually isolated, sent typically a low pressure, low volume, minor left to right shunt, therefore, patients are asymptomatic. ASD oxygenated blood shunting from LA to RATF up saturation in the RA10S, saturation in RV and pulmonary artery. In more severe defects, the shunts may lead to supraventricular arrhythmias, pulmonary hypertension, and /or Eisenmenger syndrome. Clinical features 31. General. Sent depend on defect size and shunt volume. Small defects, usually asymptomatic. Sent medium-sized to large defects. O symptoms can vary from asymptomatic to heart failure. OASDs typically manifest with advancing age. 3. General clinical features above. Auscultation 3. Back. VNA collapse. AO. Fine text outline. Auscultation 1. Sent systolic ejection murmur over the second left ICS sternal border. Sent widely split second heart sound, S, over the second left ICS, which is fixed, does not change with respiration. Sent soft mid-diastolic murmur over the lower left sternal border. AE. Epital defect. Diagnostics 23. Sent echocardiography, confirmatory test. Interatrial communication, best visualized in the apical forechamber and subcostal views. 24. Sent ECG, signs of RV hypertrophy, vertical or right axis deviation, P pulmonale, PR prolongation, complete or incomplete right bundle branch block, sent chest X-ray copyright enlarged right atrium, right ventricle, and pulmonary artery EO enhanced pulmonary vasculature. Treatment/31. Sent medical management, rarely required sent surgical repair, example transcatheter closure, patch. 4. Copyright right ventricular enlargement copyright large left to right shunts copyright clinical features of congestive heart failure o prior paradoxical embolism. Copyright up to 40% of ASDs spontaneously close by the age of 5 years. 25. Complications 26. Paradoxical embolism, 7 risk of ischemic stroke small blood portions from inferior vena cava bypass pulmonary circulation direct emptying into left atrium paradoxical embolism and stroke in the case of thromboembolism heart failure. VA CE Leaf ventricular septal defect, VSD. Description: an abnormal communication between the left and right ventricle that results in left to right shunting of blood flow. Epidemiology. Most common congenital heart defect, 4/1,000 live births, 27, cent occurs as an isolated heart defect or in combination with others, example with AVSD, tetralogy of Fallot, TGA, etiology. Asterisk genetic syndromes IEO most commonly, Down syndrome, Edwards syndrome, Patau syndrome EO less commonly, Cri-du-Chat syndrome, Apert syndrome plus intrauterine infections, example Torch, Euro LL7 asterisk maternal risk factors, diabetes, obesity, smoking 27I degree pathophysiology. Most commonly located in the membranous part of the ventricular septum, pars membranacea, sent defect in ventricular septum left to right shunt with the following consequences: EO-RV volume overload, RV eccentric hypertrophy, O excessive pulmonary blood flow, T pulmonary artery pressure, pulmonary hypertension, E cardiac output, O LV volume overload, LV eccentric hypertrophy. Copyright 1 Up saturation in right ventricle and pulmonary artery. Back collapse. Fine text outline. Clinical features 1L8. General. Sent small defects, usually asymptomatic. Sent medium-sized or large defects. Copyright lead to heart failure by the age of 2 to 3 months. O become symptomatic after high pulmonary vascular resistance, PVR, present at birth starts to decrease, PVRJ right ventricular pressure 7 left to right shunt symptoms EC nonspecific findings and heart failure in overview above. Sent hyperdynamic precordium may be detected in hemodynamically relevant defects. A. Auscultation. Plus harsh hollow systolic murmur over the left lower sternal border. Copyright becomes more intense with maneuvers that increase left ventricular afterload, example hand grip, degree typically louder in small defects. Sent mid-diastolic murmur over cardiac apex, sent loud pulmonic S, if pulmonary hypertension develops, systolic thrill 7. Uller. A. Septal defect. Ad. Symptoms of heart failure in children with VSD only develop when PVR decreases to adult levels and thus allows left to right shunting to occur. Diagnostics. 8. Sent echocardiography, confirmatory test, copyright to assess defect size and shunt volume. Copyright Doppler ultrasound findings of pathological left to right blood flow can help diagnose minor ventricular defects. ECG. Copyright small defects, normal ECG findings. O medium-sized or large defects equals signs of LV hypertrophy, due to volume loading. TQRS amplitude, left axis deviation, left atrial enlargement. Signs of RV hypertrophy, due to pulmonary hypertension or obstruction of the pulmonary outflow tract. Vertical or right axis deviation, P pulmonal, PR prolongation, complete or incomplete right bundle branch block. Sent chest X-ray. O enhanced pulmonary vascular markings. O left atrial and ventricular enlargement. Copyright in later stages, enlarged right ventricle and pulmonary artery, due to elevated PVR. Treatment 8IL3. Sense small defects. Copyright often close spontaneously and rarely require surgical interventions. Copyright follow-up echocardiography is recommended. Sense symptomatic and large defects. Copyright all patients. Provide medical management of acyanotic CHDs as needed. Copyright surgical repair. Example patch. I equals infants with large left to right shunts with clinical symptoms. Example failure to thrive. Treatment resistant congestive heart failure. Equals asymptomatic older children with large left to right shunts or evidence of left atrium or left ventricular dilatation. Equals VSD with aortic insufficiency or aortic valve prolapse into the VSD. Equals pulmonary hypertension. At VSD closure results in lower right ventricular and left atrial pressures and higher left ventricular pressures than pre-closure values. 28. Copyright VSD closure is contraindicated in patients with Eisenmenger syndrome. 3. Complications. Back collapse. Find text. O. Outline. C. Complications. Sent arrhythmias. Sent heart failure. Eisenmenger syndrome. Sent infective endocarditis. Sent aortic regurgitation. OOOE. Lee atrioventricular septal defect, AVSD. Definition: 31A defect of atrioventricular valves, i.e., mitral and tricuspid valves, as well as the atrial and/or ventricular septum, previously referred to as endocardial cushion defects. Sent complete form, ASD and VSD, common AV valve. Sent partial form, only ASD and minor AV valve abnormalities. Etiology plus strongly associated with Down syndrome. 129I30. Sent association with maternal diabetes and obesity has been shown in some studies. 31 Pathophysiology. 3. Sent complete form, ASD and VSD, equals atrial and ventricular left to right shunt, excessive pulmonary blood flow and biventricular volume overload, pulmonary hypertension and heart failure. Sent partial form, ASD only, atrial left to right shunt, symptoms that may remain minimal until adulthood. Sent in both forms, abnormal AV valve regurgitation in utero, heart failure, non-immune hydrops fetalis. 32 Clinical features. 31 Complete form, see nonspecific findings and heart failure in overview above. Partial form, see clinical features in atrial septal defect, ASD. J. Diagnostics. 33. Sent antenatal echocardiography, findings of endocardial cushion defect in first trimester. Screening for Down syndrome. Echocardiography, confirmatory test to assess defect size, shunt volume, and global cardiac function. Sent ECG, left axis deviation due to LVH. Sent chest X-ray. Copyright complete form, global cardiomegaly, 1 pulmonary markings. Copyright partial form, enlarged right heart and pulmonary artery treatment, 141I33I3. Sent all patients, provide medical management of acyanotic CHDs as needed. Sent surgical management, patch closure and AV valve reconstruction. WAOBN. Patent foramen ovale, PFO. Description: a variant of cardiac anatomy in which the foramen ovale remains patent beyond 1 year of age. Epidemiology plus prevalence, 25% of the general population, 341. Etiology: sent associated with Lewy-Steets syndrome and pathophysiology plus failure of the atrial septum primum to fuse with the septum secundum following birth. Persistence of foramen ovale. Mild left to right shunt. A shunt reversal may be induced by certain maneuvers that increase right atrial pressure, example, Valsalva maneuver, coughing. BASD equals septal tissue deficiency. PFO equals enough tissue, but problems with fusion. Clinical features. C0027 equals back collapse. Find text outline. Clinical features. Affected individuals are usually asymptomatic until complications occur. Diagnostics. 35. PFOs are sometimes an incidental finding during procedures, example PCI, cardiac surgery, or must be evaluated for after an embolic event, example ischemic stroke. Sent TTE with agitated saline, best initial test to evaluate for a right to left shunt. Sent indications for T with agitated saline. Copyright inconclusive TTE. Copyright high index of suspicion for PFO despite negative TTE. Treatment, 10. Asymptomatic PFO, treatment is not usually required. Sent confirmed PFO after embolic event, example ischemic stroke, 10. Copyright requires multidisciplinary evaluation by cardiology and neurology to determine the likelihood of paradoxical embolism from PFO. Copyright treatment may include equals antiplatelet agents or anticoagulation equals surgical or percutaneous closure of the defect. 0. PFO is one of many possible causes of stroke. Reducing subsequent stroke risk should include the evaluation of other potential causes, example arrhythmia, hypercoagulability, endocarditis. 10. Complications 34. Paradoxical embolism. Sent ischemic stroke. Sent systemic embolisms, example renal infarction. WA. CE. Patent ductus arteriosus, PDA. Description. Sent failure of the ductus arteriosus to completely close postnatally. Epidemiology. Asterisk incidence, 5 to 10% full-term births. 87 plus in premature infants, 20 to 60%. 871 asterisk sex, 2 hashtag, 2:1, 8. Etiology. Sent prematurity. Maternal exposure during pregnancy or rubella infection, during the first trimester of pregnancy. Copyright alcohol consumption. Phenytoin use, fetal hydantoin syndrome, prostaglandin use. Sent respiratory distress syndrome. Sent trisomies, example Down syndrome. Pathophysiology. Ductus arteriosus enables the underdeveloped lungs to be bypassed by the fetal circulation, normal right to left shunt, and remains patent in utero via PGE and low O tension. After birth, pulmonary vascular resistance decreases and thus allows for the reversal of the shunt from right to left to right. Sent failure of the ductus arteriosus to close after birth. Persistent communication between the aorta and the pulmonary artery. Left to right shunt. Volume overload of the pulmonary vessels. Continuous RV, and /or LV, strain. Heart failure, see also overview above. Eisenmenger syndrome may occur with shunt reversal and manifest with differential cyanosis. Back collapse. Fine text outline. Clinical features. General. Small PDA, asymptomatic with normal findings on physical examination. Large PDA. Copyright nonspecific symptoms, example failure to thrive, and symptoms of heart failure in infancy. See the overview above. Bounding peripheral pulses, wide pulse pressure. 38. Copyright heaving, laterally displaced apical impulse. Auscultation. Small PDA, a murmur is sometimes heard incidentally during routine primary care visits. Sent large PDA, machinery murmur, loud continuous murmur heard best in the left infraclavicular region, and loudest at AAC. AE. Ductus arteriosus. Registered PDA comes with prolonged deafening auscultation findings. Diagnostics, 111I39. Sent echocardiography, confirmatory test. Findings may show left atrial and ventricular dilatation. Used to assess shunt volume and pulmonary artery pressure. Copyright color Doppler, findings may show blood flow from the aorta into the pulmonary artery. ECG. Normal findings in small PDA. Left axis deviation due to LVH seen in large PDA. Sent chest X-ray. Copyright prominent pulmonary artery and aortic knob at the upper left heart border. Increased pulmonary markings. Sent cardiac catheterization and angiography, only necessary prior to repair or in more complex CHDs. Treatment, 11112. Management of PDA is complex and based on the specific PDA, example size of left to right shunt, and patient characteristics, example weight, age. PDA closure, 141. Scent indications copyright heart failure symptoms O left atrial and / or left ventricular enlargement O pulmonary hypertension without right to left shunt scent contraindications E ductal dependency HD copyright pulmonary hypertension with right to left shunt methods copyright transcatheter occlusion copyright surgical ligation. Pharmacological closure in premature infants 3. The management of premature infants with a PDA is complex and requires a multidisciplinary team including a neonatal intensivist and pediatric cardiologist. Scent indications copyright infants with birth weight 1 kg with symptomatic PDA, example heart failure symptoms, respiratory distress, scent contraindications copyright ductal dependency HD copyright persistent pulmonary hypertension of the newborn. Scent treatment, indomethacin and ibuprofen induce PDA closure by inhibiting prostaglandin synthesis. 3 scent alternatives 9 Deritanania catheter ancasian. Back collapse fine text outline. E-treatment. Inagometnicin and ibuprofen inos FUA closure dy inhibiting prostaglandin synenesis. S scent alternatives copyright percutaneous catheter occlusion copyright surgical ligation. Copyright PDA closure is contraindicated if the PDA is required for survival, example ductal dependent CHDs initiate a prostaglandin E1 infusion to keep the ductus arteriosus patent until definitive treatment can be performed. 49. Complications 381. Scent heart failure in infancy Scent infective endocarditis common cause of pulmonary hypertension and Eisenmenger syndrome in adolescents and adults Scent differential cyanosis. *G. CE. Coarctation of the aorta. Definition. Narrowing of the aorta at the aortic isthmus or, rarely, in the descending thoracic or abdominal aorta Epidemiology 41. Scent prevalence, 3/10,000 live birth scent sex, 7-2. Etiology 21. Congenital. Exact cause is unknown, but 2 hypotheses have been proposed, copyright hemodynamic, caused by underdevelopment of the aorta due to an abnormally decreased antegrade intrauterine blood flow copyright ductal, caused by closure of the ductus arteriosus tissue that extends into the thoracic aorta plus associated with Turner syndrome, in 5 to 15% of female patients with coarctation, 421I16*, often accompanied by a bicuspid aortic valve, VSD, and/or PDA. Acquired. Scent Takayasu arteritis Scent severe atherosclerosis pathophysiology, L2I. Scent genetic defects and/or intrauterine ischemia medial thickening and intimal hyperplasia formation of a ridge encircling the aortic lumen narrowing of the aorta 1 flow proximal to the narrowing and flow distal to the narrowing MS copyright coarctation is most commonly juxtadictal. Copyright the coarctation most commonly occurs distal to the left subclavian artery, where the ductus arteriosus originates. Rarely, the coarctation occurs in the lower segments of the thoracic aorta or in the abdominal aorta Scent in discrete coarctation, left ventricular outflow obstruction, myocardial hypertrophy and increased collateral blood flow, example intercostal V-is, scapular V-is. In long segment coarctation, closure of PDA after birth left ventricular pressure and volume overload hypoperfusion of organs and extremities distal to the stenosis, 43. 9 IE, PEYT. Clinical features 2. General. Neonates OE asymptomatic if the coarctation is mild and PDA is present copyright symptomatic in critical stenosis, blood flow to the lower body is PDA dependent see overview. Scent may be asymptomatic in older infants, children, and adults. Potential features include, copyright differential cyanosis, cyanosis of the lower extremities brachial femoral delay, weak femoral pulses O1 blood pressure, BP, in upper extremities and BP in lower extremities equals in distal narrowing of the left subclavian artery, TBP in both arms and BP in both legs. Back collapse. Fine text outline. May be asymptomatic in older infants, children, and adults. Potential features include copyright differential cyanosis, cyanosis of the lower extremities, brachial femoral delay, weak femoral pulses, O1 blood pressure, BP, in upper extremities and BP in lower extremities equals in distal narrowing of the left subclavian artery, TBP in both arms and JBP in both legs equals in origin of left subclavian artery is involved, BP in the right arm in left arm. Copyright cold feet and lower extremity. Claudication upon physical exertion. Copyright strong apical impulse displaced to the left. O headache, epistaxis, tinnitus. O in severe stenosis, shock and multi-organ failure when ductus arteriosus closes. O in severe stenosis, see nonspecific findings and heart failure in overview above. Auscultation. Sent systolic ejection murmur over left posterior hemithorax 4 and / or continuous murmur below the left clavicula and between the shoulder blades. Diagnostics 31. Sent blood pressure measurements. Best initial test BP measurements for upper and lower extremities to check for brachial femoral delay. Sent post-coarctation pulse oximetry, SPO may be present for ECG. O newborns, signs of RV hypertrophy. Copyright older children, normal or signs of LV hypertrophy. Sent Doppler echocardiography, confirmatory test location and extent of stenosis, detection of concurrent anomalies, VSD, PDA, bicuspid aortic valve, X-ray. Copyright cardiomegaly and TT pulmonary vascular markings. O figure of 3 sign, the result of an hourglass-like narrowing of the aorta caused by predilatation and postdilatation of the aorta with an indentation at the site of coarctation. 4. Copyright rib notching, a radiographic sign caused by collateral circulation between the internal thoracic and intercostal arteries equals enlarged vessels compress the neighboring ribs, causing pressure atrophy. Equals classically affects the inferior border of the 3/8 ribs. Sent MRI or CT. O in complicated cases and in adults. Copyright to determine the length of coarctation and for intervention planning plus genetic testing, for Turner syndrome, 61. BS. Treatment, 215. Sent neonates with critical coarctation. O initiate prostaglandin E1 infusion. O medical management of acyanotic CHDs, example inotropic support, respiratory support. Plus non-critical coarctation, 45, surgical correction, preferred in neonates. 3. O balloon angioplasty. O stent placement. Follow-up, monitor for restenosis, aortic aneurysm, and aortic dissection. Complications. Sent secondary hypertension. Sent aortic dissection and rupture. Berry aneurysm. Cerebral hemorrhage. 46. Sent heart failure. Sent infective endocarditis. Pulmonary valve stenosis. Description. Sent avalvular heart disease characterized by obstruction of blood outflow from the right ventricle into the pulmonary arteries during systole. Epidemiology. OOZ 7 equals. Back collapse. Fine text outline. Pulmonary valve stenosis. Description. Sent avalvular heart disease characterized by obstruction of blood outflow from the right ventricle into the pulmonary arteries during systole. Epidemiology. Sent relatively common in the general population, 10% of all CHDs, 3+ usually congenital, rarely acquired. Pathophysiology. Pulmonary valve stenosis. Right ventricular outflow obstruction. Pressure overload. Right ventricular hypertrophy. Clinical features. Sent depending on the grade of stenosis, symptoms of heart failure may occur. Sent systolic murmur heard best over the second left ICS at the sternal border plus S wide splitting 1. Diagnostics, 171. Sent echocardiography, confirmatory test to assess the severity of stenosis. Chest X-ray, may show pulmonary artery dilatation, 1, Treatment, 171I18. Plus neonates with critical pulmonary valve stenosis 71/3 copyright maintain PDA until definitive treatment can be performed. Method, prostaglandin E1 infusion sent non-critical pulmonary valve stenosis or repair is indicated in symptomatic patients with moderate to severe pulmonary valve stenosis. Copyright procedures include balloon valvuloplasty of the pulmonary valve, first line, and surgical commissurotomy. DG your FO, low. Eisenmenger syndrome. Description 3148. SENT a complication of acyanotic heart disease in which the shunt reverses over time and cyanotic heart disease develops. SENT can occur at any age, but usually develops during late stages of CHD's etiology. Eisenmenger syndrome may develop with any cardiac defect with a left-to-right shunt, but common defects include SENT complete AVSD, SENT persistent truncus arteriosus VSD, PDA pathogenesis 31L48. 1 left-to-right shunt, prolonged pulmonary hypertension, reactive constriction with permanent remodeling of pulmonary vessels, irreversible pulmonary hypertension. 2. Pulmonary hypertension, RV hypertrophy, increased RV pressure. 3. RV pressure exceeds LV pressure, shunt reversal, development of right to left shunt, cyanosis, digital clubbing, and polycythemia. Clinical features 31. Children at risk of Eisenmenger syndrome are often minimally symptomatic. Symptoms worsen with age and with increasing pulmonary resistance. Cyanosis, copyright central cyanosis is prominent. Copyright differential cyanosis, cyanosis in the lower extremities, seen in patients with PDA, low. SENT digital clubbing, SENT chest pain. Diagnosis. Back collapse, fine text outline. X acyanotic congenital heart defects. Systolic murmur heard best over the second left ICS at the sternal border *SY wide splitting 1. Diagnostics, 171. SENT echocardiography, confirmatory test to assess the severity of stenosis. SENT chest X-ray, may show pulmonary artery dilatation. Treatment, 171/18. Plus neonates with critical pulmonary valve stenosis 471/5E maintain PDA until definitive treatment can be performed. Method, prostaglandin E1 infusion sent non-critical pulmonary valve stenosis or repair is indicated in symptomatic patients with moderate to severe pulmonary valve stenosis. Copyright procedures include balloon valvuloplasty of the pulmonary valve, first line, and surgical commissurotomy. And Eisenmenger syndrome. Description 31L481. A complication of acyanotic heart disease in which the shunt reverses over time and cyanotic heart disease develops. SENT can occur at any age, but usually develops during late stages of CHD's etiology. 1. Eisenmenger syndrome may develop with any cardiac defect with a left-to-right shunt, but common defects include SENT complete AVSD, SENT persistent truncus arteriosus VSD, PDA pathogenesis 31L48. 1 left-to-right shunt, prolonged pulmonary hypertension, reactive constriction with permanent remodeling of pulmonary vessels, irreversible pulmonary hypertension. 2. Pulmonary hypertension, RV hypertrophy, increased RV pressure. 3. RV pressure exceeds LV pressure, shunt reversal, development of right to left shunt, cyanosis, digital clubbing, and polycythemia. Clinical features 31. Children at risk of Eisenmenger syndrome are often minimally symptomatic. Symptoms worsen with age and with increasing pulmonary resistance. SENT cyanosis, copyright central cyanosis is prominent. Copyright differential cyanosis, cyanosis in the lower extremities, seen in patients with PDA, SENT digital clubbing, SENT chest pain. Diagnosis. Echocardiography, to assess the underlying defect, evaluate shunt direction, and estimate RV and pulmonary arterial pressures. SENT cardiac catheterization, to evaluate the extent of the shunt and measure the pressure in the heart and pulmonary circulation. Treatment/31. Treatment should be guided by specialists in pulmonary hypertension and pediatric cardiology. Treatment includes medical management of acyanotic heart defects, treatment of pulmonary hypertension, rare cases, surgical treatment. Copyright heart-lung transplant or lung transplant with correction of CHD. Copyright limited by lack of donors and poor prognosis. Back collapse. Fine text outline. Euroacyanotic congenital heart defects, 1/2. Brachiocephalic artery, left common carotid artery, aorta, left subclavian artery, superior vena cava, ligamentum arteriosum, right pulmonary artery, left pulmonary artery, pulmonary trunk, left pulmonary veins, right pulmonary veins, left atrium. Pulmonary valve, aortic valve. Right atrium, mitral valve. II tendon are opening of coronary sinus and venous cords. Left ventricle tricuspid valve, papillary muscle, right ventricle, interventricular septum, inferior vena cava. Anatomy of the heart and adjacent large vessels. VV. Blue, structures that carry deoxygenated blood. Red, structures that carry oxygenated blood. Copyright Boss. Fetal circulation, postnatal circulation. Aorta, fetal ductus arteriosus, pulmonary trunk, ligamentum arteriosum, obliterated ductus arteriosus, foramen ovale, pulmonary veins. Foramen ovale, closed. Lung, inflated, lung, not inflated. Ductus venosus, ligamentum venosum A, obliterated ductus venosus, umbilical vein, navel, ligamentum teres ave, obliterated left umbilical vein, portal vein, umbilical vessels, ligated. Umbilical medial, umbilical ligament cord, umbilical artery, obliterated portia. Common iliac artery, external iliac artery, internal iliac artery. Umbilical artery, open portion artery to the ductus deferens. C. Superior vesicle artery, blood oxygen content low. Het. Fetal and postnatal circulation. Fetal circulation, left, is connected to the maternal circulation via the placenta. The umbilical vein delivers oxygen-rich blood from the placenta to the fetus, and the umbilical arteries return the blood to the placenta for oxygenation. Blood bypasses pulmonary circulation, entering from the right to the left atrium via the foramen ovale. Deoxygenated blood entering the right atrium through the superior vena cava bypasses pulmonary circulation via the ductus arteriosus, which connects the pulmonary trunk to the aorta. Postnatal circulation, right, is formed under the influence of postnatal pulmonary ventilation and the disconnection of umbilical vessels. These alterations cause a change in pressure within the circulatory system, leading to the opening of the pulmonary circulation and obliteration of the umbilical vessels and bypass structures. Blue, deoxygenated blood. Red, oxygenated blood. Pink, mixed blood. Copyright Boss. Cardiac hemodynamics in ventricular septal defect. VV. A defect in the ventricular septum leads to a left-to-right shunt, the volume of which is dependent on the size of the defect. Blood flows from the left ventricle to the right ventricle, white arrow, along the pressure gradient, 1. This leads to increased RV and LV preload, due to increased end diastolic volume, ventricular hypertrophy and dilation, double-headed white arrows, and pulmonary hypertension resulting from excessive pulmonary blood flow. 2. In end-stage disease, the pressure gradient is reversed because of Eisenmenger syndrome, shunt reversal, leading to the flow of mixed blood to the systemic circulation, white arrow, and subsequent cyanosis. 3. Blue, structures that contain deoxygenated blood. Red, structures that contain oxygenated blood. Purple, structures that contain mixed blood. Copyright Boss. Euroacyanotic congenital heart defects, 2/5. Cardiac hemodynamics in atrial septal defect. VV. An atrial septal defect causes blood to flow from the left to the right atrium, left to right shunt, white arrow, resulting in volume overload of the right atrium and ventricle. 1. As a result, there is dilation and compensatory hypertrophy, double-headed white arrows, of the right atrium and ventricle. 2. In the late stages, Eisenmenger syndrome with shunt reversal, right to left shunt, white arrow, and cyanosis can occur. 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, purple, structures that contain mixed blood. Copyright Boss. Euroacyanotic congenital heart defects, 3/5. DSIFP, electrocardiogram, ECG, LLAIGSCSIVED. Heart murmur in ventricular septal defect, mitral regurgitation, and tricuspid regurgitation. VV holosystolic murmur, often referred to as pansystolic murmur in the case of a ventricular septal defect. Copyright Boss. June 2004, 13:57 and 35 seconds. Overlay. Ventricular septal defect VV. Color Doppler echocardiography. There is a moderate defect in the mid part of the septum. The blood flow through the defect is displayed in different colors. The red mark in the trace, lower left, shows the moment during the cardiac cycle that the image was captured. This is the typical presentation of a ventricular septal defect. IVs, interventricular septum, LA, left atrium, LV, left ventricle, MV, mitral valve, RA, right atrium, RV, right ventricle, TV, tricuspid valve. Source, ventricular septal defect, Echo, Wikimedia Commons licensed under public domain. Acyanotic congenital heart defects, 5/5. Atrial septal defect VV. Transesophageal echocardiography. A defect, white arrow, located between the left atrium, LA, and right atrium, RA, can be seen on the regular ultrasound image, A. There is also an atrial septal aneurysm bulging into the left atrium just below the defect. The color Doppler ultrasound image, B, shows the blood flow through the defect. This is the typical echocardiographic appearance of the atrial septal defect. Source, Figure 1 in, Platypnea orthodoxia associated with a fenestrated atrial septal aneurysm, case report by William J. Van Gaal Dr., Majo Joseph Dr., Elizabeth Jones Dr., George Modelanis Dr. and Mark Horrigan Dr., Cardiovascular Ultrasound Journal, Biomed Central, licensed under CC by 2.0. Ascending aorta. Pulmonary trunk superior vena cava. At the level of the tricuspid valve. Inferior vena cava. Types of atrial septal defects. VV. A. ASD2/ostium secundum. Atrial septal defect is the impaired growth of the septum secundum or excessive resorption of the septum primum. The defect is located in the fossa ovalis, in the cranial part of the atrial septum. B. ASDI/ostium primum. Atrial septal defect is the incomplete fusion of the septum primum with the endocardial cushion, caudal part of the atrial septum, near the ventricular septum. C. Sinus venosus. ASD, rare defect. D. Coronary venosus. ASD, rare defect. Copyright Boss. Euroacyanotic congenital heart defects, 2/3. Cardiac hemodynamics in atrial septal defect. VV. An atrial septal defect causes blood to flow from the left to the right atrium, left to right shunt, white arrow, resulting in volume overload of the right atrium and ventricle. 1. As a result, there is dilation and compensatory hypertrophy, double-headed white arrows, of the right atrium and ventricle. 2. In the late stages, Eisenmenger syndrome with shunt reversal, right to left shunt, white arrow, and cyanosis can occur. 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, purple, Structures that contain mixed blood. Copyright Boss. Acyanotic congenital heart defects, 3/3. Atrial septal defect VV. Transesophageal echocardiography A defect, white arrow, located between the left atrium, LA, and right atrium, RA, can be seen on the regular ultrasound image, A. There is also an atrial septal aneurysm bulging into the left atrium just below the defect. The color Doppler ultrasound image, B, shows the blood flow through the defect. This is the typical echocardiographic appearance of the atrial septal defect. Source, Figure 1 in, Platypnea orthodoxia associated with a fenestrated atrial septal aneurysm, case report by William J. Van Gaal Dr., Majo Joseph Dr., Elizabeth Jones Dr., George Modelanis Dr. and Mark Horrigan Dr., Cardiovascular Ultrasound Journal, Biomed Central, licensed under CC by 2.0. Cardiac hemodynamics in ventricular septal defect VV. A defect in the ventricular septum leads to a left-to-right shunt, the volume of which is dependent on the size of the defect. Blood flows from the left ventricle to the right ventricle, white arrow, along the pressure gradient, 1. This leads to increased RV and LV preload, due to increased end diastolic volume, ventricular hypertrophy and dilation, double-headed white arrows, and pulmonary hypertension resulting from excessive pulmonary blood flow, 2. In end-stage disease, the pressure gradient is reversed because of Eisenmenger syndrome, shunt reversal, leading to the flow of mixed blood to the systemic circulation, white arrow, and subsequent cyanosis, 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, purple, structures that contain mixed blood. Copyright Boss. Euro__acyanotic congenital heart defects, 2/3. In EPSX electrocardiogram, ECG, what LS152S12 Heart murmur in ventricular septal defect, mitral regurgitation, and tricuspid regurgitation VV holosystolic murmur, often referred to as pansystolic murmur in the case of a ventricular septal defect. Copyright Boss. June 2004, 13:57 and 35 seconds. Overlay. Ventricular septal defect VV. Color Doppler echocardiography. There is a moderate defect in the mid-part of the septum. The blood flow through the defect is displayed in different colors. The red mark in the trace, lower left, shows the moment during the cardiac cycle that the image was captured. This is the typical presentation of a ventricular septal defect. IVs, interventricular septum, LA, left atrium, LV, left ventricle, MV, mitral valve, RA, right atrium, RV, right ventricle, TV, tricuspid valve source, ventricular septal defect, echo, Wikimedia Commons licensed under public domain. Acyanotic congenital heart defects, 1/1. Copyright. Overlay. Patent foramen ovale VV. Echocardiography, transesophageal, with color Doppler, bicable view, color Doppler reveals a left-right shunt, red arrow, across a patent foramen ovale. LA, left atrium, RA, right atrium, PFO, patent foramen ovale source, figure 2a, in, recurrent arterial ischemic strokes in a patient with patent foramen ovale and ductus arteriosus, presentation of our management and review of the literature by D. Panagopoulos, S. Lakopoulou, E. Karanagios et al., Global Cardiology Science and Practice, licensed under CC by 4.0. Euroacyanotic congenital heart defects, 1/3. Cardiac hemodynamics in patent ductus arteriosus VV. In patent ductus arteriosus, there is a left-to-right shunt, with blood flowing from the aorta to the pulmonary arteries during both systole and diastole, 1. This shunt leads to volume overload, recirculation, of the blood within the pulmonary vessels, the left atrium, and left ventricle, too. Eventually, because of the increased blood flow to the pulmonary circulation, pulmonary hypertension may develop as well as Eisenmenger syndrome, which involves a shunt reversal. The left-to-right shunt without cyanosis becomes a right-to-left shunt with cyanosis. 3. Blue, structures that contain deoxygenated blood, red, structures that contain oxygenated blood, pink, structures that contain mixed blood. Copyright Boss. Euroacyanotic congenital heart defects, 2/3. EA/ET, electrocardiogram, ECG. $1 BZA1SZ heart murmur in patent ductus arteriosus VV continuous systolic and diastolic heart murmur, machinery murmur, copyright Boss. Acyanotic congenital heart defects, 3/3. Overlay. Patent ductus arteriosus. Doppler echocardiography in a newborn. There is blood flow, indicated by red chevrons, through the blood vessel connecting the pulmonary trunk, P, and the aorta, AO. This finding is characteristic of patent ductus arteriosus, DA. Copyright Boss. Acyanotic congenital heart defects, 3/3. Overlay. Patent ductus arteriosus VV. Doppler echocardiography in a newborn. There is blood flow, indicated by red chevrons, through the blood vessel connecting the pulmonary trunk, P, and the aorta, AO. This finding is characteristic of patent ductus arteriosus, DA. Copyright Boss. Euroacyanotic congenital heart defects, 1/3. TBP. Obliterated ductus arteriosus. Obliterated/ductus arteriosus. Coarctation of the aorta VV. 1. Stenosis distal to the left subclavian artery results in hypertension, TBP, in the upper extremities and the head, and hypotension, JBP, in the lower extremities and abdomen. 2. If coarctation involves the origin of the left subclavian artery, BP in the right arm and head will be higher than in the left arm, lower extremities, and abdomen. Copyright Boss. Euro__acyanotic congenital heart defects, 2/3. Copyright. Overlay. Coarctation of the aorta VV. X-ray chest, PA view. Focal indentation of the distal aortic arch is seen at the location of aortic coarctation, illustration. An additional finding is inferior rib notching, Roessler sign, examples indicated by arrowheads, which is produced by dilated intercostal arteries. The figure 3 sign of coarctation, indicated by red line, is seen in this patient. It is produced by prestenotic dilatation of the aortic arch and left subclavian artery in combination with poststenotic dilatation of the descending aorta. The presence of bilateral rib notching indicates that the coarctation is distal to the origin of both subclavian arteries. Source: Aortic coarctation chest X-ray by Gibson C.M., Singh P., Zorkin C., ETAL, Wikidoc, licensed under CC by SA 3.0. Modifications: image enlarged. Overlay. Coarctation of the aorta VV. X-ray chest, PA view. Focal indentation of the distal aortic arch is seen at the location of aortic coarctation, illustration. An additional finding is inferior rib notching, Roessler sign, examples indicated by arrowheads, which is produced by dilated intercostal arteries. The figure 3 sign of coarctation, indicated by red line, is seen in this patient. It is produced by prestenotic dilatation of the aortic arch and left subclavian artery in combination with poststenotic dilatation of the descending aorta. The presence of bilateral rib notching indicates that the coarctation is distal to the origin of both subclavian arteries. Source: Aortic coarctation chest X-ray by Gibson C.M., Singh P., Zorkin C. ETAL, Wikidoc, licensed under CC by SA 3.0. Modifications, image enlarged. Rib notching in coarctation of the aorta. Chest radiograph, PA view, there is mild cardiomegaly with a cardiothoracic ratio 50%, and bilateral rib notching is visible on the inferior border of the ribs, white arrows. These features indicate coarctation of the aorta. Source, Figure 1, in, two-stage hybrid approach for complex aortic coarctation repair by F. Stratios Kolitsis, Stella Economides, Nikolaos Panagopoulos et al., Journal of Cardiothoracic Surgery, licensed under CC by 2.0. Digital clubbing VV. The fingers show symptoms of gross clubbing. The distal end of the finger is thickened, with increased convexity of the nail. Fold. Source, Akapaquia by Disharinka, Wikimedia Commons, licensed under CC by SA 4.0. X. Congenital diaphragmatic hernias. A diaphragmatic hernia is the protrusion of intra-abdominal contents through an abnormal opening in the diaphragm. Congenital diaphragmatic hernias, CDH, are a common developmental defect, resulting from an incomplete fusion of embryonic components of the diaphragm. Left-sided posterolateral diaphragmatic defects, Bogdalic hernias, are the most common, followed by anterior defects, Morgagni hernias. About 50% of babies with CDH have additional congenital malformations. CDH are often diagnosed prenatally on routine antenatal ultrasound. Neonates with CDH present postnatally with respiratory distress and a characteristic absence of breath sounds in the ipsilateral chest. The respiratory distress is due to severe pulmonary hypoplasia, persistent pulmonary hypertension of the newborn, PPHN, and poor surfactant production, all of which are typical characteristics of CDH. Postnatal diagnosis is confirmed on a chest X-ray which reveals abdominal contents in the thorax. Neonates with CDH should be medically stabilized, mechanical ventilation, inotropic support, gastric decompression, before surgical repair, which is then done within the first week of life. Also see our article Acquired Diaphragmatic Hernias. Co. CE. Epidemiology. Cent incidence, 1 in 3,000 live births. Epidemiological data refers to the U.S., unless otherwise specified. WA. CE. Embryology of the diaphragm. Cent. The diaphragm consists of two parts, 1O the peripheral muscular part, made up of radial muscle fibers, OA central tendinous part, a flat aponeurosis into which the peripheral muscle fibers converge and insert E. Embryologically, the diaphragm is derived from 4 embryonic structures. 2O septum transversum equals forms at 4 weeks of gestation as an incomplete diaphragm centrally separating the pleural and peritoneal cavities equals develops into the central tendon of the diaphragm. O pleuroperitoneal membranes equals at the 5 week of gestation, pleuroperitoneal membranes form lateral to the central tendon, on either side. Equals they fuse with the septum transversum and the mesentery of the esophagus to complete the partition between the pleural and peritoneal cavities. Equals the left side fuses later, possibly explaining why most CDH are left-sided. O dorsal mesentery of the esophagus, develops into the diaphragmatic crura. O mesoderm of the body wall, forms the peripheral rim of the diaphragm. WARO, IEEE. Etiology. Cent. Impaired development and/or fusion of embryonic structures, pleuroperitoneal membrane, defect in the diaphragm persists during fetal development. Displacement of abdominal contents into the pleural cavity. Compression of lung tissue, pulmonary hypoplasia. Types O. Failure of fusion of the septum transversum posterolaterally with the pleuroperitoneal membranes. Bogdalic hernia. Equals most common CDH, accounting for 90% of cases. Equals posterolateral, lumbocostal, CDH, 85% are left-sided, O failure of fusion of the septum transversum anteriorly with the sternum and ribs. Morgagni hernia, Morganellari hernia, equals rare. And because the liver protects the right hemidiaphragm, diaphragmatic hernias most commonly occur on the left side. I.e. Y2 was 3-4. OOV. Back collapse. Fine text outline. Clinical features. SENT presentation depends on the degree of pulmonary hypoplasia and pulmonary hypertension plus respiratory distress, example nasal flaring, tachypnea, cyanosis, intercostal retractions, grunting, one barrel-shaped chest, scaphoid abdomen, concave anterior abdominal wall, and auscultation of bowel sounds in the chest. OA, absent breath sounds on the ipsilateral side, mediastinal shift of heart sounds / apex beat to the right side *, possible syndromic dysmorphism, example craniofacial, spinal dysraphism, cardiac. And diagnostics. Plus antenatal ultrasound, *, most cases are diagnosed on routine antenatal ultrasound. O fluid-filled stomach / bowel seen in the thorax. Copyright peristalsis may also be noted in the chest, confirming the diagnosis. O esophageal compression can cause polyhydramnios. O hydrops fetalis may also be seen in severe cases. Chest X-ray. Copyright abdominal contents, air / fluid-filled bowel, and poorly aerated lung in the ipsilateral hemithorax. Mediastinal shift to the right and compression of the contralateral lung. O in doubtful cases, a nasogastric tube is inserted and a chest radiograph is taken. The feeding tube will be seen in the thorax. In right-sided CDH, the liver appears as an intrathoracic soft tissue mass plus absence of the normal intra-abdominal liver shadow. Registered avoid pleurocentesis in a suspected diaphragmatic hernia because of the risk of bowel perforation, which is suggested by bile in the chest tube. Go. OE shared note. Differential diagnoses. SENT prenatal CDH, copyright congenital diaphragmatic eventration, not a true hernia, but rather an outpouching or abnormal elevation of a portion of the hemidiaphragm, no break in diaphragmatic tissue. EC bronchogenic cysts equals definition, a congenital malformation of the lungs that arises during embryonic development. The cysts may be intrapulmonary or located within the mediastinum. Equals pathogenesis, abnormal budding of the ventral foregut, dilation of the terminal or large bronchi, unilateral or bilateral unilocular cysts. Equals clinical features. Equals usually asymptomatic. Equals in some cases, failure to drain can cause airway compression with significant respiratory distress or recurrent respiratory tract infections. Equals diagnostics. Equals chest X-ray, discrete, round, and sharply defined fluid-filled densities, infection indicated by air inclusions. Copyright congenital pulmonary airway malformation, CPAM, 6, equals previously known as congenital cystic adenomatoid malformation, CCAM. Equals features cystic and / or adenomatous pulmonary lesions. Equals diagnosed via prenatal ultrasound. Equals management involves steroids and drainage and / or surgical removal of cysts. Copyright pulmonary agenesis - copyright tumors in the anterior / posterior mediastinum, example teratoma, neurofibroma, pheochromocytoma, neuroblastoma, etc. Eopulmonary sequestration, lung tissue that is not connected to the tracheobronchial tree plus postnatal CDH. Copyright other causes of pulmonary hypoplasia, example oligohydramnios, renal hypoplasia. Copyright other causes of pulmonary hypertension of the newborn, example meconium aspiration. Back collapse. Fine text outline. Congenital diaphragmatic hernias. Differential diagnoses. * prenatal CDH, copyright congenital diaphragmatic eventration, not a true hernia, but rather an outpouching or abnormal elevation of a portion of the hemidiaphragm, no break in diaphragmatic tissue. O bronchogenic cysts equals definition, a congenital malformation of the lungs that arises during embryonic development. The cysts may be intrapulmonary or located within the mediastinum. Pathogenesis, abnormal budding of the ventral foregut, dilation of the terminal or large bronchi, unilateral or bilateral unilocular cysts. Clinical features usually asymptomatic. In some cases, failure to drain can cause airway compression with significant respiratory distress or recurrent respiratory tract infections. Diagnostics chest X-ray, discrete, round, and sharply defined fluid-filled densities, infection indicated by air inclusions. Congenital pulmonary airway malformation, CPAM, 6, previously known as congenital cystic adenomatoid malformation, CCAM. Features cystic and or adenomatous pulmonary lesions. Diagnosed via prenatal ultrasound. Management involves steroids and drainage and or surgical removal of cysts. Pulmonary agenesis copyright tumors in the anterior posterior mediastinum, example teratoma, neurofibroma, pheochromocytoma, neuroblastoma, etc. Pulmonary sequestration, lung tissue that is not connected to the tracheobronchial tree. Postnatal CDHO. Other causes of pulmonary hypoplasia, example oligohydramnios, renal hypoplasia. Other causes of pulmonary hypertension of the newborn, example meconium aspiration. N. The differential diagnoses listed here are not exhaustive. RO, IEEE. Treatment. Plus prenatally diagnosed CDH, antenatal glucocorticoids. Postnatal therapy. Copyright initial medical resuscitation equals correction of hypoxia, intubation and mechanical ventilation, indicated in all infants with CDH. Extracorporeal life support, ECLS, a heart-lung bypass pump that circulates the infant's blood through an artificial lung and then back into the bloodstream. Indicated in infants who do not improve on mechanical ventilation / have persistent hypoxia or acidosis. Contraindicated in infants with large / expanding intracranial hemorrhages, as ECLS requires anticoagulation. Gastric decompression, insertion of a nasogastric tube and continuous suction. Inotropic support may be required to maintain blood pressure. Surfactant administration, in infants born. Timing, after the infant is stabilized, often after 24 to 48 hours. 1. Procedure, reduction of the hernial contents and primary closure of the defect. OOFA, RO. Complications. Bowel complications, obstruction, strangulation, incarceration, ileus, ulceration, perforation. 1. Back collapse. Fine text outline. Congenital diaphragmatic hernias, 1/1. Congenital diaphragmatic hernias. Diaphragm, cranial view. Lumbocostal triangle. Bogdalic hernia. Central tendon. Central diaphragmatic hernia. Sternocostal triangle, right, Morgagni hernia. Larry hernia. Illustration of the locations of congenital diaphragmatic hernias, a common developmental anomaly that is characterized by protrusion of intra-abdominal contents through an abnormal opening in the diaphragm. Congenital diaphragmatic hernias most commonly emerge along the closure lines of the different embryological diaphragmatic parts. Copyright Boss. Congenital diaphragmatic hernias, 1/2. Overlay. Right diaphragmatic hernia with enterothorax VV. Chest X-ray, PA view, of a female newborn. Multiple loops of bowel, green overlay, can be seen within the right hemithorax. Hypoplasia of the right lung and mediastinal shift to the left is also visible. These findings are characteristic of a right diaphragmatic hernia with enterothorax. Source, copyright IMPP. Congenital diaphragmatic hernias, 1/2. Overlay. Right diaphragmatic hernia with enterothorax VV. Chest X-ray, PA view, of a female newborn. Multiple loops of bowel, green overlay, can be seen within the right hemithorax. Hypoplasia of the right lung and mediastinal shift to the left is also visible. These findings are characteristic of a right diaphragmatic hernia with enterothorax. Source: Copyright IMPP. Urocongenital diaphragmatic hernias, 2 halves. Overlay. Left-sided congenital diaphragmatic hernia. Chest X-ray, PA view, in a newborn. Mediastinal shift to the right, solid line, mediastinal border in this patient, dashed line, approximate physiologic position, bowel loops within the left thoracic cavity, green marking, and a poorly aerated lung in the left hemithorax. This image was created by Omboss and is licensed under CC by SA 3.0. It is based on the image Congenitals Wurchfell hernia links, row AP001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital diaphragmatic hernias, 2 halves. Copyright overlay. Left-sided congenital diaphragmatic hernia chest X-ray, PA view, in a newborn. Mediastinal shift to the right, solid line, mediastinal border in this patient, dashed line, approximate physiologic position, bowel loops within the left thoracic cavity, green marking, and a poorly aerated lung in the left hemithorax. This image was created by Omboss and is licensed under CC by SA 3.0. It is based on the image Congenitals Wurchfell hernia links, row AP001 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital diaphragmatic hernias, 1/1. Overlay. Bronchogenic cyst VV. Photomicrograph of a mediastinal cyst cross-section specimen, H&E stain, 450x magnification. The lumen is lined by ciliated epithelium, green overlay, examples of cilia indicated by arrowheads, and layers of smooth muscle, yellow overlay, are visible, resembling upper airway tissue. Also, normal adipose tissue, examples of adipocytes indicated by black dashed outlines, can be found in the periphery. The typical location, suprasternal, behind the manubrium, middle mediastinum, paired with the described histologic appearance indicates a bronchogenic cyst. Source: Bronchogenic cyst high mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Urocongenital diaphragmatic hernias, 1/1. Overlay. Bronchogenic cyst VV. Photomicrograph of a mediastinal cyst cross-section specimen, H&E stain, 450x magnification. The lumen is lined by ciliated epithelium, green overlay, examples of cilia indicated by arrowheads, and layers of smooth muscle, yellow overlay, are visible, resembling upper airway tissue. Also, normal adipose tissue, examples of adipocytes indicated by black dashed outlines, can be found in the periphery. The typical location, suprasternal, behind the manubrium, middle mediastinum, paired with the described histologic appearance indicates a bronchogenic cyst. Source: Bronchogenic cyst high mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. X. Airway malatias. Airway malatias are a group of conditions characterized by softening or weakening of the airway cartilage resulting in increased collapsibility of the larynx, trachea, and/or bronchi, which can cause respiratory symptoms. Laryngomalacia refers to the congenital weakening of the laryngeal cartilage and is the most common type of airway malacia. Tracheomalacia refers to the weakening of the tracheal cartilage or posterior membrane and can be congenital, often in association with other congenital syndromes, or acquired. Visualization of the airway, example laryngoscopy, bronchoscopy, is the test of choice to diagnose airway malatias. Management of asymptomatic patients or patients with mild symptoms is conservative. Patients with severe symptoms generally require surgery. WA. OROS. Laryngomalacia. Definition. SENT collapse of supraglottic structures during inspiration due to anatomical and/or functional abnormalities. Epidemiology. Most common cause of congenital stridor, cause of stridor in 45 to 75% infants, most common congenital anomaly of the larynx. Etiology. Almost always congenital. 1 SENT most likely due to an underdeveloped nervous system. Pathophysiology. SENT congenital abnormality of laryngeal cartilage. T laxity and collapse of supraglottic structures during inspiration. Airway obstruction. Clinical features. Symptoms typically begin within the first 2 months of life and peak at 6 to 8 months. Inspiratory stridor worsens in the supine position, during crying, upper respiratory tract infections, agitation, and feeding difficulties, example regurgitation, emesis. 1 Approximate 60% of affected children have concomitant GERD-2 SENT severe course, failure to thrive, obstructive sleep apnea, cyanosis. Diagnostics. SENT flexible laryngoscopy, gold standard, copyright direct visualization of the airway. Copyright collapse of supraglottic structures during inspiration and an omega-shaped epiglottis. Copyright clinical correlation is required to establish a diagnosis of laryngomalacia. Treatment. Reassurance and monitoring in mild cases, approximate 90% of cases resolved by 2 years of age. Acid suppression therapy, e.g., PPI, histamine receptor blockers, for patients with symptoms of GERD. Copyright speech and swallow therapy. Ensure appropriate weight gain. SENT supraglottoplasty in severe cases. Tracheomalacia. 4. Definition. A structural abnormality involving softening or weakening of the tracheal cartilage and/or posterior membrane that results in excessive tracheal collapsibility. When the bronchi are also affected, the condition is called tracheobronchomalacia. Isolated bronchomalacia is extremely rare. Epidemiology. 41. Most common congenital tracheal abnormality, incidence, approximate 1 in 2,100 live births. Back collapse. Fine text outline. Epidemiology. 41. Most common congenital tracheal abnormality, incidence, approximate 1 in 2,100 live births. Acquired form is more common than congenital one. Etiology. SENT congenital, primary, copyright idiopathic. Copyright cartilage abnormalities, example polychondritis, Ehlers-Danlos syndrome, underdeveloped respiratory tract, example prematurity, bronchopulmonary dysplasia, associated with congenital syndromes, example trisomy 21, and/or birth defects, example tracheoesophageal fistula, SENT acquired, secondary, copyright tracheal trauma, example prolonged intubation, tracheotomy, chest trauma, copyright airway inflammation, example chronic infections, tracheobronchitis, external compression, example vascular abnormalities, tumors. Pathophysiology. SENT structural weakness of the tracheal cartilage and/or posterior membrane. Excessive collapsibility of the trachea during expiration, due to T intrathoracic pressure, equals airway obstruction. 1 Clinical features. SENT clinical findings differ between infants and adults regardless of the etiology, i.e., congenital or acquired. Symptoms may be exacerbated by increased intrathoracic pressure or respiratory effort, example Valsalva maneuvers, forced expiration, crying, coughing, and respiratory infections. The intrathoracic trachea is most frequently affected, extrathoracic and cervical tracheomalacia are rare. SENT in pediatric patients, symptoms usually appear during the first 2 to 3 months of age. Children. Expiratory stridor / barking, cough, noisy breathing, wheezing, cyanosis, respiratory distress, spontaneous hyperextension of the neck. Adults, plus dyspnea, SENT cough, SENT increased sputum production, SENT hemoptysis. Diagnostics. Scent diagnostic tests. Bronchoscopy, gold standard, equals flexible bronchoscopy is preferred, equals direct visualization of the airway, equals decrease in airway lumen size and loss of semicircular shape. Dynamic airway CT scan, tracheal narrowing. Scent additional tests. Copyright chest X-ray, may show underlying abnormalities, example structural compression. Pulmonary function tests, obstructive pattern. X treatment. Asymptomatic or mild tracheomalacia, observation and reassurance. Scent symptomatic tracheomalacia. Treat underlying causes, example airway inflammation and coexisting conditions, example COPD. Copyright supportive care, example ipratropium bromide, respiratory physiotherapy. Copyright continuous positive pressure ventilation, if conservative measures fail. Copyright tracheal stenting. 1. Copyright surgical repair, example tracheobronchoplasty. Back collapse. Find text outline. X airway malicious. Clinical features. Asterisk. Clinical findings differ between infants and adults regardless of the etiology, i.e., congenital or acquired. Symptoms may be exacerbated by increased intrathoracic pressure or respiratory effort, example Valsalva maneuvers, forced expiration, crying, coughing, and respiratory infections. Scent. The intrathoracic trachea is most frequently affected, extrathoracic and cervical tracheomalacia are rare. Scent. In pediatric patients, symptoms usually appear during the first 2 to 3 months of age. Children. Expiratory stridor, barking, cough, noisy breathing, wheezing, cyanosis, respiratory distress, spontaneous hyperextension of the neck. Adults. Scent dyspnea, scent cough, increased sputum production, scent hemoptysis. Diagnostics. Scent diagnostic tests. Bronchoscopy, gold standard, flexible bronchoscopy is preferred, equals direct visualization of the airway, equals decrease in airway lumen size and loss of semicircular shape. Dynamic airway CT scan, tracheal narrowing. Scent additional tests. Copyright chest X-ray, may show underlying abnormalities, example structural compression. Pulmonary function tests, obstructive pattern. X treatment. Scent asymptomatic or mild tracheomalacia, observation and reassurance. Scent symptomatic tracheomalacia. Copyright treat underlying causes, example airway inflammation and coexisting conditions, example COPD. Copyright supportive care, example ipratropium bromide, respiratory physiotherapy. Copyright continuous positive pressure ventilation, if conservative measures fail. Copyright tracheal stenting. 1. Copyright surgical repair, example tracheobronchoplasty. WA+. OES. Differential diagnoses. Subglottic stenosis, epiglottitis, vocal cord paralysis, bronchiolitis, asthma, cystic fibrosis, foreign body aspiration, scent GERD. The differential diagnoses listed here are not exhaustive. Back collapse. Find text outline. Omega-shaped epiglottis laryngoscopy. I.e. equals E+. During inspiration, the lateral folds of the epiglottis curl inward, creating an omega shape. This finding may be a normal variation but is more frequently seen in laryngomalacia. Clinical correlation is required to establish a diagnosis of laryngomalacia. Source: Copyright IMPP. Yule DP1E, equals at. Try again. Tracheomalacia VV. Bronchoscopic image of the trachea during expiration. Collapse of the tracheal cartilage in tracheomalacia results in the narrowing of the tracheal lumen and loss of its semicircular shape. Source: Fig 5, in Airway Problems in Neonates, a review of the current investigation and management strategies by Mach Q, Frontiers, licensed under CC by 4.0. X. Esophageal atresia. Esophageal atresia is a congenital defect in which the upper esophagus is not connected to the lower esophagus, ending blindly instead. It is caused by the abnormal development of the tracheoesophageal septum. Esophageal atresia with a fistula connected distally to the trachea is the most common kind of esophageal malformation, classified as gross type C. It manifests immediately after birth with cyanotic attacks, foaming at the mouth, and coughing, and prevents any attempts to pass a feeding tube into the stomach. X-ray is mandatory for classifying the atresia and should show an air-filled pouch situated at the level of the third thoracic vertebra. Infants with suspected esophageal atresia cannot be fed orally because of the risk of aspiration pneumonia. Curative surgery must, therefore, be performed within the first 24 hours after birth. WA OE Overview. Type A. Esophageal atresia description without tracheoesophageal fistula. Epidemiology *8% of cases. Polyhydramnios excessive clinical secretion / foaming at features the mouth copyright choking, drooling copyright inability to feed. Scent gasless abdomen ali findings scent esophageal pouch. I.e., AOA. References, 2IL5. OO. CE. Epidemiology. Overview of types of esophageal atresia. SS Type B esophageal atresia with tracheoesophageal fistula connected to the proximal esophageal segment. 1% of cases. Polyhydramnios. Copyright choking, drooling copyright inability to feed aspiration pneumonia copyright coughing spells degree rouse copyright cyanotic attacks. Scent incidence, approximate 1:4,300 live births in the U.S. 4. Epidemiological data refers to the U.S., unless otherwise specified. WI OE Pathophysiology. Type C scent esophageal atresia with tracheoesophageal fistula connected to the distal esophageal segment. Asterisk 87% of cases. At the mouth. Scent large gastric bubble esophageal pouch. Type D esophageal atresia with tracheoesophageal fistula connected to the proximal and distal esophageal segments. Asterisk 1% of cases. A wedge of mesoderm called the tracheoesophageal septum separates the developing foregut, esophagus, from the trachea. Esophageal atresia and tracheoesophageal fistula are caused by a defect in mesodermal differentiation. About 50% of cases are associated with other mesodermal defects, bacterial association, 2O vertebral anomaly copyright anal atresia EO cardiac anomaly copyright tracheoesophageal fistula O esophageal atresia O renal anomaly copyright limb malformation. References 5. Back. We collapse. A. Find text. Type E. H-type tracheoesophageal fistula without atresia. 4% of cases. Aspiration pneumonia degree coughing spells arouse cyanotic attacks respiratory distress 1. Large gastric bubble. O. Outline. Clinical features. Overview of clinical features of types of esophageal atresia. Type A, Type B, Type C, Type D, Type E. Polyhydramnios FFVVVVV% excessive secretions VVVVV equals aspiration pneumonia RVVVVV gastric distension I, VVVV. Esophageal atresia. Scent definition, a congenital defect in which the upper esophagus is not connected to the lower esophagus and ends blindly. Instead, scent prenatal features EO polyhydramnios equals the fetus is unable to swallow amniotic fluid. Equals occurs in approximate 57% of pregnancies. 6 copyright associated with an increased risk of premature birth. 22726 scent postnatal features O pooling of secretions excessive secretions / foaming at the mouth. 2 equals choking. Drooling equals inability to feed equals vomiting tracheoesophageal fistula. Scent definition, an abnormal connection between the trachea and esophagus that may be connected to the proximal and/or distal esophageal segment sent postnatal features copyright aspiration and subsequent aspiration pneumonia, especially if the fistula is connected to the proximal esophageal segment, equals coughing spells, equals rales equals cyanotic attacks due to reflex laryngospasms that prevent reflux aspiration. If the fistula is connected to the distal esophageal segment, gastric distension SLL. Newborns usually present with symptoms directly after birth. The exception is gross type E fistula, in which the diagnosis of a small H-type tracheoesophageal fistula may occur as late as adulthood. WA. OE. Diagnostics. Placement of a feeding tube. The feeding tube cannot pass through the esophagus in the case of esophageal atresia. 2E X-ray of the thorax/abdomen, 2O esophageal pouch, except with an H-type fistula, O large gastric bubble, air in the stomach, gross types A and B present with a gasless abdomen, sent further diagnostics concerning bacterial anomalies. O ultrasound of the abdomen. OE echocardiography. OO. E. Differential diagnoses. Double aortic arch. Sent definition, an embryonic malformation resulting in a double aortic arch, vascular ring anomaly, with subsequent constriction of the trachea and esophagus. A sent etiology, associated with Charge syndrome, DiGeorge syndrome, trisomy 21 pathophysiology. Copyright the right and left pharyngeal arch arteries persist postnatally. Formation of a vascular ring, double aortic arch, constriction of the trachea and esophagus. O feeding equals 7 constriction of the trachea, exacerbation of respiratory symptoms. Back collapse. Fine text outline. Sent clinical features * copyright typically manifests within the first weeks of life, especially in cases of tracheal compression - copyright tracheal constriction, inspiratory and expiratory stridor, dyspnea, respiratory arrest equals acute episodes of severe constriction and/or apnea with cyanosis may occur, can be life-threatening, equals hyperextension of the head to improve airflow. O esophageal constriction, dysphagia, choking, retching, vomiting, failure to thrive. Sent diagnostics. Copyright chest X-ray. Anteroposterior and lateral shows anterior tracheal bowing and narrowing. Degree echocardiography, to identify anomaly and associated congenital heart defects, example VSD, tetralogy of Fallot, PDA, copyright chest CTA or MRA, to visualize the extent of compression and the relationship of the trachea, esophagus, and vessels preoperatively. Sent treatment, surgical division of the minor arch. 9. Differential diagnoses of newborn swallowing disorders. F2I10 differential diagnosis findings: excessive secretion / foaming at the mouth, coughing spells, cyanotic attacks, esophageal atresia. Excessive secretion status post C-section, a reversible condition, as opposed to esophageal atresia. Cyanotic attacks, choanal atresia, attacks normalize after crying or opening the mouth. Delayed diagnosis, after introduction of solid food, dysphagia, regurgitation, esophageal stenosis. Very rare during childhood. Delayed diagnosis, after introduction of solid food, dysphagia, regurgitation, achalasia. Central nervous system disorders, defective swallowing reflex, peripheral neuromuscular disorders. The differential diagnoses listed here are not exhaustive. WA. OOXE. Treatment. Preoperative. Placement of an oroesophageal or nasoesophageal tube for continuous suction of secretions to prevent aspiration and facilitate breathing. 3-2 upper body elevated, left lateral decubitus position. 3 antibiotics in case of aspiration pneumonia. 7. At infants who potentially have esophageal atresia should not be fed orally under any circumstances. Surgery. Surgical treatment should be performed within the first 24 hours of birth. The goal is to reconnect the upper esophageal pouch and the lower esophagus. 3. A long gap between both ends of the esophagus may not allow primary repair. 2. Copyright. In this case, a gastrostomy tube is necessary to allow enteral feeding. Copyright treatment options include promoting elongation of the esophagus, via the Fokker technique, and colon interposition postoperative. Uncomplicated surgery, transition to a normal diet after 2 to 3 days. 3. Anastomosis under tension, postoperative ventilation, for approximate 5 days, 1 cent radiological examination with a contrast agent, esophagram, 1 week after surgery to identify complications, example esophageal stricture or anastomotic leak to approximate 4 weeks after the procedure, gastroscopy, EGD, and dilation of the anastomosis may be necessary. Back collapse. Find text outline. X. Esophageal atresia. Differential D of newborn. G. Disorders. Differential diagnosis. Findings: excessive secretion/foaming at the mouth, coughing spells, cyanotic attacks. Esophageal atresia. Excessive secretions - status post C-section, reversible condition, as opposed to esophageal atresia. Cyanotic attacks. Choanal atresia, attacks normalize after crying or opening the mouth. Delayed diagnosis, after introduction of solid food, dysphagia, regurgitation. Esophageal stenosis. Very rare during childhood. Delayed diagnosis, after introduction of solid food, dysphagia, regurgitation. Achalasia. Central nervous system disorders. Defective swallowing reflex, peripheral neuromuscular disorders. The differential diagnoses listed here are not exhaustive. Why? A. Treatment. Preoperative. Placement of an oroesophageal or nasoesophageal tube for continuous suction of secretions to prevent aspiration and facilitate breathing. 3. 2. E. Upper body elevated, left lateral decubitus position. 3 plus antibiotics in case of aspiration pneumonia. 7. At. Infants who potentially have esophageal atresia should not be fed orally under any circumstances. Surgery. Surgical treatment should be performed within the first 24 hours of birth. Cent. The goal is to reconnect the upper esophageal pouch and the lower esophagus. 3 cent. A long gap between both ends of the esophagus may not allow primary repair. 2. Copyright. In this case, a gastrostomy tube is necessary to allow enteral feeding. Copyright treatment options include promoting elongation of the esophagus, via the Fokker technique, and colon interposition postoperative. Uncomplicated surgery, transition to a normal diet after 2 to 3 days. 3. Anastomosis under tension, postoperative ventilation, for approximate 5 days, cent. Radiological examination with a contrast agent, esophagram, 1 week after surgery to identify complications, example esophageal stricture or anastomotic leak. 2. Approximate 4 weeks after the procedure, gastroscopy, EGD, and dilation of the anastomosis may be necessary. O. Prognosis. Overall good prognosis, but surgical complications occur frequently: dysphagia, gastroesophageal reflux disease, anastomotic stenosis, wheezing, infections of the respiratory tract, anastomotic insufficiency, recurrence of esophageal tracheal fistula, esophageal stricture. The overall survival of esophageal atresia is good, 85%, but decreases when other associated anomalies are present, example cardiac anomalies. 11. Back collapse. Find text outline. Esophageal atresia, 1/1. Gross type A MN. A. Gasless stomach. Normal anatomy. \C gastric bubble equals. Yeah, large gastric bubble. Gross classification of esophageal atresia VV. Gross type A, esophageal atresia without tracheoesophageal fistula. Gross type B, esophageal atresia with an upper tracheoesophageal fistula. Gross type C, esophageal atresia with a lower tracheoesophageal fistula. Gross type D, esophageal atresia with upper and lower tracheoesophageal fistula gross type E, tracheoesophageal fistula without atresia copyright Boss. Uroesophageal atresia, 1/3. Esophageal atresia gross type C, void 3b, VV. An X-ray of the thorax and abdomen of a newborn shows a nasogastric tube coiled in the esophagus and air in the stomach, indicating an esophageal atresia with tracheoesophageal fistula to the distal esophageal segment, otherwise known as type C, or void 3b. Source: Esophagus atrophy void 3b und Hemimetamere segment Verschiebung 000 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Esophageal atresia, 2/3. Overlay. Esophageal atresia type CVV. X-ray of the thorax and abdomen of a newborn, with contrast administered via gastric tube, white hatched line. The contrast medium only fills the esophagus down to the level of vertebra Th4, which reveals that the esophagus is dilated and has a blind ending, green overlay. There are air-filled intestinal loops in the abdomen, which indicate a tracheoesophageal fistula, through which air reaches the intestine. This finding confirms the diagnosis. An endotracheal tube is also visible, red overlay. Source: Esophageal atresia contrast, DRM, Key, Wikimedia Commons licensed under public domain. Copyright. Overlay. Esophageal atresia type C. X-ray of the thorax and abdomen of a newborn, with contrast administered via gastric tube, white hatched line. The contrast medium only fills the esophagus down to the level of vertebra Th4, which reveals that the esophagus is dilated and has a blind ending, green overlay. There are air-filled intestinal loops in the abdomen, which indicate a tracheoesophageal fistula, through which air reaches the intestine. This finding confirms the diagnosis. An endotracheal tube is also visible, red overlay. Source: Esophageal atresia contrast, DRM, Key, Wikimedia Commons licensed under public domain. Esophageal atresia, 3/3. Overlay. Newborn with type C esophageal atresia VV X-ray, AP view with contrast agent filling a blind-ended esophageal pouch, green overlay, that ends at the level of the third thoracic vertebra. Inside the pouch, a nasogastric tube can be seen, dashed lines. There is abundant gas in the gastrointestinal tract, indicating patent tracheoesophageal fistula. Source: Esophagus atrophy 2 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Esophageal atresia, 3/3. Copyright overlay. Newborn with type C esophageal atresia VV X-ray, AP view with contrast agent filling a blind-ended esophageal pouch, green overlay, that ends at the level of the third thoracic vertebra. Inside the pouch, a nasogastric tube can be seen, dashed lines. There is abundant gas in the gastrointestinal tract, indicating patent tracheoesophageal fistula. Source: Esophagus atrophy 2 by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Esophageal atresia, 1/3, esophagus E__trachea. Normal. Double aortic arch ventral view of mediastinal structures. Double aortic arch. There is constriction of the trachea and esophagus as a result of the additional aortic arch, vascular ring anomaly. Copyright Boss. Double aortic arch VV. CT axial images demonstrate a double aortic arch and subsequent tracheobronchial narrowing. Source: Figure 2, a 21-month boy with double aortic arch and subsequent tracheobronchial narrowing by Wei Xiao, Zhoudong Su, Laban Wu et al. +1, licensed under CC by 4.0. Esophageal atresia, 3/3. Anatomy of the heart, aorta, trachea, and esophagus VV. Dorsal view. Copyright Boss. X. Hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis, the most common cause of gastric outlet obstruction in infants, is characterized by hypertrophy and hyperplasia of the pyloric sphincter in the first months of life. Clinical manifestations usually appear between 3 and 5 weeks of age. The primary symptom is regurgitation progressing to non-bilious, projectile vomiting, which occurs intermittently or after feeding. The infant is irritable and demonstrates a strong rooting and sucking reflex because of hunger. Constant vomiting leads to hypokalemic and hypochloremic metabolic alkalosis. The diagnosis is usually clinical and involves the detection of a palpable, olive-shaped structure in the epigastrium, a sign of marked hypertrophy of the pylorus, and visible gastric peristalsis proximal to the site of obstruction. The condition may also be diagnosed on ultrasound in the absence of a palpable, olive-shaped structure. Initial management involves adequate rehydration and correction of electrolyte imbalances. The definitive treatment is Ramstedt pyloromyotomy. WA. CE. Epidemiology. Plus incidence, 0.5-5:1000 live births, considered to be the most common cause of gastric outlet obstruction in infants. Sex, 7-5:1, more common in firstborn children. The incidence is higher in white populations. 2. Epidemiological data refers to the U.S., unless otherwise specified. WZ. Fe. IEEE. Etiology. Environmental factors. Exposure to nicotine during pregnancy. 2. Copyright bottle feeding, 1/5. Genetic factors. Patients with affected relatives have a higher risk of hypertrophic pyloric stenosis. Macrolide antibiotics erythromycin and azithromycin are associated with a higher risk of hypertrophic pyloric stenosis, especially when administered within 2 weeks after birth. Hypertrophic pyloric stenosis associated with macrolide antibiotics should be reported to the FDA. WA. CE. Clinical features. Symptoms usually develop between the 24 and 7 week of age, rarely after the 2th week. Frequent regurgitation progressing to projectile, non-bilious vomiting immediately after feeding. An enlarged, thickened, olive-shaped, non-tender pylorus, diameter of 1 to 2 centimeters, should be palpable in the epigastrium. A peristaltic wave, moving from left to right, may be evident in the epigastrium. Hungry vomiter, demands refeeding after vomiting, demonstrates a strong rooting and sucking reflex, irritable if left untreated, dehydration, weight loss, failure to thrive. Diagnostics. Initial imaging, abdominal ultrasound shows an elongated and thickened pylorus. 1 cent. Alternative imaging. Barium studies = narrow pyloric orifice = string sign, elongated, thickened pylorus = beak sign. The pylorus is only partially open to the stomach because of hypertrophy, resulting in 2 muscular layers adjacent to one another in an open beak. Back collapse. Fine text outline. Endoscopy. Laboratory tests. Hypochloremic, hypokalemic metabolic alkalosis, a classic result, is now uncommon because infants are typically diagnosed and treated early. The loss of gastric hydrochloric acid from emesis results in increased bicarbonate and decreased chloride concentrations in the blood. 1. See Pathophysiology of acid-base disorders for more information. Hypokalemia usually occurs in infants that have been vomiting for many days or even weeks. Hyponatremia or hypernatremia may be present. And nowadays, hypertrophic pyloric stenosis is diagnosed early, and infants generally do not present with significant electrolyte imbalances. WA. OAO. Differential diagnoses. Condition. Hypertrophic pyloric stenosis. Midgut and gastroesophageal reflux in infants. Reflux D, in infants. Gastroenteritis. Congenital adrenal hyperplasia with salt loss. Cyclical vomiting syndrome, 4. Gastroesophageal reflux in infants 5 Relaxation. Etiology. DEL diagnosis of VB, vomiting findings. Regurgitation projectile, non-bilious vomiting no diarrhea alkalosis and hypokalemia. Bilious vomiting signs of bowel ischemia, hematochezia, hematmesis, hypotension, and tachycardia in severe cases abdominal distension. Regurgitation and/or vomiting of food shortly after feeding healthy children with normal development. Regurgitation and/or persistent vomiting of food, poor appetite, weight loss, failure to thrive, abdominal pain/discomfort, wheezing, stridor, chronic cough, hoarseness. Diarrhea, vomiting, possibly fever. Vomiting, apathy, weight loss, acidosis and hyperkalemia. Recurrent, self-limiting attacks of severe vomiting, see Rome 4 criteria for cyclical vomiting syndrome below. Epidemiology, physiologic process in infants, typically occurs shortly after feeding. Copyright esophageal sphincter, transient lower relaxation due to frequent, large volume feedings. Copyright esophagus, short length and/or supine position. Clinical features. Copyright spitting up or regurgitation shortly after feeding. Copyright normal physical examination and development, normal weight gain, no difficulty feeding. Diagnostics, clinical findings. Management. Copyright reassurance of the infant's parents. Copyright conservative measures. Maintain breastfeeding equals avoiding overfeeding equals positioning therapy. Maintain the infant in an upright position for 20 to 30 minutes after feeding equals avoid sitting. Using food thickeners equals avoid exposure to tobacco smoke. 7. Prognosis, the frequency of episodes decreases with age, usually resolves spontaneously by 12 to 18 months of age. Back. WV equals A. Collapse. Find text. Definition, the movement of stomach contents into the esophagus with or without spitting up and regurgitation due to transient lower esophageal sphincter. O. Outline. E. Prognosis. Me. Frequency of episodes decreases with age. USUAAHY Tissos spontaneously dy 127-16 monuus of age. Gastroesophageal reflux disease, GERD, 5. C. Gastroesophageal reflux disease in infants. Cyclical vomiting syndrome and LL41. Scent. Etiology, unknown, often associated with stress, example psychological stress due to parent divorce, infections, fasting, and a personal or family history of migraine headaches. Scent. Epidemiology, peak incidence 5 years of age. 8. Scent. Clinical features. O. Recurrent, self-limited attacks of severe vomiting, bilious or non-bilious, and no evidence of anatomical anomalies or underlying conditions. O. Attacks may be accompanied by severe nausea, headaches, photophobia, abdominal pain. Scent. Diagnostic criteria, Rome 4 criteria for cyclical vomiting syndrome. All 4 criteria must be fulfilled for the diagnosis of cyclical vomiting syndrome to be made. 4. Copyright each episode lasting. Copyright identify and avoid triggers, example foods such as cheese or chocolate, stress. O. Prophylactic treatment equals cyproheptadine in patients 5 years old. Copyright supportive care, example LV fluids, antiemetics. Sandover syndrome, degree 1. Scent. Definition, a paroxysmal movement disorder characterized by torticollis and arching of the spine that occurs in association with gastroesophageal reflux disease, GERD, and hiatal hernia. Scent. Epidemiology. EO unknown incidence and prevalence. O. associated with GERD in children. Scent. Clinical features. Copyright torticollis and arching of the spine, opistotonic posturing, lasting between 1-3 minutes, and often associated with ingestion of food. Copyright vomiting, poor feeding. feeding, epigastric discomfort scent diagnosis, based on clinical findings, association with GERD and a normal neurological examination, scent treatment of GERD. The differential diagnoses listed here are not exhaustive. WA. Anode-MAD. Treatment. Scent conservative measures, before surgery. Copyright correct electrolyte imbalance, example replace K**, copyright B rehydration O frequent administration of small meals, 12 to 24 per day, O elevate head scent treatment of choice, Ramstead pyloromyotomy, a longitudinal muscle splitting incision of the hypertrophic sphincter. Co. OOIAOESN. Prognosis. Very good prognosis * mortality rate. Or. Sources. Last updated June 30th, 2022. Back collapse fine text outline. Hypertrophic pyloric stenosis, 1/2. Hypertrophic pyloric stenosis B. In newborns with hypertrophic pyloric stenosis, an enlarged, thickened, olive-shaped, non-tender pylorus may be palpable in the epigastrium. The primary symptom of the condition is projectile, non-bilious vomiting immediately after feeding. Copyright Boss. Gastric folds. Pyloric sphincter muscle. Anatomy of the stomach BB. Copyright Boss. Overlay. Infantile hypertrophic pyloric stenosis. Ultrasound abdomen, pylorus, longitudinal plane, of an 8-week-old male infant. The single wall thickness of the muscular layer measures 6.5 mm, normal cutoff, 3 mm. The pyloric channel measures 17 mm, normal cutoff, 14 mm. No fluid was seen to pass through the pylorus into the duodenum during real-time evaluation when the infant was fed. The imaging findings confirmed the diagnosis of pyloric stenosis. Source, Figure 1, in infantile hypertrophic pyloric stenosis in postoperative esophageal atresia with tracheoesophageal fistula by R.A.N. Hassan, Y.U. Chu, Arnare.etal, Journal of Neonatal Surgery, licensed under CC by 4.0. Modifications, remove dots in middle of dotted line and place X to measure each side individually. X Meckel diverticulum. A Meckel diverticulum is the most common congenital anomaly of the gastrointestinal tract and is caused by an incomplete obliteration of the omphalomessenteric duct. It is generally about 2 inches long and located 2 feet proximal to the ileocecal valve. It is seen in 2% of the general population and is more common in males. The mucosal lining of the diverticulum may be either native ileal mucosa or heterotopic mucosa, most commonly gastric. It is often asymptomatic and detected incidentally on imaging or abdominal surgery. Surgery. The characteristic presentation of symptomatic Meckel diverticulum is painless lower gastrointestinal bleeding, hematochezia, in children. Long, broad-based diverticulum, should be resected. An asymptomatic Meckel diverticulum incidentally detected on imaging does not require treatment. OES. Epidemiology. Prevalence, most common congenital gastrointestinal tract anomaly, 2% of the population, 1 plus sex, 2:1, 2 plus age. OSCE. Pathophysiology. The omphalomessenteric duct, vitellin or vitellointestinal, is a patent tubular structure connecting the yolk sac to the alimentary tract in the embryo. The duct is normally obliterated by the 6 to 7 week of intrauterine life. Plus incomplete obliteration of the omphalomessenteric duct, persistence of the proximal, intestinal, segment of the duct Meckel diverticulum. WA. Or. Anatomy. Meckel diverticulum is a true diverticulum, involves all 3 layers of the small intestine, located 2 feet proximal to the ileocecal valve, on the untum's enteric side of the ileum, 3 cent usually. Q. The rule of 2s, Meckel diverticulum occurs in 2% of the population, 2% are symptomatic, mostly in children. Back collapse. Find text outline. Outline. Clinical features. Asymptomatic, almost common manifestation. Copyright detected incidentally on imaging or during surgery, laparoscopy/laparotomy, performed for an unrelated condition. Symptomatic. A lower gastrointestinal bleeding, most common feature, equals presence of ectopic gastric mucosa or pancreatic tissue acid or enzyme secretion within the diverticulum. Ileal ulceration. Bleeding equals can manifest as hematochezia. Tarry stools. 1 equals current jelly stools. Copyright abdominal pain, typically in the right lower quadrant. O nausea and vomiting. WA. OS. Diagnostics. The initial workup follows the same protocol as that for lower gastrointestinal bleeding and/or acute abdomen. Only the imaging tests specific to Meckel diverticulum are mentioned here. Imaging. Copyright indications. Hemodynamically stable patients with lower gastrointestinal bleeding equals children. Equals the sequential inflation and deflation of the two balloons help advance the scope into the intestine by pleating the bowel onto the scope. O capsule endoscopy, a diagnostic procedure using a tiny wireless camera fitted inside a capsule that is swallowed by the patient to take pictures of the mucosa as it passes through the GL tract. Equals the patient swallows the encapsulated camera equals pictures are analyzed after the capsule is excreted 24 to 48 hours later. Sent diagnostic laparoscopy. 5O Meckel diverticulum may be identified on diagnostic laparoscopy performed on hemodynamically stable patients with acute abdomen/lower gastrointestinal bleeding and negative findings using other investigations. OC anatomy above for features of Meckel diverticulum on laparoscopy. Treatment. Asymptomatic Meckel diverticulum. Copyright incidentally detected on imaging studies, no treatment necessary. Degree incidentally detected on laparotomy/laparoscopy, equals children or young adults. Surgical resection of all incidentally detected Meckel diverticula. Adults 50 years, no treatment necessary. Symptomatic or complicated Meckel diverticulum. Copyright initial stabilization of the patient. Copyright surgical resection of all symptomatic/complicated Meckel diverticula. Back collapse. Find text outline. X Meckel diverticulum. O Meckel scintigraphy scan. Meckel scan, a non-invasive nuclear medicine imaging technique using radiolabel technetium C2 trademark 2, which is preferentially one absorbed by the gastric mucosa and can identify ectopic gastric mucosa. Copyright CT angiography, may demonstrate the vitelline artery or contrast extravasation from a bleeding Meckel diverticulum. Copyright other imaging tests equals mesenteric arteriography equals tagged RBC scans, useful to detect a bleeding Meckel diverticulum. Sent new imaging techniques. See double balloon enteroscopy, an enteroscopic technique to visualize the entire small bowel. Equals a long endoscope is advanced, either through the mouth or the rectum, into the small intestine. Equals the sequential inflation and deflation of the two balloons help advance the scope into the intestine by pleating the bowel onto the scope. O capsule endoscopy, a diagnostic procedure using a tiny wireless camera fitted inside a capsule that is swallowed by the patient to take pictures of the mucosa as it passes through the GL tract. Equals the patient swallows the encapsulated camera equals pictures are analyzed after the capsule is excreted 24 to 48 hours later. Sent diagnostic laparoscopy. 5 Copyright Meckel diverticulum may be identified on diagnostic laparoscopy performed on hemodynamically stable patients with acute abdomen/lower gastrointestinal bleeding and negative findings using other investigations. Copyright see anatomy above for features of Meckel diverticulum on laparoscopy. Treatment. Plus asymptomatic Meckel diverticulum. Copyright incidentally detected on imaging studies, No treatment necessary. Copyright incidentally detected on laparotomy/laparoscopy / children or young adults. Surgical resection of all incidentally detected megaldiverticula adults. 50 years, no treatment necessary. Sent symptomatic or complicated megaldiverticulum. Initial stabilization of the patient. Copyright surgical resection of all symptomatic/complicated megaldiverticula. Surgical procedures. Copyright segmental resection, indicated for a megaldiverticulum that is bleeding, has a broad base, or a palpable abnormality. Copyright diverticulectomy, megaldiverticulum is resected at the base. 1 CS equals WA CE. Complications. Sent hemorrhage, most common. Sent bowel obstruction, usually affects terminal ileum, due to copyright intussusception. Copyright volvulus olytra hernia, incarceration of a megaldiverticulum inside a femoral hernia. Bowel perforation, peritonitis or intra-abdominal abscess infection, megaldiverticulitis. Patients present with acute right lower abdominal pain, mimicking acute appendicitis or acute mesenteric lymphadenitis. Neoplasia, rare. Copyright benign tumors, example leiomyoma, are the most common. Leiomyosarcomas, carcinoid tumors, lipomas, fibromas, and angiomas may also be found. Back collapse. Find text outline. Megaldiverticulum, 1/1. Y /OE /A. Copyright, umbilical cord 6, navel ectotelin duct at fibers cord 6, megaldiverticulum. Copyright Liam. Megaldiverticulum. The megaldiverticulum is a remnant of the omphalomesenteric duct. The omphalomesenteric duct connects the yolk sac to the alimentary tract in the embryo, left image. The duct is normally obliterated by the 6th week of intrauterine life. However, incomplete obliteration leads to the development of a diverticulum located approximate 2 feet proximal to the ileocecal valve, right image. The megaldiverticulum is often connected to the navel via a fibrous cord, which is the obliterated part of the omphalomesenteric duct, middle image. Copyright on Voss. Megaldiverticulum BV. Small intestine, gross photograph, an abnormal sac, about 6 cm large, can be seen protruding from the small intestine. It is located on the unterenteric side of the ileum, about 60 cm in front of the ileocecal valve. The megaldiverticulum involves all layers of the intestinal wall, true diverticulum. Source, megaldivertical.jpg by Millie Weiss, Wikimedia Commons, licensed under CC by SA 3.0. Euro megaldiverticulum, 1/1. 6.9 WCITC 99 and sodium pertechnate. Overlay. Megaldiverticulum BV. Nuclear medicine technetium 99M pertechnate, 99 MTC, scan, anterior view of trunk over 60 minutes interval following injection, radiotracer activity in both the stomach, indicated by yellow circle, and right lower quadrant, indicated by blue circle, shows increased intensity over time, top left to bottom right. The appearance is diagnostic of a megaldiverticulum with gastric mucosa. Source, Meckel's diverticulum by technetium 99M pertechnate scan by Jason Robert Young MD, Wikimedia Commons, licensed under CC by SA 4.0. X midgut volvulus and intestinal malrotation. Volvulus is defined as the twisting of a loop of bowel on its mesentery and is one of the most common causes of intestinal obstruction. Volvulus in a neonate or infant almost always presents as a midgut volvulus secondary to intestinal malrotation. Patients typically show features of bowel obstruction, abdominal pain, distension, bilious vomiting, or of bowel ischemia and gangrene, tachycardia, hypotension, hematochezia, peritonitis, in severe cases. Upper GL series is the investigation of choice in infants with suspected midgut volvulus, which is seen as a corkscrew duodenum. The LAD procedure, laparotomy and deposition of the volvulus, is indicated in all patients with intestinal malrotation since it is impossible to predict if volvulus of the midgut will occur in an asymptomatic patient or not. See sigmoid volvulus and cecal volvulus for more details of volvulus occurring in adults. Epidemiology. Cent incidence, symptomatic malrotation, midgut volvulus, in 1:6,000 live births in the United States *, age, neonates and infants, 1, 21. And sigmoid volvulus is more common in older individuals while midgut volvulus and malrotation are more common in minors. Epidemiological data refers to the U.S., unless otherwise specified. BA or pathophysiology. Cent normal intestinal rotation, the midgut starts to elongate in utero, 4 week, herniation of the midgut out of the umbilicus, ul week, 190 degrees counterclockwise rotation of the midgut re-entry of the midgut into the abdominal cavity, 10 week, 180 degrees rotation inside the abdominal cavity, a total of 270 degrees, LJ fixation of the duodenojejunal flexure and cecum to the posterior abdominal wall, cent intestinal malrotation, arrest in the normal rotation of the gut in utero, resulting in an abnormal orientation of the bowel and mesentery within the abdominal cavity. CC types of ionols non-rotation, incomplete rotation asterisk the entire colon is left-sided, the entire small bowel is right-sided 1 asterisk the cecum remains fixed in the RUQ by peritoneal bands, LAD bands. Asterisk the mesenteric attachment has a wider base than in incomplete rotation 1 asterisk the mesenteric base is narrow. Cent midgut volvulus, torsion of a malrotated midgut causing mechanical bowel obstruction, mostly in neonates and infants. Copyright torsion of bowel on its axis, 61 equals closed loop mechanical bowel obstruction accumulation of gas and feces within the loop increased intraliminal pressure impaired capillary perfusion of bowel strangulation, ischemia, and gangrene equals torsion of the mesenteric vascular pedicle occlusion / thrombosis of mesenteric vessels bowel strangulation, ischemia, and gangrene. Cent gastric volvulus, an abnormal rotation of the stomach of more than 180 degrees closed loop obstruction possible incarceration and strangulation intestinal ischemia and perforation. WA. CE. Risk factors. Plus intestinal bands / adhesions plus intestinal malrotation, abnormal rotation of the bowel with abnormal fixation of mesentery to the posterior abdominal wall. Cent megacolon, Hirschsprung disease, Chagas disease, anatomic disorder, example paraesophageal hernia is commonly associated with gastric volvulus. Back collapse. Find text outline. Clinical features. Malrotation, mostly asymptomatic midgut volvulus. Copyright bilious vomiting with abdominal distension in a neonate / infant. Copyright signs of bowel ischemia, hematochezia, hematmesis, hypotension, and tachycardia. Features of gastric volvulus, severe abdominal pain, retching, and inability to pass a nasogastric tube. Features of duodenal obstruction, bilious vomiting without abdominal distension. 7 variable presentation in older children / adults or recurrent episodes of abdominal pain and vomiting or failure to gain weight malabsorption. Features of associated congenital anomalies. Abdominal examination is unreliable in neonates / infants because abdominal tenderness / rebound tenderness is difficult to assess in this population. Commonly associated anomalies, congenital diaphragmatic hernia, 100%, congenital heart defects, up to 90%, omphalocele, up to 45%. Less commonly associated anomalies, gastroschisis, Meckel diverticulum, esophageal atresia, biliary atresia. ORO, IEEE. Diagnostics. Intestinal malrotation and midgut volvulus. Cent workup follows the same protocol as that for bowel obstruction. Only the specific findings seen in intestinal malrotation and midgut volvulus are mentioned here. See sigmoid volvulus and cecal volvulus for more details of volvulus occurring in adults. laboratory studies, complete blood count, electrolyte levels, arterial blood gas analysis LON and midgut volvulus intestinal malrotation upper GI series, gold in displaced duodenojejunal junction patients, 1. SLL10LY stable the small bowel is right-sided. Barium enema, lower GI series, malpositioning of the cecum, left-sided cecum, abnormal position of the superior mesenteric vessels and abdominal ultrasound, 11 bowel. CECT scan, oral and for contrast, findings similar to those seen on ultrasound. Is often normal, demonstrates bowel perforation, if present abdominal X-ray. References SIL 22131 L14 LH Slizzle, Alt 10 LL 111. WA or differential diagnoses. In neonates/infants with recurrent vomiting, duodenal atresia and stenosis, hypertrophic pyloric stenosis sent in neonates with features of bowel ischemia/gangrene, necrotizing enterocolitis, NEC, sent in older children with abdominal pain and vomiting, intussusception sent in older children/adults with nonspecific symptoms, GERD, chronic mesenteric ischemia, food allergy sent C differential diagnosis of lower gastrointestinal bleeding in children. References 6LL171B. Midgut volvulus duodenal obstruction corkscrew duodenum bird's beak sign at the side of the twist. Whirlpool sign, on color Doppler. Findings similar to those seen on ultrasound can demonstrate bowel ischemia if present _J, or perforation. Double bubble sign may be seen in patients with duodenal AO. Outline. X midgut volvulus and intestinal malrotation. Diagnostics. Intestinal malrotation and midgut volvulus. Workup follows the same protocol as that for bowel obstruction. Only the specific findings seen in intestinal malrotation and midgut volvulus are mentioned here. See sigmoid volvulus and cecal volvulus for more details of volvulus occurring in adults. SLL9E laboratory studies, complete blood count, electrolyte levels, arterial blood gas analysis, ENE and midgut volvulus intestinal malrotation upper GL series, gold INH in Arnell-Colley stable patients, LLL displaced duodenojejunal junction degree the small bowel is right-sided. Barium enema, lower GI series, malpositioning of the cecum, left-sided cecum, a tall abnormal position of the superior mesenteric vessels and abdominal ultrasound power ILJ. CECT scan, oral and for contrast, degree, findings similar to those seen on ultrasound EA. Abdominal obstruction 1. References SLLT 22131 L14 LL1 SLLSL, OLL 101111. OOROE. Differential diagnoses. OOAEAEAEA, we by Rat Mata. In neonates/infants with recurrent vomiting, duodenal atresia and stenosis sent in neonates with features of bowel ischemia/gangrene, necrotizing enterocolitis, NEC, sent in older children with abdominal pain and vomiting, intussusception sent in older children/adults with nonspecific symptoms, GERD, chronic mesenteric ischemia, food allergy sent C differential diagnosis of lower gastrointestinal bleeding in children. References 61L17 The differential diagnoses listed here are not exhaustive. VACE. Treatment. Sent midgut volvulus with/without peritonitis. Is often normal, demonstrates bowel perforation, if present. Hypertrophic pyloric stenosis. Midgut volvulus duodenal obstruction corkscrew duodenum, bird's beak sign at the side of the twist. Whirlpool sign, on color Doppler. Doppler, 5. 5. Findings similar to those seen on ultrasound can demonstrate bowel ischemia, 1, or perforation, 1, if present double bubble sign may be seen in patients with duodenal. Copyright initial resuscitation, NPO, nasogastric tube insertion, LV fluids, correction of electrolyte imbalance, Broad spectrum 4 antibiotics O emergency surgery, LAD procedure, 4 equals the volvulus is reduced / untwisted and the LAD bands removed. Equals gangrenous / necrotic bowel, if present, is resected and either anastomosed or created into a stoma. Equals appendix is removed, to prevent future diagnostic / operative difficulties. Equals development of postoperative adhesions decreases the chance of recurrent volvulus. Incidentally detected / asymptomatic intestinal malrotation, elective surgery, LAD procedure, fatal. AO. Find text outline. Midgut volvulus and intestinal malrotation, 1/1. Midgut volvulus equal volvulus sigmoid volvulus. / bands, y. /nl/ys, and on yat, l. On is yy. Plus. Of. /send. Vy at jy on fqy /yq say, iiwt, /ww. At. Types of volvulus VB. The types of volvulus are classified by anatomical location as illustrated here. Midgut volvulus, a malrotated midgut causing mechanical bowel obstruction, mostly in neonates and infants. Fibrous peritoneal bands, LAD bands, attaching the cecum to the retroperitoneum are a common pathological finding in midgut volvulus. Cecal volvulus, the cecum rotates on its mesenteric axis resulting in mechanical bowel obstruction and vascular compromise. Sigmoid volvulus, the sigmoid colon rotates on its mesenteric axis resulting in mechanical bowel obstruction and vascular compromise. Copyright on Boss. Malrotation re and non-rotation 90°-180° incomplete rotation 270 degrees on I rotation axis, determined by sub. Mesenteric artery. _LEE. _YEEW equals A. L4. Y1. I equals /4. C. A. LS. ENA came LN equals ST. Intestinal malrotation B non-rotation, left the small bowel is entirely right-sided and the colon is entirely left-sided. Incomplete rotation, middle the cecum remains fixed in the RUQ by peritoneal bands, LAD bands. Copyright on Boss. Euro midgut volvulus and intestinal malrotation, 1/1. Intestinal malrotation. Fluoroscopy, double contrast barium enema, AP view, non-obstructed loops of air-filled small bowel are seen to the right of the cecum and ascending colon, which contain contrast, black. Some barium studies reverse the image contrast to depict barium as white. These findings are consistent with intestinal malrotation. Source, Figure 2, in Chronic Intermittent Abdominal Pain in Young Woman with Intestinal Malrotation, Fitzhugh-Curtis Syndrome, and Appendiceal Neuroendocrine Tumor, a rare case report and literature review by Alessia Cusimano, Ahmed Mohamed Alaldi and Benyamin Abdelghani, Andrea Donadini, BMC Women's Health, licensed under CC by 4.0. Euro midgut volvulus and intestinal malrotation, 1/1. Bilious vomiting in an infant, i.e., possible intestinal obstruction. NK. Y, *NPO. ENG or OG tube placement E4 fluids / sent correct electrolyte abnormalities. A. Hemodynamically unstable or signs yes of peritonitis, example fever, guarding, and rebound tenderness. XQI no. Yen. Abdominal X-ray. SAY, YY, N. Pneumoperitoneum dilated loops double bubble maze. Maze 4 Widiase opal pneumatosis, portal, example Riegler sign, of bowel sign OM sega LEE venous gas i.e. absence of stool filled colon in RLQEES7. ___A. Contrast enema upper GI contrast study. _JXS1S abnormal duodenojejunal junction location, rectosigmoid obstructed duodenum with microcolon transition zone corkscrew appearance VYVG at. Esther Hirsch-Sprung P. malrotation with necrotizing bowel perforation meconium ileus hesiaea duodenal atresia midgut volvulus Breyeritis. XYY and YXY. YVYYY, at copyright at. 4 antibiotics plus refer to meconium higher, 2 RI refer to duodenal refer to volvulus and intestinal refer to necrotizing emergency surgery ileus article disease SV atresia article malrotation article enterocolitis article. XNY XNY and Y and YXNY and. Management of bilious vomiting in the newborn BV. Copyright on Boss. X Hirsch-Sprung disease. Hirsch-Sprung disease, congenital aganglionic megacolon, is an inherited disorder primarily affecting newborns. The condition is characterized by an aganglionic colon segment, usually the rectosigmoid region, which fails to relax leading to functional intestinal obstruction. The first sign of the disease is often when a newborn fails to pass meconium within 48 hours after birth and/or shows symptoms of gastrointestinal obstruction, example bilious vomiting and abdominal distension. The onset and severity of symptoms vary according to the length of the aganglionic segment. A longer aganglionic segment is associated with an early and more severe onset. Diagnosis usually involves 3 different modalities: contrast enema, anorectal manometry, and stepwise biopsy for histological detection of aganglionosis. Treatment of choice is surgical resection of the aganglionic segment, although it is important to maintain anal sphincter function. A severe complication of the disease is Hirsch-Sprung enterocolitis, which presents with abdominal pain, fever, and foul-smelling and/or bloody diarrhea. If not treated promptly, this condition can progress to toxic megacolon or sepsis. The prognosis for patients with Hirsch-Sprung disease is good if treated at an early age. WI. CE. Epidemiology. Asterisk incidence, 1 in 5,000 live births. Copyright sex, $4:1. Epidemiological data refers to the U.S., unless otherwise specified. WA. CE. Etiology. Asterisk genetic causes, 1. ORET gene mutations associated with multiple endocrine neoplasia type 2, MEN2, and familial Hirsch-Sprung disease O endothelin receptor B, EDNARB, gene mutations associated with Waardenburg syndrome asterisk associated conditions. 2J copyright trisomy 21 O multiple endocrine neoplasia type 2, MEN2, EO Waardenburg syndrome O neuroblastoma copyright other conditions, congenital deafness, malrotation, gastric diverticulum, and intestinal atresia. EO, Hirsch-Sprung disease always involves the REC-TUM and is often associated with RET mutations. WA. OE. Pathophysiology. Hirsch-Sprung disease is caused by defective caudal migration of parasympathetic neuroblasts, precursors of ganglion cells, from the neural crest to the distal colon. This process takes place between the 4 and 7 week of development. Affected segments are histologically characterized by the absence of the Meissner plexus and Auerbach plexus, submucosal and myenteric plexus ganglion, beginning at the anorectal line, leading to 3. Copyright inability of the myenteric plexus to control the intestinal wall muscles, uncoordinated peristalsis and slowed motility O spastic contraction of intestinal muscles, stenosis and functional obstruction O expansion of the colon segment proximal to the aganglionic section, possible megacolon, plus extent of the disease to O ultra short segment, limited to the distal rectum below the pelvic floor and the anus O short segment, limited to the rectosigmoid region, approximate 80% of cases. O long segment, involvement of the distal colon up to the splenic flexure, approximate 10% of cases. Copyright total colonic, entire colon, 3 to 8% of cases. Back collapse find text outline. Clinical features. Early presentation sent delayed passage of meconium, 48 hours, sent distal intestinal obstruction, abdominal distension and bilious vomiting sent digital rectal examination copyright tight anal sphincter o empty rectum copyright squirt sign, explosive release of stool and air upon removal of the finger sent palpation of feces via the abdominal wall. Late presentation /4. Sent chronic constipation with possible inability to pass gas sent failure to thrive /poor feeding. WACE. Subtypes and variants. Ultra short segment Hirschsprung disease 5. Sent definition, very short segment of aganglionosis, limited to the distal rectum symptoms, less severe symptoms, example chronic constipation, sent treatment, usually treated with diet and stool softeners sent prognosis, better prognosis with fewer complications total colonic aganglionosis 1. Sent definition, complete aganglionosis of the colon symptoms, ranging from incomplete intestinal obstruction to ileus prognosis, significant long-term morbidity and mortality, example enterocolitis, postoperative bowel incontinence. VACE. Diagnostics. Imaging. Abdominal X-ray. Sent indication, usually performed initially in newborns with abdominal distension and delayed passage of meconium plus findings O decreased or absent air in rectum copyright dilated colon segment immediately proximal to aganglionic region O distal intestinal obstruction 1 to 7. Barium enema. Indication, usually performed in addition to X-ray, to localize and determine the length of the aganglionic segment prior to surgery sent findings E change in caliber along the affected intestinal segment, transition zone, copyright retention of barium for 24 to 48 hours anorectal manometry /5. Sent goal, it measures the relaxation pressure of the internal anal sphincter after distension with a balloon. Difficult to perform in newborns as cooperation is essential. Back collapse find text outline. Anorectal manometry. Asterisk goal, it measures the relaxation pressure of the internal anal sphincter after distension with a balloon. Difficult to perform in newborns as cooperation is essential plus indication, screening in atypical presentations or in older children 1 sent finding O absent relaxation reflex of the internal sphincter after stretching of the rectum O presence of high baseline resting pressures. Rectal biopsy, 1. Indication, confirmatory test procedure copyright full thickness biopsy under general anesthesia copyright suction rectal biopsy 1. Sent findings O absence of ganglion cells in an adequate tissue sample O elevated acetylcholinesterase activity O hyperplasia of the parasympathetic nerve fibers copyright absent calretinin immunostained fibers. BQ in approximately 10% of newborns with Hirschsprung disease, no dilation or change in caliber is found in the colon contrast enema examination. Imaging and rectal biopsy are necessary to confirm the diagnosis. WA. OSO. Treatment. Surgical correction 6. Asterisk objective, definitive treatment to remove the affected segment of the colon and bring the normal ganglionic intestinal ends together sent procedures. Copyright total transanal endorectal pull-through, preferred method that can be done in one stage, 6, EO abdominoperineal pull-through, SOAVE procedure traditionally performed in 2 stages, first stage, diverting colostomy to relieve the dilated bowel, 1. Equals second stage resection of the aganglionic segment anastomosis of the normal ganglionic colon segment to either the distal modified rectum or normal, unmodified, distal rectum, preservation of internal anal sphincter function is of the utmost importance. Medical therapy 51. Scent objectives: O. Maintain normal fluid and electrolyte balance. O. Reduction of bowel distension. O. Prevent and manage complications. Scent initial medical management. Copyright intravenous fluid resuscitation. O. Nasogastric decompression. Copyright intravenous antibiotics. If indicated, copyright colonic irrigation may be required. Scent postoperative medical management. Copyright routine colonic irrigation. Copyright prophylactic antibiotic therapy. WA. CE. Differential diagnoses. Diffjal D is of Icolia in Hirschsprung D intestinal dysplasia YSP, IND, 7 meconium mech N ileus meconium plug SYND C ital H. Delayed passage of * delayed passage of meconium. Copyright colicky pain meconium _ clinical, trademark. OO equals E. * constipation abdominal distension and * diarrhea, constipation, in some abdominal distension, features 1Z, scent abdominal distension bilious vomiting cases, bloody discharge, may have associated cystic fibrosis. Constipation. Neonatal screening allows barium enema, change in, early diagnosis of cystic oligohyaluronidase and TAD2 pantol humorcans hinanin and 2 dinanin afo-alinian, NNO_Mandelanin and TES. Back collapse. Find text outline. X. Hirschsprung disease. Scent objectives: O. Maintain normal fluid and electrolyte balance. Copyright reduction of bowel distension. O. Prevent and manage complications. Scent initial medical management. Copyright intravenous fluid resuscitation. O. Nasogastric decompression. O. Intravenous antibiotics. If indicated, copyright colonic irrigation may be required. Scent postoperative medical management. Routine colonic irrigation. Copyright prophylactic antibiotic therapy. Diff-ELD is of eye obstruction in neonates. Neuronal DYSPL, IND, 7 meconium ileus plug SY. Delayed passage of meconium. Copyright colicky pain meconium clinical 5, XYSFI 7 sense constipation abdominal distension and * diarrhea, constipation, in some abdominal distension A. Features = 7. * abdominal distension bilious vomiting cases, bloody discharge, may have associated cystic fibrosis. * Neonatal screening allows scent barium enema, change in = early diagnosis of cystic caliber along the affected * rectal biopsy, hyperganglionosis as fibrosis * diagnosis of exclusion, example diagnosis intestinal segment opposed to aganglionosis in cystic fibrosis or Hirschsprung barium enema, microcolon rectal biopsy, absence of ganglion cells, aganglionosis, Hirschsprung disease ruled out, and meconium pellets in the terminal ileum. If bilious vomiting. SOSWEEA ER2 ERAE. The differential diagnoses listed here are not exhaustive. Go your note. OES. Complications. Hirschsprung associated enterocolitis 8 copyright symptoms of toxic megacolon, example abdominal pain, fever, foul smelling and / or bloody diarrhea, copyright if not treated early, sepsis, transmural intestinal necrosis, and perforation are possible. * constipation. Plus neonatal screening allows early diagnosis of this condition. O. Management, 4 fluid resuscitation, broad spectrum 4 antibiotics, anaerobic and aerobic coverage, rectal irrigations, with possible colostomy. Scent fecal incontinence. Scent urinary dysfunction. 1 scent erectile dysfunction. Peritonitis due to bowel perforation. We list the most important complications. The selection is not exhaustive. 7. A 6. Prognosis. * good prognosis with early treatment. 9 scent higher mortality associated with younger age, length of aganglionosis, and preoperative enterocolitis. 9. Back collapse. Find text. O. Outline. Euro Hirschsprung disease, 1/1. Colon in normal mouth. Colon, Hirschsprung disease. LF colon dilatek, above F, the stricture. ILESA ganglionic India segment dash plus epithelium. Underscore $. 4 serosa. Etiopathogenesis of Hirschsprung disease VV. The affected colon, right, is missing both the Meissner and Auerbach nerve plexus. Copyright Boss. Euro Hirschsprung disease, 1/1. Hirschsprung's disease in a 5-day-old male newborn VV. Distended, bulging abdomen that is tender on palpation. Diagnosis performed by rectal suction biopsy, Hirschsprung's disease. Source, copyright IMPP. Hirschsprung disease, 1/1. Overlay. Hirschsprung disease VV. X-ray abdomen, AP view, of a 5-day-old newborn. A massively dilated colon, green overlay, is seen proximal to a narrow distal segment, red overlay. The appearance and location of the narrowing are consistent with short segment Hirschsprung disease. Yellow overlay, gastric bubble source, copyright IMPP. Overlay. Hirschsprung disease VV. X-ray abdomen, AP view, of a 5-day-old newborn. A massively dilated colon, green overlay, is seen proximal to a narrow distal segment, red overlay. The appearance and location of the narrowing are consistent with short segment Hirschsprung disease. Yellow overlay, gastric bubble source, copyright IMPP. Euro Hirschsprung disease, 1/1. Bilious vomiting in an infant, i.e., possible intestinal obstruction. NK. Y, *NPO. ENG or OG tube placement. E4 fluids /_send correct electrolyte abnormalities. A. Hemodynamically unstable or signs yes of peritonitis, example fever, guarding, and rebound tenderness. XQI no. Yen. Abdominal X-ray. SAY, YY, A. Pneumoperitoneum dilated loops double bubble maze for Whittier's opal pneumomatosis, portal, example Riegler sign, of bowel sign OM sega LDE venous gas i.e. absence of stool-filled colon in RLQEES7. _//A. Contrast enema upper GI contrast study. /JXS1S abnormal duodenojejunal junction location, rectosigmoid obstructed duodenum with microcolon transition zone corkscrew appearance VYVG at the F. Esther Hirschsprung P. malrotation with necrotizing bowel perforation meconium ileus eziaia duodenal atresia midgut volvulus Freeritis. XYYXY and YXY. YVYYY, at copyright at. 4 antibiotics plus refer to meconium higher, 2 RI refer to duodenal refer to volvulus and intestinal refer to necrotizing emergency surgery ileus article disease SV atresia article malrotation article enterocolitis article. XNYXNY. Management of bilious vomiting in the newborn VV. Copyright Boss. X congenital visceral malformations. Congenital visceral malformations develop during organogenesis, which occurs in the first 8 weeks after conception, embryonal period. Common malformations include anorectal malformation, omphalocele, gastroschisis, and biliary atresia. They may occur on their own or together with other malformations and syndromes. An anorectal malformation is characterized by an absent anal opening and failure to pass meconium, which may lead to ileus or the formation of fistulas. An omphalocele is often associated with trisomies and manifests with the herniation of abdominal viscera through the abdominal wall into a hernia sac. In cases of gastroschisis, by contrast, herniated parts of the intestine are not covered by a sac, but exposed. Bladder exstrophy is a rare condition caused by an embryonic malformation resulting in failed closure of the anterior abdominal wall and an exposed urinary bladder. All four conditions are clinical diagnoses and require surgery to prevent infections and further complications. In extrahepatic biliary atresia, the infant presents with prolonged neonatal jaundice, acolic stools, dark urine, and hepatomegaly. Conjugated hyperbilirubinemia and abnormalities on ultrasonography provide valuable clues for diagnosis. If extrahepatic biliary atresia remains undetected or surgery is delayed, the infant may die within the first 2 years of life, usually as a result of biliary liver cirrhosis. Go. A. Gastrointestinal atresia and stenosis. Definition: a congenital defect that can occur at any point along the gastrointestinal tract leading to complete atresia, or incomplete stenosis. Occlusion of the affected lumen. Epidemiology: approximate 7:10,000 live births. 1. Etiology. Copyright often associated with chromosomal anomalies. Copyright gastrointestinal atresia is the result of varying mechanisms that lead to a disruption of normal bowel development. Clinical features. Copyright intrauterine polyhydramnios. Copyright postpartum. Signs of intestinal obstruction equals abdominal distension equals bilious vomiting equals failed or delayed meconium passage. Diagnosis: O prenatal ultrasound. O X-ray of the abdomen. E evaluation for associated anomalies. Example: physical examination, echocardiogram, ultrasound of the brain, abdomen, and spine. Newborn screening results. Treatment. Copyright preoperative placement of a gastric tube for suction, parenteral nutrition, and fluid replacement. O surgery, bypass of the atresia or stenosis. Duodenal atresia and stenosis. Scent definitions. OE duodenal atresia is the complete occlusion or absence of the duodenal lumen. O duodenal stenosis is an incomplete obstruction caused by narrowing of the lumen. Scent epidemiology. Copyright around 1:5000-10,000 live births. 21. O approximate 50% of cases are associated with further anomalies, example bile duct and bacterial association. 3. Copyright 20 to 25% of cases are associated with chromosomal abnormalities, especially Down syndrome. 2. Scent pathophysiology. O duodenal atresia occurs when recanalization of the closed duodenum during the embryonic period fails or is only partial, usually between the 8 and 10 weeks of gestation. O since the development of the duodenum is connected to the growth of the pancreas and the hepatobiliary system, duodenal atresia is also commonly associated with anomalies of these organs. 2. Scent clinical features. O intrauterine polyhydramnios. 40. Postpartum equals vomiting that is typically bilious if the stenosis is distal to the major duodenal papilla. 4. Atresia or high-grade stenosis, vomiting a few hours after birth. 2. Mild stenosis, vomiting after a few days. Distended upper abdomen and scaphoid lower abdomen. 4 equals delayed meconium passage. Scent diagnostics. Copyright prenatal ultrasound registered. Back collapse. Fine text outline. Scent diagnostics. Copyright prenatal ultrasound equals double bubble sign equals air and fluid build up proximal to the obstruction and are separated by the pyloric sphincter, which resembles 2 bubbles on imaging, one in the stomach and one in the duodenum. Equals if present, test for associated anomalies, example karyotyping, microarray, 1. 6LL7 equals polyhydramnios equals dilation of the stomach and duodenum, proximal to the obstruction, is common. Copyright postnatal, X-ray of the abdomen. 9. 4. Gasless distal bowel equals double bubble sign plus differential diagnoses. O jejunal atresia. Oleal atresia. Degree Hirschsprung disease. Copyright meconium Meconium ileus copyright malrotation with volvulus treatment o preoperative management equals parenteral nutrition via a central catheter shortly after birth equals fluid replacement and restoration of the electrolyte balance equals gastric decompression surgery. Bypass of the atresia or stenosis equals the choice of procedure depends on the anatomical findings and associated anomalies. Equals the most common procedures are duodenal-duodenostomy or duodenojejunectomy with the proximal transverse to distal longitudinal, diamond-shaped, anastomosis. Scent prognosis, if diagnosis and treatment are quickly established, the survival rate of isolated duodenal atresia, without further anomalies, is 95%. CA. References 3. WA. OE. Jejunal atresia and ileal atresia. Definition: absence of the jejunal or ileal lumen. Epidemiology: less common than duodenal atresia. Etiology: copyright associated with cystic fibrosis. Copyright risk factors: maternal smoking and / or use of vasoconstrictive agents, example cocaine, MDMA, during pregnancy. Discontinuous bowel obstruction. Clinical features: similar to duodenal atresia o polyhydramnios, intrauterine, copyright bilious vomiting and upper abdominal distension. Postpartum. Diagnostics: abdominal X-ray shows a triple bubble sign, dilated small bowel loops and air fluid levels. The three bubbles correlate with the distended stomach, duodenum, and jejunum proximal to the obstruction, and gasless colon. Treatment: surgical correction with bypass of the occluded part of the bowel is always required. WA. Degree IOS. Lee colonic obstruction. Colonic atresia. Scent definition: a congenital anomaly of the colon that results in either stenosis or a complete absence of a colonic segment. Scent epidemiology: rare, accounts for approximate 7% of bowel atresia. 8. Scent pathophysiology: disruption of vascular supply or a mechanical event, example intestinal volvulus, ischemic necrosis and reabsorption of the colon. Distal microcolon or absence of the distal colonic segment. Scent clinical features: symptoms of intestinal obstruction may appear later than with more proximal lesions. Abdominal distension. Back collapse. Fine text outline. Pathophysiology: vascular accident in utero, usually a disruption of superior mesenteric artery, ischemic necrosis and reabsorption of the jejunum or ileum. Scent clinical features: symptoms of intestinal obstruction may appear later than with more proximal lesions. Copyright abdominal distension. Copyright bilious vomiting o delayed or failed meconium passage. Diagnosis: copyright clinical diagnosis. Copyright X-ray, dilated proximal segment and absence of gas in the rectum. Scent treatment: primary anastomosis surgery or temporary colostomy. Anorectal malformation, anal atresia. Definition: sporadically occurring malformation of the rectum with absent anal opening. Epidemiology. 9. Copyright approximate 1:5,000 live births in the US. O sex, 7 equals 2. Etiology: associated with a number of conditions. Co-mesodermal defects, example bacterial association, co-Down syndrome o maternal diabetes. Copyright other malformations, example vaginal or uterine anomalies, renal anomalies, spinal cord or cardiovascular malformations. Pathophysiology: failure of the urorectal septum to descend caudally to the cloacal membrane. Clinical features 10, 11, 12. Co-absence of anal opening. Copyright thin anal membrane in place of anal opening through which meconium is visible. Obstipation, ileus. Copyright fistulas that complicate defecation, example rectovestibular, rectourethral, rectovaginal, small or missing anal dimple. Plus copyright in some cases, bucket handle malformation. Copyright flat bottom, absent or poorly developed midline groove between buttocks. Diagnostics. Copyright clinical diagnosis o lateral pelvic radiography or invertogram to determine position of the rectal pouch. Copyright investigation of additional malformations, example spinal ultrasonography, sacral X-ray. O fistula screening equals examination of the genital area and the urethra, example abdominal ultrasound, equals urinalysis. Meconium detectable in case of recto-urinary fistula. Augmented pressure distal colostography to assess for fistulas. 1 treatment. Copyright 4 hydration, no oral feeding. Anal reconstructive surgery, primary anaplasty, or temporary colostomy in more complex malformations. S. Abdominal wall defects. Description. Pathophysiology. Anatomy. Associated conditions. Back. Omphalocele, a ventral wall defect that results in congenital herniation of abdominal viscera through the abdominal wall at the umbilicus. Persistent herniation of the midgut derivatives due to impaired closure of the lateral umbilical folds. Viscera may also contain liver and gallbladder, herniate into the umbilical cord. The hernia sac is covered by amniotic membrane and peritoneum. Frequently observed in individuals with trisomies, trisomy 21, trisomy 18, and trisomy 13, and Beckwith-Wiedemann syndrome, often associated with additional malformations, example cardiac, GI, genitourinary, and neural tube defects. Overview of abdominal wall defects. Gastroschisis, a ventral wall defect that results in para-umbilical herniation of the intestine through the abdominal wall, without formation of a hernia sac. Failed formation of a sufficiently large peritoneal cavity. Growing bowel, rupture of the anterior abdominal wall at its weakest point. Herniation of bowel sections. Protrusion of intestinal content, usually on the right side of the umbilicus. The intestine is not contained in a hernia sac. Additional anomalies are rarely present. WV equals law. Umbilical hernia. Aventral wall defect with a protruding sac, possibly containing intestines, at the umbilicus. Failed spontaneous closure of the umbilical ring following physiological herniation of the midgut patent umbilical orifice. The mass protrudes through the umbilicus. The hernia is covered by skin. Incidence is more common in children with other congenital anomalies, example trisomy 21, trisomy 18, congenital hypothyroidism. Collapse. Fine text outline. Frequently observed in individuals with trisomies, trisomy 21, trisomy 18, and trisomy 13, and associated Beckwith-Wiedemann syndrome conditions. Often associated with additional malformations, example cardiac, GI, genitourinary, and neural tube defects. Clinical diagnosis. Diagnostics can be detected prenatally. Copyright ultrasonography, polyhydramnios in utero. Degree T. MISAFP. Cesarean delivery. Vaginal delivery for small omphalocele without scent, usually vaginal delivery. Liver involvement. Wrapping of the hernia sac / free intestines with sterile saline dressings covered with plastic wrap. Management plus nasogastric suction for fluids. Surgery. Sent within the first 24 hours of life. Sent emergency surgery. Omphalocele. Scent definition. Scent. Additional anomalies are rarely present. Incidence is more common in children with other congenital anomalies, example trisomy 21, trisomy 18, congenital hypothyroidism. Usually no further diagnostics necessary. Vaginal delivery. Conservative, closes spontaneously by the age of 5 years. Rarely necessary. Ventral wall defect that results in congenital herniation of abdominal viscera through the abdominal wall at the umbilicus. The hernia sac is covered by the amniotic membrane and the peritoneum. Scent epidemiology. Approximate 1:4,000 live births in the U.S. Degree sex, $7. Scent etiology. Frequently observed in tri-IES, trisomy 21, trisomy 18, and trisomy 13, and Beckwith-Wiedemann syndrome. Copyright often associated with additional malformations, example cardiac, gastrointestinal, genitourinary, and neural tube defects. Scent pathophysiology. Persistent herniation of the midgut derivatives due to impaired closure of the lateral umbilical folds. Scent clinical features. OE most commonly affects premature infants. Copyright umbilical hernia sac, may contain intestine, liver, and gallbladder. AO features of associated conditions. Diagnosis, 5. Copyright clinical diagnosis at birth. Copyright can be detected prenatally. Ultrasonography, polyhydramnios in utero. 1 maternal serum alpha-fetoprotein, MIS-F. Scent treatment. Cesarean delivery to prevent rupture of the sac of large omphalocele, especially if the liver is contained in the hernia sac. Vaginal delivery is possible in cases with small omphalocele. Wrapping of the hernia sac with sterile saline dressings covered with plastic wrap. Nasogastric suction. Copyright for fluids to avoid abdominal distension and to compensate fluid loss. Copyright surgery, within the first 24 hours of life, usually primary abdominal wall closure. Alternatively, secondary closure following, staged silo repair, skin graft or dermal patch. 1 Scent complications. A rupture of hernia sac with infection, peritonitis. Copyright secondary intestinal wall atresia as a result of injury. Scent prognosis. Dependent on the size of the defect and birth weight. Copyright survival rate over 90% in the absence of additional malformations. V. Back collapse. AO. Fine text outline. LL gastroschisis. Scent definition, a ventral wall defect that results in para-umbilical herniation of the intestine through the abdominal wall without formation of a hernia sac. Scent epidemiology, approximate 1:2,000 live births in the U.S. Scent pathophysiology. Failed formation of a sufficiently large peritoneal cavity. Growing bowel leads to rupture of the anterior abdominal wall at its weakest point. 1 Herniation of bowel sections. Copyright because the malformation occurs relatively late in development. Additional anomalies are rarely present, in contrast to omphalocele. Scent clinical features. Copyright protrusion of intestinal content usually on the right side of the umbilicus. Copyright the intestine is not contained in a hernia sac and appears edematous, erythematous, and dull. Copyright shortened bowel dash. Malabsorption caused by mucosal damage. Copyright peritonitis. Seen especially in premature infants and associated with cryptorchidism and gastrointestinal stenosis or atresia. Scent diagnosis. Usually clinical diagnosis. Copyright can be detected prenatally. See diagnosis of omphalocele above. Scent treatment. Cesarean delivery has no advantage over vaginal delivery. See treatment of omphalocele above. Emergency surgery primary abdominal wall closure, success rate of 70%, alternative, staged silo repair. See treatment of omphalocele above. Scent prognosis. Copyright survival rates are generally high, 90%. Short bowel syndrome is a common complication. Copyright 20% of children develop necrotizing enterocolitis. 14. Unlike in cases of omphalocele, gastroschisis does not manifest with a hernia sac. Omphalocele keeps your gut sealed, covered with peritoneum, but in gastroschisis, the gut freezes, herniates through the abdominal wall without being covered by peritoneum. CE. Other complex abdominal wall defects. Bladder exstrophy. Definition, embryological defect of ventral abdominal wall due to an overdeveloped cloacal membrane. 1 plus epidemiology. 5 prevalence is 3 per 100,000 live births. More common in males. Scent clinical features. Bladder and urethra herniated through a defect in the abdominal wall. Copyright incontinence. Copyright genital abnormalities males, shortened penis with dorsal penile curvature and epispadias. Females, bifid clitoris with labia separated anteriorly and epispadias widely separated. Pubic symphysis. Copyright associated malformations. Omphalocele often a low set umbilicus, indirect inguinal hernia, J, and anteriorly displaced anus. Possibly hip dysplasia, bicornuate uterus, cardiac dysplasia. Scent diagnostics. Largely a clinical diagnosis. Copyright prenatal ultrasound with inability to visualize bladder, lower abdominal wall mass, low set umbilical cord, abnormal genitalia, and pubic bone diastasis. Treatment. Copyright staged or primary surgical repair and reconstruction 1. Back collapse fine text outline. Scent treatment copyright staged or primary surgical repair and reconstruction equals timing depends on surgeon preference and infant's anatomy, within first 2 to 3 days of life, immediate, or between 6 to 12 weeks of age, delayed. 1. Copyright iliac osteotomy may be required if the diastasis is extreme or after first 2 to 3 days of life as pelvis becomes less malleable. Scent complications copyright persistent incontinence, I. Copyright urinary tract infections, UTIs, epididymitis e bladder stones, fistulas. Copyright vesicoureteral reflux e vaginal and rectal prolapse. Copyright possible infertility in males. O. Bladder adenocarcinoma. Scent prognosis, lifelong management necessary with focus on bladder and renal function, psychological status, and sexual function and fertility. OOES. Biliary tract malformations. Biliary atresia. Scent definition, obliteration or discontinuity of the extrahepatic biliary system, most commonly of the common bile duct. Scent epidemiology. O. Approximate 1:10,000-15,000 live births in the U.S. O. Fog. Scent etiology. O. Exact etiology unknown, most likely an embryonal malformation or acquired lesion. Copyright approximate 10 to 35% of cases involve additional anatomical malformations, example situs inversus, asplenia, polysplenia, cardiac anomalies, pathophysiology, discontinuity of the biliary system due to obliteration or fibrosis, obstruction of bile flow, cholestasis, secondary biliary cirrhosis and portal hypertension. Scent clinical features. EO jaundice equals prolonged neonatal jaundice, 2 weeks, equals onset 2 weeks after birth is possible. Copyright acolic stools, dark urine. EO hepatomegaly. Scent diagnosis. O. Laboratory analysis equals conjugated hyperbilirubinemia 1 aminotransferases and alkaline phosphatase equals 1 GGT. O. Ultrasonography equals absence of the gallbladder equals no dilatation of the biliary tree. Copyright liver biopsy. Active inflammation with bile duct degeneration and fibrosis equals bile duct proliferation equals portal stromal edema. O. hepatobiliary syntoscanning, HBSS. Failed excretion of the tracer into the bowel. Copyright intraoperative cholangiography to confirm diagnosis. Scent treatment. O. Kasai procedure, hepatoportoenterostomy. A connection is created between the liver and the small intestine to allow for bile drainage. O. In cases of liver cirrhosis, liver transplantation, primary reason for liver transplantation in children. Scent complications. O. If undetected equals early biliary liver cirrhosis, at approximate 9 weeks of age, equals children may die within the first 2 years of life. Copyright postoperative equals cholangitis in 50% of cases equals portal hypertension in 60% of cases. Alagille syndrome. Back collapse fine text outline. X congenital visceral malformations equals prolonged neonatal jaundice, 2 weeks, equals onset 2 weeks after birth is possible. Acolic stools, dark urine. O. hepatomegaly. Scent diagnosis. E. Laboratory analysis equals conjugated hyperbilirubinemia 1, T. aminotransferases and alkaline phosphatase equals 1 GGT. O. Ultrasonography equals absence of the gallbladder equals no dilatation of the biliary tree. Copyright liver biopsy equals active inflammation with bile duct degeneration and fibrosis. A. equals bile duct proliferation equals portal stromal edema. Copyright hepatobiliary syntoscanning, HBSS. Failed excretion of the tracer into the bowel. O. Intraoperative cholangiography to confirm diagnosis. Scent treatment. O. Kasai procedure, hepatoportoenterostomy. A connection is created between the liver and the small intestine to allow for bile drainage. Copyright in cases of liver cirrhosis, liver transplantation, primary reason for liver transplantation in children. Scent complications. O. If undetected equals early biliary liver cirrhosis, at approximate 9 weeks of age, equals children may die within the first 2 years of life. O. Postoperative equals cholangitis in 50% of cases equals portal hypertension in 60% of cases. B. Degree equals Alagille syndrome. Scent description, a genetic condition that is characterized by intrahepatic biliary duct aplasia or hypoplasia. Cent epidemiology, approximate 1:30,000-45,000 live births in the U.S. Cent etiology, autosomal dominant inheritance o mutation in the JAG1 gene on chromosome 20 in 90% of patients. Cent clinical features, hepatic manifestations equals cholestasis equals jaundice equals pruritus equals cirrhosis. Copyright facial dysmorphism equals triangular face equals deep set eyes equals broad nasal bridge. Copyright congenital heart defects, example peripheral pulmonary stenosis, O butterfly vertebrae, E posterior embryotics and O renal dysplasia. Cent diagnosis. Copyright laboratory findings equals conjugated hyperbilirubinemia equals 7 serum aminotransferases equals 1 YGT. O liver biopsy, decreased number of interlobular bile ducts. Copyright confirmation via genetic testing, detection of JAG1 gene mutation. Cent treatment, E depends on the affected organ systems. Copyright conservative management of cholestasis and pruritus, example ursodeoxycholic acid, cholestyramine. Back collapse. Fine text outline. Urocongenital visceral malformations, 1/4. RAB 48L/OB Me 1.0 15.4 cm/40 Hz TIS 0.2. Double bubble sign on ultrasound. Ultrasound of a fetus in the second trimester with duodenal atresia. Routine Harnedy PWR 100 GNC7 IME. Overlay. The stomach, S, and proximal duodenum, D, show severe dilatation and fluid collection, resembling two bubbles. Both structures are separated by the pyloric sphincter, green overlay. Copyright Boss. Urocongenital visceral malformations, 1/4. RAB 48L/0B Me 1.0 15.4 cm/40 Hz TLS 0.2. Double bubble sign on ultrasound. Ultrasound of a fetus in the second trimester with duodenal atresia. Routine Harnedy PWR 100. GNC7 IME. Copyright. Overlay. The stomach, S, and proximal duodenum, D, show severe dilatation and fluid collection, resembling two bubbles. Both structures are separated by the pyloric sphincter, green overlay. Copyright Boss. Congenital visceral malformations, 2/4. Overlay. Double bubble sign VV. X-ray abdomen, AP view, of a newborn with duodenal atresia. A nasogastric tube terminates in the gastric antrum. Gaseous distension of the stomach and pyloric channel, green overlay, and dilatation of the duodenal bulb, red overlay, are seen. Bowel distal to the duodenal bulb does not contain gas. This appearance has been termed the double bubble sign. This sign is seen with duodenal atresia and several other congenital and acquired causes of duodenal obstruction. Source, Duodutras by Kinderradiologie Olga Hospital Klinikum Stuttgart, Wikimedia Commons, licensed under CC by SA 3.0. Copyright. Overlay. Double bubble sign. X-ray abdomen, AP view, of a newborn with duodenal atresia. A nasogastric tube terminates in the gastric antrum. Gaseous distension of the stomach and pyloric channel, green overlay, and dilatation of the duodenal bulb, red overlay, are seen. Bowel distal to the duodenal bulb does not contain gas. This appearance has been termed the double bubble sign. This sign is seen with duodenal atresia and several other congenital and acquired causes of duodenal obstruction. Source, Duodutras by Kinderradiologie Olga Hospital Klinikum Stuttgart, Wikimedia Commons, licensed under CC by SA 3.0. Congenital visceral malformations, 3/4. Overlay. Duodenal atresia in a newborn VV X-ray of the abdomen. Dilation of the prestenotic bowel segments duodenum, D, and stomach, S, with an air fluid level in each dilated segment, double bubble sign. No air is visible in the post-stenotic bowel loops. Source, copyright IMPP. A. Bilious vomiting in an infant, i.e., Possible intestinal obstruction, is S. NPO. ENG or OG tube placement E4 fluids / E correct electrolyte abnormalities. LE hemodynamically unstable or signs yes of peritonitis, example fever, guarding, and rebound tenderness. XJT no. PG yen on. Abdominal X-ray. XNJSYYYRA. Pneumoperitoneum dilated loops double bubble non-pneumatosis, portal. E.g. Regicid of how? Sign absence of stool-filled colon in RLQ venous 0 degrees SXQ. VVY_FA. Contrast enema upper GI contrast study. XY1 at 4D at 7 PEE Hirschsprung malrotation with necrotizing bowel perforation meconium ileus fui and duodenal atresia midgut volvulus anaeronitic. XY and YY and Y and YVVYYVA4 copyright at sent at 4 antibiotics plus refer to meconium ICA refer to duodenal refer to volvulus and intestinal refer to necrotizing emergency surgery ileus article disease, i.e. atresia article malrotation article enterocolitis article. YX and YYX and 4ODS ad. Management of bilious vomiting in the newborn A. Congenital visceral malformations, 1/1. Copyright. Overlay. Imperforate anus VV. X-ray abdomen, invertogram view, of a newborn A coin has been placed over the anus and the patient has been turned upside down. Multiple dilated gas-filled loops of bowel, examples indicated by green line, are seen proximal to a point of abrupt termination of the distal colon. Beyond this, double arrow, no gas continues to the anus. The appearance is consistent with imperforate anus, anal atresia. The distance between the gas column and the coin can be measured to determine the length of the atretic segment. Imperforate anus can be associated with other congenital abnormalities, among them esophageal atresia, bacterial association, caudal regression syndrome, trisomy 21, and Carrera-No triad. Source, copyright IMPP. Urocongenital visceral malformations, 1/1. Overlay. Imperforate anus VV. X-ray abdomen, invertogram view, of a newborn A coin has been placed over the anus and the patient has been turned upside down. Multiple dilated gas-filled loops of bowel, examples indicated by green line, are seen proximal to a point of abrupt termination of the distal colon. Beyond this, double arrow, no gas continues to the anus. The appearance is consistent with imperforate anus, anal atresia. The distance between the gas column and the coin can be measured to determine the length of the atretic segment. Imperforate anus can be associated with other congenital abnormalities, among them esophageal atresia, bacterial association, caudal regression syndrome, trisomy 21, and Carrera-No triad. Source, copyright IMPP. Omphalocele. Umbilical hernia diastasis recti gastroschisis. Congenital malformations of the anterior abdominal wall VV. Omphalocele, herniation of intra-abdominal contents through an anterior abdominal wall defect at the base of the umbilical cord caused by the failure of the midgut to return to the abdominal cavity after its physiological herniation through the umbilical ring. Accordingly, the hernial sac is formed by the amniotic membrane and peritoneum, and the umbilical cord lies at the apex of the hernia. Gastroschisis, a developmental defect of the anterior abdominal wall in the para-umbilical region through which intra-abdominal contents prolapse. As it is the anterior abdominal wall that fails to develop correctly, there is no outer peritoneal or membranous covering. Congenital umbilical hernia, herniation of intra-abdominal contents through a patent umbilical orifice, which typically closes by 2 years of age. The sac of a para-umbilical hernia is the peritoneum. Diastasis recti, an abnormally wide separation of the right and left rectus abdominis muscles. The abdominal fascia are intact. There is therefore no herniation, but a midline bulge is visible on straining, example when trying to sit up. Urocongenital visceral malformations, 2 halves. Congenital umbilical hernia. Anterior abdominal wall of a newborn. There is a mass 2 cm in diameter protruding through the umbilical orifice. This is the typical appearance of a congenital umbilical hernia, which characteristically increases in size on crying or coughing. Copyright Boss. Omphalocele. Umbilical hernia diastasis recti gastroschisis. Congenital malformations of the anterior abdominal wall VV. Omphalocele, herniation OT intra-abdominal contents through an anterior abdominal wall detect at the base of the umbilical cord caused by the failure of the midgut to return to the abdominal cavity after its physiological herniation through the umbilical ring. Accordingly, the hernial sac is formed by the amniotic membrane and peritoneum, and the umbilical cord lies at the apex of the hernia. Gastroschisis, a developmental defect of the anterior abdominal wall in the para-umbilical region through which intra-abdominal contents prolapse. As it is the anterior abdominal wall that fails to develop correctly, there is no outer peritoneal or membranous covering. Congenital umbilical hernia, herniation of intra-abdominal contents through a patent umbilical orifice, which typically closes by 2 years of age. The sac of a para-umbilical hernia is the peritoneum. Diastasis recti, an abnormally wide separation of the right and left rectus abdominis muscles. The abdominal fascia are intact. There is therefore no herniation, but a midline bulge is visible on straining, example when trying to sit up. Omphalocele. Umbilical hernia diastasis recti gastroschisis. Congenital malformations of the anterior abdominal wall VV. Omphalocele, herniation of intra-abdominal contents through an anterior abdominal wall defect at the base of the umbilical cord caused by the failure of the midgut to return to the abdominal cavity after its physiological herniation through the umbilical ring. Accordingly, the hernial sac is formed by the amniotic membrane and peritoneum, and the umbilical cord lies at the apex of the hernia. Gastroschisis, a developmental defect of the anterior abdominal wall in the para-umbilical region through which intra-abdominal contents prolapse. As it is the anterior abdominal wall that fails to develop correctly, there is no outer peritoneal or membranous covering. Congenital umbilical hernia, herniation of intra-abdominal contents through a patent umbilical orifice, which typically closes by 2 years of age. The sac of a para-umbilical hernia is the peritoneum. Diastasis recti, an abnormally wide separation of the right and left rectus abdominis muscles. The abdominal fascia are intact. There is therefore no herniation, but a midline bulge is visible on straining, example when trying to sit up. And congenital visceral malformations, 2 halves. YL/and add AII, 2. 5, EOSE \E, IF9EE \SO_equals 5 \A, iter A. 7 YS, equals NP teats RAL \SSS NAN ATL. A. 7 2 LSI, SOG ASSF/9 plus a pass/FOS, IMEYLXN. Equals me9s \WSOOC. Visual mnemonic for omphalocele and gastroschisis. Omphalocele, congenital herniation of abdominal viscera through the abdominal wall at the umbilicus. The hernia sac is covered by the amniotic membrane and the peritoneum. To remember this, think, the herniating abdominal contents stay within the O, i.e., they are covered by peritoneum. Gastroschisis, congenital para-umbilical herniation of the intestine through the abdominal wall without formation of a hernia sac. To remember this, think, the herniating abdominal contents come out of the G, i.e., they are not covered by peritoneum. Copyright Boss. Biliary atresia. Definition: obliteration of bile ducts of the extrahepatic biliary system. Diagnostics at T parameters of cholestasis, ALP, GGT, direct bilirubin, E at TAST and ALT at liver biopsy at intraoperative cholangiography hepatomegaly. Treatment: ECASI procedure, hepatoportoenterostomy, At liver transplantation if cirrhosis is present. Complications if untreated, liver cirrhosis and death. Dark urine. Biliary atresia fact sheet. Copyright Boss. Prolonged neonatal jaundice. It / _ atretic gallbladder, IDX / obliterated bile ducts. Acolic stools. Abdominal hernias. Abdominal hernias are a protrusion of intra-abdominal contents through a congenital or acquired defect in the abdominal wall. Abdominal hernias are broadly classified by location, anterior wall, lateral wall, groin, or pelvis, and presentation, reducible, irreducible, obstructed, or strangulated. Physiological states that increase intra-abdominal pressure, example ascites, pregnancy, obesity, intra-abdominal tumors, chronic cough, increase the risk of developing an abdominal hernia. Clinical presentation ranges from an asymptomatic mass in reducible hernias, to pain, bowel obstruction, and systemic symptoms in strangulated hernias. Abdominal hernias are typically a clinical diagnosis made on physical examination. Imaging, example ultrasound, CT scan, may be used if the examination is difficult or atypical, and before surgery. Treatment is primarily surgical repair with or without a mesh, though observation may be adequate in some patients. Emergency surgery is always required for an obstructed or strangulated, i.e., ischemic, hernia. Congenital umbilical hernias typically close spontaneously by 5 years of age and have a wide neck, and the risk of complications is low. Surgical intervention is rarely necessary. See inguinal hernias and femoral hernias for more detail on these hernia types. WA. CE. Classification. By anatomical location, L2. E. Anterior abdominal wall hernias. O. Umbilical hernia, midline ventral hernia at the level of the umbilicus. 141st. O. Epigastric hernia, protrusion of intra-abdominal contents through the linea alba, between the xiphoid process and the umbilicus. MS. Copyright incisional hernia, protrusion of intra-abdominal contents through an abdominal wall defect due to previous surgery. O. Peristomal hernia, a subset of incisional hernias in which intra-abdominal contents protrude through the abdominal wall defect. Created during stoma placement, example colostomy. Lateral abdominal wall hernias. EO. Lumbar hernia equals superior lumbar hernia, herniation through the superior lumbar triangle. 1 equals inferior lumbar hernia, herniation through the inferior lumbar triangle. 4 equals lumbar incisional hernia, herniation following surgery involving the posterolateral abdominal wall, example nephrectomy, aortic aneurysm repair. 5. Copyright Spigelian hernia, herniation along the semilunar line, commonly adjacent to the arcuate line, i.e., below the umbilicus, SIL. Cent groin hernias. Copyright inguinal hernia, direct or indirect. O. Femoral hernia equals plus pelvic hernias. 161L degree. Copyright obturator hernia, herniation through the obturator foramen. Copyright perineal hernia, herniation through the pelvic floor. 99. Copyright sciatic hernia, herniation through the greater sciatic foramen or lesser sciatic foramen. By degree of complication, 1I10. Cent reducible hernia, hernia contents can be completely returned to the peritoneal cavity. Irreducible hernia, also known as incarcerated hernia, hernia contents cannot be completely returned to the peritoneal cavity. 11. Cent obstructed hernia, a hernia in which the lumen of the intestine within the hernial sac has become completely obstructed. Cent strangulated hernia. O. A hernia in which the contents of the hernial sac, example omentum, bowel, have become ischemic due to a compromised vascular supply. Copyright Richter hernia, a subset of strangulated hernias in which only the untum's enteric portion of the intestinal wall is trapped by the abdominal wall defect, causing ischemia without obstruction. 22IL13. Cent complex hernia, a hernia that is technically challenging to repair, requires a longer operative time, and has greater associated perioperative morbidity than a simple hernia. 4. Q at intermediate-sized abdominal wall defects have the highest risk of causing an incarcerated hernia. Small wall defects are less likely to allow a visceral protrusion, and large wall defects are less likely to cause mechanical impingement of the contents of the hernial sac. Back collapse. Fine text outline. Clinical features. Reducible hernia, 151L16117. Scent history. Eosymptomatic or asymptomatic mass or fullness. E size decreases with recumbency. Copyright size increases with sitting, standing, and / or straining. Scent physical examination. O non-tender mass that returns to the peritoneal cavity with mild, externally applied pressure. Copyright visible or palpable. Cough impulse, expansion of the mass with increased abdominal pressure. O edges of the facial defect may be palpable. O bowel sounds may be present over the mass if part of the bowel is present in the hernial sac. Irreducible, incarcerated, hernia, 51L161I17. Scent chronic incarceration, non-tender or minimally tender mass. Scent acute incarceration, mass may be painful. Scent neither recumbency nor external pressure significantly reduce mass size. Scent cough impulse may be present. Obstructed hernia, 151L161I17. Acute pain at the site of the hernia. Symptoms of bowel obstruction. Absent cough impulse. Strangulated hernia, 151L16117. Scent history. O acute pain at the site of the hernia. O symptoms of bowel obstruction, if part of the bowel is present in the hernial sac. E physical examination. O tender, non-reducible hernia. O absent cough impulse. O edematous, erythematous, warm overlying skin. MS. O systemic symptoms, fever, signs of sepsis. And intestinal strangulation can lead to gangrene, which can be fatal if not treated promptly. Atypical manifestations. 15I16I17. Pelvic hernias. Obturator hernia, pain and paresthesia in the pelvis and inner thigh. Episodic intestinal obstruction. Scent perineal hernia, pelvic pain, mass on rectovaginal examination. Scent sciatic hernia, symptoms of bowel obstruction, mass in the gluteal or intragluteal area. Spigelian hernia, spontaneous lateral ventral hernia, hernia of semilunar line. Scent definition, protrusion of abdominal contents and / or peritoneum through a defect in the lower anterior abdomen adjacent to the semilunar line. Epidemiology, very rare, 0.1 to 2% of all ventral hernias. 8. Etiology, T. Intra-abdominal pressure, example obesity, pregnancy, ascites, trauma to the abdominal wall, example prior incisions, and / or degeneration of the abdominal aponeurotic layers. Defect between the rectus abdominis and the semilunar line in the Spigelian aponeurosis. Protrusion of abdominal contents and / or peritoneum. 91 Risk factors, older age, disorders of collagen synthesis, example Ehlers-Danlos syndrome, smoking. 8 LL9 Clinical features, variable EO abdominal pain. O palpable mass along the Spigelian fascia. Degree diagnostics, ultrasound and CT scan. Treatment, all Spigelian hernias must be repaired surgically because of the high risk of incarceration and / or obstruction. OO. OE. Diagnostics. Back collapse. Fine text outline. Diagnostics. General principles. An abdominal hernia is usually a clinical diagnosis made on physical examination. Imaging may be necessary if the examination is difficult, example due to tenderness, obesity, scarring, or presentation is atypical. Imaging 2421. Indications 221. Unclear diagnosis, example abdominal wall pain without a clinically apparent hernia. Scent suspected complication, example bowel obstruction or strangulation. Modalities. Scent CT abdomen. Copyright sensitive imaging study for suspected bowel obstruction or strangulation. 10 Copyright typically performed with both fore and po contrast, unless contraindicated because of obstruction. Scent ultrasound. Copyright consider in children and for non-acute adult groin hernias. O allows for dynamic assessment, the patient can perform a Valsalva maneuver or reposition themselves to induce a hernia. Sent abdominal X-ray may be used to rapidly evaluate for bowel obstruction and perforation. Presence of viscera in the hernial sac plus strangulated hernia, signs of visceral ischemia 125 cent obstructed hernia, radiological signs of mechanical bowel obstruction. Differential diagnoses. Differential diagnoses of ventral hernias. Sent diastasis recti, abdominal wall tumor, example desmoid tumor, lipoma E in newborns, omphalocele, gastroschisis. Rectus sheath hematoma. Sent definition, an accumulation of blood within the rectus sheath that most commonly arises from the disruption of a branch of the inferior epigastric artery. Sent etiology, 27280 blunt or penetrating trauma. Copyright spontaneous risk factors. Age 70 years. Copyright anticoagulation or antiplatelet therapy. Copyright coagulation disorders. Copyright pregnancy. 22 * clinical features. 28 Copyright acute onset abdominal pain. Palpable abdominal mass. Back collapse. Find text. Outline. Clinical features. Degree. Acute onset abdominal pain. Copyright palpable abdominal mass. Abdominal tenderness and / or guarding. Copyright Carnet sign. The patient is in the supine position and asked to sit upright while the point of maximal abdominal tenderness is palpated. Positive if the tenderness remains unchanged or increases during contraction of the rectus abdominis muscles. Copyright Fothergill sign equals the patient is asked to lie in the supine position and contract the abdominal muscles. Example. By lifting the head or lower limbs. Positive if the palpable abdominal mass does not cross the midline and remains palpable after contraction of the rectus abdominis muscles. Copyright Cullen sign, periumbilical ecchymosis, copyright Gray-Turner sign, flank ecchymosis, copyright signs of hypovolemic shock, example tachycardia, hypotension, dash. Sent diagnostics, 27/29 Copyright serial measurement of hematocrit and / or hemoglobin levels, anemia and / or leukocytosis may be present. ECT scan, confirmatory test. Hematoma confined to the abdominal wall. Abdominal ultrasound, alternative modality to CT for children and pregnant women. Plus treatment. 27 Copyright compression of the hematoma. Copyright correction of abnormal coagulation. 04 Fluid resuscitation and / or blood transfusion. Hemodynamically unstable patients with expanding hematoma equals angiography with arterial embolization equals surgical evacuation of the hematoma and ligation of the artery. Differential diagnoses of other hernias. Pelvic and groin hernias. Copyright inguinal lymphadenopathy. Copyright crypt orchid testes. Lipoma. Femoral artery aneurysm. Sent strangulated hernia. Abscess. Hematoma. Lymphadenitis. Strangulated groin hernias. The differential diagnoses listed here are not exhaustive. OES. Treatment. Surgical repair is the definitive treatment for abdominal wall hernias, but management with watchful waiting may be appropriate in select patients. See also incisional hernia and umbilical hernia for management specific to these hernia types. Copyright treat strangulated hernias and obstructed hernias as surgical emergencies, for which operative repair is indicated within hours to prevent complications, example intestinal ischemia, sepsis, and death. Non-operative and preoperative management. Plus watchful waiting may be considered in selected patients. 231-2224 If elective hernia repair is anticipated, consider starting preoperative lifestyle modifications, example smoking cessation, weight loss, and optimization of chronic illnesses. 41135. Surgical management, 1. Emergency surgery for any obstructed hernias or strangulated hernias. Copyright elective surgery for all symptomatic hernias and asymptomatic hernias at risk for complications. On. Back collapse. Find text outline. Incisional hernia. Sent definition, herniation of intra-abdominal contents through an abdominal wall defect due to previous abdominal surgery plus incidence, up to 20% after abdominal surgery, 1371I38 * risk factors, 18LL22-230 Olaparadomy, especially via midline incision o postoperative wound infection. Copyright patient factors, smoking history, diabetes mellitus, obesity, immunosuppression, malnourishment, older age 35 emergency abdominal surgery. Copyright pregnancy * clinical features 221 391 mass or protrusion at the site of the incisional scar that increases with coughing/straining. Edges of the hernial defect are palpable upon reduction of the hernia. Patients may be asymptomatic or present with nonspecific symptoms such as postprandial fullness. Plus treatment 221/39. Copyright elective surgical repair, usually with mesh, is typically recommended. 1 SLL40 LL41. Conservative management may be considered in patients at high risk for perioperative morbidity, example patients with COPD. CLIA. Scent complications 2235, copyright strangulation or obstruction, up to 20% of patients with a ventral hernia will require emergency surgery. Recurrence after repair, 15 to 25% of repaired incisional hernias recur. 35-143 Scent peristomal hernia. Copyright a type of incisional hernia in which intra-abdominal contents protrude through the abdominal wall. Defect created during stoma placement, example colostomy. 30. Copyright diagnosis, usually clinical, imaging, CT or ultrasound, may be considered if the diagnosis is uncertain. AAA. Umbilical hernia. Umbilical hernias are defined as midline hernias at the level of the umbilicus. 90% of umbilical hernias are acquired, usually as a result of increased abdominal pressure. 2I3. Epidemiology. Site of hernial defect. Etiology. Risk factors. Clinical features. Risk of developing complications, incarceration, obstruction, strangulation, or rupture. Treatment. Nepharyngeal back. Congenital versus acquired umbilical hernias 44. Congenital umbilical hernia, 45, 46 147. 10 to 20% of infants born at term have a congenital hernia. Umbilical orifice. Delayed spontaneous closure of the umbilical ring following physiological herniation of the midgut patent umbilical orifice. For more information, see embryology in gastrointestinal tract. Persistently raised intra-abdominal pressure. Other congenital anomalies, example Down syndrome, trisomy 18, congenital hypothyroidism. Mass that protrudes through the umbilicus covered by skin. Mass increases with increased abdominal pressure, example as a result of crying, coughing, straining, reduces in size in recumbent position. Hernia can be completely reduced, unless incarcerated. Low. Conservative, 90% will spontaneously close by 2 years of age. Surgery, rarely necessary. Copyright large umbilical hernias, defect 1.5 to 2 centimeters, in children 2 to 3 years of age. Copyright no evidence of spontaneous closure by 5 years of age. Copyright patients with incarcerated, obstructed, or strangulated umbilical hernias. Omphalocele, gastroschisis, see overview of abdominal wall defects, 4VNA collapse. Acquired umbilical hernia, IL4. 10% of all adult abdominal hernias are acquired umbilical hernias. 3 direct, umbilical orifice indirect, para-umbilical hernia adjacent to the umbilical orifice. Reopening of the previously closed umbilical ring or surrounding tissue CIIAD. Persistently raised intra-abdominal pressure. Direct hernia, mass that protrudes symmetrically through the umbilicus. Indirect hernia, mass that protrudes adjacent to the umbilical orifice, pushing the umbilicus into a crescent shape. Facial defect is often small. Low, but higher than in congenital umbilical hernias. 44. Surgical repair, usually with mesh. Conservative management may be appropriate for small, asymptomatic hernias. Epigastric hernia. Snealian hernia. Find text. O. Outline. X abdominal hernias. Plus clinical features, 22,391 copyright mass or protrusion at the site of the incisional scar that increases with coughing/straining. O edges of the hernial defect are palpable upon reduction of the hernia. Copyright patients may be asymptomatic or present with nonspecific symptoms such as postprandial fullness. Plus treatment 22,139. Copyright elective surgical repair, usually with mesh, is typically recommended. 30-40-41 Copyright conservative management may be considered in patients at high risk for perioperative morbidity, example patients with COPD. Kale * complications 221-35. Copyright strangulation or obstruction, up to 20% of patients with a ventral hernia will require emergency surgery. 30. Recurrence after repair, 15 to 25% of repaired incisional hernias recur. 35 plus peristomal hernia %. 1L4S Copyright a type of incisional hernia in which intra-abdominal contents protrude through the abdominal wall. Defect created during stoma placement, example colostomy. Copyright diagnosis, usually clinical, imaging, CT or ultrasound, may be considered if the diagnosis is uncertain. AA. O. OES. Umbilical hernia. Umbilical hernias are defined as midline hernias at the level of the umbilicus. 90% of umbilical hernias are acquired, usually as a result of increased abdominal pressure. 2IL3. Congenital versus acquired umbilical hernias 44. Congenital umbilical hernia, 4I 46, 47 Acquired umbilical hernia, 14. Epidemiology. 10 to 20% of infants born at term have a congenital hernia, * 10% of all adult abdominal hernias are acquired umbilical hernias. 3. Direct, umbilical orifice. Indirect, para-umbilical hernia adjacent to the umbilical orifice site of hernial defect. Umbilical orifice. Delayed spontaneous closure of the umbilical ring following physiological reopening of the previously closed umbilical ring or surrounding tissue. Etiology. Herniation of the midgut patent umbilical orifice. For more information, see embryology in gastrointestinal tract. Persistently raised intra-abdominal pressure are risk factors. Other congenital anomalies, example Down syndrome, trisomy 18, congenital persistently raised intra-abdominal pressure. A. Hypothyroidism. Direct hernia, mass that protrudes symmetrically through the umbilicus. WI a mass that protrudes through the umbilicus covered by skin. MS mass increases with increased abdominal pressure, example as a result of crying. Clinical features coughing, straining, reduces in size in recumbent position pushing the umbilicus into a crescent shape. MS hernia can be completely reduced, unless incarcerated. Indirect hernia, mass that protrudes adjacent to the umbilical orifice. Facial defect is often small. Risk of developing complications = degree = incarceration, obstruction, low, but higher than in congenital umbilical hernias. A44 strangulation, or rupture. Conservative, 90% will spontaneously close by 2 years of age, surgery, rarely necessary, surgical repair, usually with mesh. Conservative management may be appropriate for small, degree-large umbilical hernias, defect 1.5 to 2 cm, in children 2 to 3 years of age. Treatment. Copyright no evidence of spontaneous closure by 5 years of age. Copyright patients with incarcerated, obstructed, or strangulated umbilical hernias. Asymptomatic hernias 1. Epigastric hernia. Omphalocele, gastroschisis. See Overview of abdominal wall defects. A. Spigelian hernia. Epigastric hernia. Differential diagnosis. Incisional hernia 0. 6. Up to 20% of patients with cirrhosis develop an umbilical hernia. 30. Back collapse. Find text outline. Linea alba degree rectus abdominis muscle. Epigastric hernia. Epigastric hernia VV herniation of intra-abdominal contents through the linea alba, between the xiphoid process and the umbilicus. Copyright Boss. Epigastric hernia. Photograph of the abdomen of a female patient, lateral view, the epigastric region of the abdomen is bulging ventrally. This appearance is suggestive of an epigastric hernia. Source, Figure 1 in, endoscopic assisted linea alba reconstruction plus mesh augmentation for treatment of umbilical and/or epigastric hernias and rectus abdominis diastasis. Early results by Ferdinand Keckerling, Marinos Damianos Botsinas, Christine Rode, and Wolfgang Reinpold, Frontierson, licensed under CC by 4.0. Copyright. Overlay. Epigastric hernia with colocutaneous fistula. CT abdomen, with contrast, axial plane, a midline epigastric hernia, green arrowheads, contains transverse colon, TC. A colocutaneous fistula has formed, with necrosis, N, visible near the skin surface. RK, right kidney source, Fig 2, in, severe mental illness, a contraindication to watchful waiting in hernia management, by Milne D.M., Narain V., Gulcharan S., Curious, licensed under CC by 4.0. Uroabdominal hernias, 4/16. Simon Delays D. Pell W. Cobb. Copyright. Overlay. Peristomal hernia VV. CT abdomen and pelvis, with contrast, axial plane, of a patient with a history of left lower quadrant colostomy. A large peristomal hernia, arrowheads and green overlay, contains portions of the stomach, S, mesentery, M, small bowel, SB, and colon, C. K, contrast enhanced left kidney source, Fig 1, in, gastric peristomal hernia, a case report of a rare yet fascinating clinical entity by Wahid A., Zeller P.E., Bishop P.J., Robinson S.K., Tuma F., Curious, licensed under CC by 3.0. Modifications, removed arrow. Uroabdominal hernias, 4/16. 5 minutes delays Appel WW Co R. Overlay. Peristomal hernia VV. CT abdomen and pelvis, with contrast, axial plane, of a patient with a history of left lower quadrant colostomy. A large peristomal hernia, arrowheads and green overlay, contains portions of the stomach, S, mesentery, M, small bowel, SB, and colon, C. K, contrast enhanced left kidney source, Fig 1, in, gastric peristomal hernia, a case report of a rare yet fascinating clinical entity by Wahid A., Zeller P.E., Bishop P.J., Robinson S.K., Tuma F., Curious, licensed under CC by 3.0. Modifications, removed arrow. Serratus posterior inferior muscle. Superior lumbar hernia, Grenfell hernia, through the superior triangle _atissimus dorsi muscle. Sternal oblique muscle me external oblique muscle. Inferior lumbar hernia internal oblique muscle, Petit hernia, through the inferior lumbar triangle iliac crest. Lumbar hernias. Lumbar hernias VV. Superior lumbar hernia, Grenfell hernia herniation of intra-abdominal contents through the superior lumbar triangle, the boundaries of which are the 12 rib, the erector spinae muscle, and the internal oblique muscle. Inferior lumbar hernia, Petit hernia herniation of intra-abdominal contents through the inferior lumbar triangle, the boundaries of which are the iliac crest, the latissimus dorsi, and the external oblique muscle. Copyright Boss. Transverse degree abdominal muscle of linea I, rectus. Semilunaris, abdominis / muscle arcuate line / Spigelian hernia. Spigelian hernia VV. Herniation of intra-abdominal contents through the semilunar line, commonly adjacent to the arcuate line, typically below the umbilicus. The semilunar line is the lateral border of the rectus abdominis. The arcuate line is the inferior border of the posterior rectus sheath. The lack of posterior rectus sheath below the arcuate line is assumed to predispose this region to hernia formation. Copyright Boss. Spigella in hernia. Photograph of the anterior abdominal wall of a female patient. An ill-defined swelling is visible just lateral to the left rectus abdominis muscle, i.e., along the semilunar line. Examination of the mass showed a positive cough impulse. This is the typical appearance of a Spigella in hernia, an uncommon ventral hernia. Source: Hernia Spiegeli 01 by Afro-Brazilian, Wikimedia Commons, licensed under CC by SA 3.0. Inferior API gastric vessels. Peritoneum with transition to tunica vaginalis subserosa transversalis fascia with transition to internal spermatic fascia transversus abdominis muscle obliterated processus vaginalis abdominal internal oblique muscle with transition to cremaster muscle with cremasteric fascia external abdominal oblique muscle and superficial abdominal fascia with transition to external spermatic fascia. Normal direct inguinal hernia. Indirect inguinal hernia. Direct and indirect inguinal hernias VV. Normally, the only contents of the inguinal canal are the spermatic cord, or round ligament in females, and the ilioinguinal nerve. Direct inguinal hernia, herniation of intra-abdominal contents through the posterior wall of the inguinal canal, medial to the inferior epigastric vessels. The hernial sac lies posteromedial to and outside the spermatic cord. Indirect inguinal hernia, herniation of intra-abdominal contents through the deep inguinal ring into the inguinal canal, and, in the case of large inguinal hernia, also through the superficial inguinal ring. The hernial sac lies within the spermatic cord and is therefore covered by the same tissue layers as the spermatic cord. Copyright Boss. Inguinal hernia. Pelvic and inguinal region. There is a pronounced protrusion on the right side, circled. Inguinal hernia can be confirmed with palpation and a cough test. Source: Hernia by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Abdominal hernias, 10/16. Superficial abdominal fascia with aponeurosis of the external abdominal oblique muscle transverse abdominal muscle. Abdominal internal oblique muscle transversalis fascia. Peritoneum. Femoral hernia V. Sagittal view of the male inguinal region at the level of the superior pubic ramus, medial to the epigastric vessels. There is a protruding hernial sac, comprised of the transversalis fascia and parietal peritoneum, below the inguinal ligament but above the pubic bone, which, in the example shown, contains intestine. Copyright Boss. Inguinal ligament superficial inguinal ring. Saphenous opening. Femoral vessel. Peritoneum transversalis fascia fascia lata. Great saphenous vein. Femoral hernia V. Femoral hernia passes through the vascular lacuna, internal hernial orifice, below the inguinal ligament and usually medial to the femoral vein and runs through the femoral canal until it reaches the saphenous opening, external hernial orifice, approximate 2 cm caudal. The saphenous opening typically contains loose connective and fatty tissue as well as inguinal lymph nodes. Due to the increased width of the female pelvis, and therefore larger vascular lacuna, femoral hernia occurs predominantly in women. Copyright Boss. Obturator foramen external obturator pectineus. Adductor longus. Obturator hernia. Obturator hernia herniation of intra-abdominal contents through the obturator foramen of the pelvis. The hernia passes superior and anterior to the external obturator muscle and lies posterior to the pectineus muscle. Copyright Boss. Ischiocavenosus muscle. Bulbospongiosus muscle deep transverse perineal muscle anterior perineal hernia. Upperficial transverse perineal muscle posterior perineal hernia levator ani muscle ischiorectal hernia external anal sphincter. Gluteus maximus plus muscle. Perineal hernias. Perineal hernias M. Perineal hernias involve herniation of intra-abdominal contents through a defect in the pelvic floor. There are three types: 1. Anterior perineal hernia, herniation anterior to the superficial transverse perineal muscle. 2. Posterior perineal hernia, herniation posterior to the superficial transverse perineal muscle. 3. Ischiorectal hernia, herniation through the levator ani muscle. Copyright Boss. Se gluteus maximus. 3. Gluteus medius muscle suprapiriform infrapiriform hernia piriformis superior end muscle. EEI spinotuberous OSS by equals hernia internal obturator muscle sacrotuberous. Inferior ligament. Gemellus muscle sciatic nerve. Sciatic hernias. Sciatic hernias. Suprapiriform foramen greater infraperi sciatic form foramen. Sacrospinous ligament. Lesser sciatic foramen. Sacrotuberous ligament. Herniation of intra-abdominal contents through the greater, more common, or lesser sciatic foramen. Hernias through the greater sciatic foramen can be further classified into suprapiriform, more common, and infrapiriform hernias. Copyright Boss. Uroabdominal hernias, 15/16. Hernial orifice abdominal wall. Hernial contents. Hernial sac / Components of an abdominal or inguinal hernia. Abdominal and inguinal hernias have three components: hernial sac, parietal peritoneum surrounding the hernial contents, typically the omentum and / or loops of small intestine, uncommonly, the large intestine, appendix, bladder, fallopian tubes. Hernial coverings, layers of the abdominal wall. The hernial orifice is a hiatus, example the umbilicus, deep inguinal ring, posterior wall of the inguinal canal, through which hernial contents herniate. The hernial contents are constricted at the hernial orifice. This constricted area is known as the neck of a hernia. Copyright Boss. Reducible hernia, irreducible hernia, strangulated hernia. Reducible, irreducible, and strangulated hernias. VV. Reducible hernia, the hernia is easily reducible. Irreducible hernia, the hernia is not easily reducible because its contents adhere to the hernial sac. Strangulated hernia, ischemia of hernial contents resulting from a tight abdominal wall defect compromising the vascular supply of the hernial contents. Copyright Boss. Strangulated inguinal hernia. VV. An ill-defined swelling with erythema of the overlying skin can be seen in the right inguinal region. This is the typical appearance of a strangulated inguinal hernia, which should be differentiated from other causes of erythematous inguinal swellings, example inguinal lymphadenitis, abscess, hematoma, with imaging. Source: Copyright IMPP. Copyright Overlay. Epigastric hernia with colocutaneous fistula. CT abdomen, with contrast, axial plane, a midline epigastric hernia, green arrowheads, contains transverse colon, TC. A colocutaneous fistula has formed, with necrosis, N, visible near the skin surface. RK, right kidney source, Fig 2, in severe mental illness, a contraindication to watchful waiting in hernia management, by Milne D.M., Narain V., Gulcharan S., Curious, licensed under CC by 4.0. Uroabdominal hernias, 2/3. SCV 376 110 m. Overlay. Spigelian hernia VV. CT abdomen, with fore and oral contrast, axial plane, an anterior abdominal wall hernia, yellow overlay, containing fat is seen lateral to the left rectus abdominis muscle. A Spigelian hernia occurs through a defect in the linea semilunaris, a curved vertical line at the lateral margin of each rectus abdominis muscle. Spigelian hernias are usually found in the region of the arcuate line, a horizontal line that demarcates the lower extent of the posterior layer of the rectus sheath. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Spigella and hernia. Created by, wishes to remain anonymous. Licensed under public domain. Modifications to original image, arrow removed. Uroabdominal hernias, 2/3. SCV 376 110M. Copyright. Overlay. Spigella and hernia VV. CT abdomen, with fore and oral contrast, axial plane, and anterior abdominal wall hernia, yellow overlay, containing fat is seen lateral to the left rectus abdominis muscle. A Spigella and hernia occurs through a defect in the linea semilunaris, a curved vertical line at the lateral margin of each rectus abdominis muscle. Spigella and hernias are usually found in the region of the arcuate line, a horizontal line that demarcates the lower extent of the posterior layer of the rectus sheath. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Spigella and hernia. Created by, wishes to remain anonymous. Licensed under public domain. Modifications to original image, arrow removed. Abdominal hernias, 3/3. Overlay. Small bowel obstruction VV. X-ray abdomen, AP view, erect, multiple distended bowel loops, examples indicated by white dashed outlines, are seen, many of which contain air fluid levels, examples indicated by green overlay. A distended colon, with haustra, is not visible. The pattern of the distended loops suggests small bowel obstruction. Stomach source, upright X-ray demonstrating small bowel obstruction. JPG by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications, letter R removed. Abdominal hernias, 3/3. Overlay. Small bowel obstruction VV. X-ray abdomen, AP view, erect, multiple distended bowel loops, examples indicated by white dashed outlines, are seen, many of which contain air fluid levels, examples indicated by green overlay. A distended colon, with haustra, is not visible. The pattern of the distended loops suggests small bowel obstruction. Stomach source, upright X-ray demonstrating small bowel obstruction. JPG by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications, letter R removed. Abdominal hernias, 1/2. Erectus 1 abdominis, / muscle. Linea alba E. Diastasis recti. Diastasis recti. There is an abnormally large separation, greater than 2 cm, between the two rectus abdominis muscles. This results in protrusion of intra-abdominal contents through the linea alba on straining, example coughing, sitting up from a reclined posture, causing a midline bulge. The abdominal fascias, not shown here, remain intact. Copyright Boss. Abdominal hernias, 2/2. Overlay. Rectus sheath hematoma VV. CT abdomen, with contrast, axial plane, of a patient with acute left anterior abdominal pain. There is marked asymmetry in size of the right and left rectus muscles. The enlarged left rectus muscle, green overlay, is heterogeneous, with low and high attenuation components. High attenuation, hatched green overlay, represents a site of contrast-enhanced blood from acute hemorrhage. RRM, right rectus muscle source, axial CT of rectus sheath hematoma, with active bleeding under Mark Umar by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Abdominal hernias, 2/2. Overlay. Rectus sheath hematoma VV. CT abdomen, with contrast, axial plane, of a patient with acute left anterior abdominal pain. There is marked asymmetry in size of the right and left rectus muscles. The enlarged left rectus muscle, green overlay, is heterogeneous, with low and high attenuation components. High attenuation, hatched green overlay, represents a site of contrast-enhanced blood from acute hemorrhage. RRM, right rectus muscle source, axial CT of rectus sheath hematoma, with active bleeding under Mark Umar by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Abdominal hernias, 3/4. Incisional hernia. A bulging mass with an overlying midline laparotomy scar is visible in the epigastric region. These features suggest an incisional hernia. Source, file, hernia epigastrica.png by Paco Paramo, Wikimedia Commons, licensed under CC by SA 3.0. Incisional hernia. A bulging mass is visible in the epigastric region, with an overlying midline laparotomy scar. These features suggest an incisional hernia. Source, Fig 1, in, laparoscopic incisional hernia repair by Kerman A, Beldigi, Intech Open, licensed under CC by 3.0. 5 minutes delays appel www.co.ur. Overlay. Peristomal hernia VV. CT abdomen and pelvis, with contrast, axial plane, of a patient with a history of left lower quadrant colostomy. A large peristomal hernia, arrowheads and green overlay, contains portions of the stomach, S, mesentery, M, small bowel, SB, and colon, C. K, contrast-enhanced left kidney source, Fig 1, in, gastric peristomal hernia, a case report of a rare yet fascinating clinical entity by Wahid A, Zeller P.E., Bishop P.J., Robinson S.K., Tuma F., Curious, licensed under CC by 3.0. Modifications, removed arrow. Uroabdominal hernias, 2/4. Simon Delays D. Pel W. Cobb. Copyright. Overlay. Peristomal hernia VV. CT abdomen and pelvis, with contrast, axial plane, of a patient with a history of left lower quadrant colostomy. A large peristomal hernia, arrowheads and green overlay, contains portions of the stomach, S, mesentery, M, small bowel, SB, and colon, C. K, contrast-enhanced left kidney source, Fig 1, in, gastric peristomal hernia, a case report of a rare yet fascinating clinical entity by Wahid A, Zeller P.E., Bishop P.J., Robinson S.K., Tuma F., Curious, licensed under CC by 3.0. Modifications, removed arrow. Peristomal hernia. Abdominal wall of a 92-year-old woman with a long-established endoleostomy who presented with vomiting and abdominal pain. There is gross circumferential swelling around the stoma. CT showed peristomal herniation of the distal stomach. Source, Fig 1, in, peristomal stomach herniation complicated by gastric outlet obstruction, a case report and literature review by Eastman J., Versto M., Science Direct, licensed under CC by 4.0. Linea alba. Rectus abdominis O muscle. Umbilical hernia. Umbilical hernia VV. Herniation of intra-abdominal contents through the umbilical orifice. A true umbilical hernia herniates through the umbilical orifice and is most common in infants. Congenital umbilical hernia. Most adult umbilical hernias herniate from an abdominal wall defect adjacent to the umbilical orifice, acquired umbilical hernia. Copyright Boss. Para-umbilical hernia. Anterior abdominal wall of an adult. There is a protruding mass adjacent to the right lateral wall of the umbilical orifice. The right lateral wall and cavity of the umbilical orifice are obliterated by the mass, resulting in a crescent-shaped umbilicus. This is the typical appearance of a para-umbilical hernia. Source, Umbilical hernia 01 by Salt Anat, Wikimedia Commons, licensed under CC 1.0. Omphalocele. Umbilical hernia diastasis recti gastroschisis. Congenital malformations of the anterior abdominal wall VV. Omphalocele, herniation of intra-abdominal contents through an anterior abdominal wall defect at the base of the umbilical cord caused by the failure of the midgut to return to the abdominal cavity after its physiological herniation through the umbilical ring. Accordingly, the hernial sac is formed by the amniotic membrane and peritoneum, and the umbilical cord lies at the apex of the hernia. Gastroschisis, a developmental defect of the anterior abdominal wall in the para-umbilical region through which intra-abdominal contents prolapse. As it is the anterior abdominal wall that fails to develop correctly, there is no outer peritoneal or membranous covering. Congenital umbilical hernia, herniation of intra-abdominal contents through a patent umbilical orifice, which typically closes by 2 years of age. The sac of a para-umbilical hernia is the peritoneum. Diastasis recti, an abnormally wide separation of the right and left rectus abdominis muscles. The abdominal fascia are intact. There is therefore no herniation, but a midline bulge is visible on straining, example when trying to sit up. Abdominal hernias, 3/6. Para-umbilical hernia VV. Anterior abdominal wall of an adult. There is a protruding mass adjacent to the superior wall of the umbilical orifice. The cavity of the umbilical orifice is obliterated by the mass, resulting in a crescent-shaped umbilicus. This is the typical appearance of a para-umbilical hernia. Source: Hernia umbilicalis by Millie Weiss, Wikimedia Commons, licensed under CC by SA 3.0. Uroabdominal hernias, 2/6. Umbilical hernia. Anterior abdominal wall of an adult. There is a mass protruding directly through the umbilical orifice. This is the typical appearance of an umbilical hernia, which is rare in adults. Para-umbilical hernias, which protrude through a facial defect adjacent to the umbilical orifice, are more common in adults. Source: Nobelbruch by Here It Comes Doc, Wikimedia Commons, licensed under CC by SA 3.0. Congenital umbilical hernia. Anterior abdominal wall of a newborn. There is a mass 2 cm in diameter protruding through the umbilical orifice. This is the typical appearance of a congenital umbilical hernia, which characteristically increases in size on crying or coughing. Copyright Boss. X. Congenital anomalies of the kidneys. Congenital anomalies of the kidneys and urinary tract, KCUT, are one of the most common malformations diagnosed in newborns. The pathogenesis of KCUT is multifactorial, both specific genes and environmental factors, example in utero exposure to ACE inhibitors, have been implicated in the development of KCUT. Even though most cases are initially asymptomatic, up to 50% of children with end-stage renal disease have an underlying KCUT. For this reason, early identification of these malformations is essential in order to prevent renal damage. W.A. T.E. Seuss. Overview. Anomalies of the collecting system. Cent duplex collecting system, a complete or incomplete duplication of the collecting system, pelvic-calyceal system and ureter, has different clinical manifestations depending on the degree of fusion. Copyright. The most common congenital anomaly of the urinary tract. O complete duplication, an additional ureteric bud forms resulting in two separate ureteric buds that interact with the same metanephric blastema. The affected kidney has two separate pelvic-calyceal systems and two ureters that enter the bladder at different points, double ureter. O incomplete duplication, the ureteric bud splits before interacting with the metanephric blastema. The affected kidney has two collecting systems that merge between the ureteropelvic junction and the urinary bladder, resulting in a single ostium in the bladder. Bifid ureter, the affected kidney has two separate pelvic-calyceal systems and two ureters that merge and share a single ostium into the bladder, Y-shaped ureter. Bifid pelvis, the affected kidney has two separate pelvic-calyceal systems that merge into a single ureter at the ureteropelvic junction. Associated with vesicoureteral reflux, ureteral stricture, hydronephrosis, and UTIO. Ureteroureteral reflux may occur due to Y-shaped ureter. Cent ectopic ureter, the ureter opening is located caudal to the normal insertion site on the bladder. O prenatal hydronephrosis 4, Postnatal UTI copyright. In female individuals, the ureter may bypass the external sphincter and insert directly in the vagina, resulting in incontinence. Sent ureterocele, abnormal dilation of the terminal portion of the ureter, which bulges into the urinary bladder or extends to the bladder neck and the urethra, often appears balloon-shaped on cystoscopy. Prenatal hydronephrosis. Postnatal UTI. Sent ureteropelvic junction obstruction, see article on urinary tract obstruction. Malformation of the renal parenchyma. Renal dysgenesis. Sent renal agenesis, the absence of the kidney and the ureter. OTFZ copyright. Pathophysiology. Ureteric bud does not develop. Complete lack of stimulating signals for differentiation of metanephric blastema. Kidney fails to develop. Unilateral renal agenesis, usually asymptomatic, depending on the condition of the other kidney, see congenital solitary kidney. Bilateral renal agenesis, causes Potter sequence. Sent renal hypoplasia, underdevelopment of the kidney characterized by a reduced number of nephrons. Sent renal dysplasia, abnormal development of the kidney that results in a non-functional kidney with abnormal features, example cysts, increased amount of connective tissue. Pathophysiology, ureteric bud does not properly stimulate differentiation of metanephric blastema. Disorganized nephrons, reduced number of nephrons, and abnormal cells. Copyright. Unilateral dysplasia is usually asymptomatic. See congenital solitary kidney. Bilateral dysplasia leads to early renal insufficiency and Potter sequence if present in utero. Co-examples: polycystic kidney disease, multicystic dysplastic kidneys, obstructive cystic dysplasia, medullary sponge kidney. Copyright. Associated with anomalies of the collecting system that predispose to UTI. Sent renal aplasia, kidney with only rudimentary renal parenchyma present with no residual function. Congenital solitary kidney. Sent definition, the presence of a single functioning kidney due to absence or anomalies of the contralateral kidney. Anatomical congenital solitary kidney, the absence of one kidney due to renal agenesis. Copyright. Functional congenital solitary kidney, a non-functional kidney due to example renal aplasia, severe renal dysplasia or hypoplasia. Sent often asymptomatic and diagnosed during prenatal ultrasound screening. Back collapse. Fine text outline. Often asymptomatic and diagnosed during prenatal ultrasound screening. Sent a solitary kidney is usually hypertrophic to compensate for the contralateral kidney. Higher incidence of anomalies, example vesicoureteral reflux, increased risk of hypertension, renal insufficiency, and progression to end-stage renal disease. Anomalies of kidney migration. Horseshoe kidney, fusion of the left and right inferior renal poles. Normal ascent interrupted as fused kidney gets caught on the inferior mesenteric artery, IMA. Increased incidence in patients with chromosomal aneuploidy, example trisomies 13, 18, 21, and Turner syndrome. Usually asymptomatic, typically diagnosed incidentally on abdominal imaging for unrelated conditions. Rarely requires treatment. Copyright. Increased risk of renal stones, ureteropelvic junction obstruction, hydronephrosis, infections, and renal cancer. Renal dystopia and renal ectopia, displacement of the kidney within the retroperitoneum. Sent cross dystopia, displacement of the kidneys, both kidneys located on the same side of the spine. Sent malrotation, torsion of the orthotopic kidney. CE. Etiology. Sent disturbance of embryonic development. Environmental factors. Sent in utero exposure to ACE inhibitors or angiotensin IL receptor blockers. Juxtaglomerular hyperplasia, absent proximal convoluted tubules, or renal fibrosis. References: OES. Clinical features. Most K-cut are incidental findings with no clinical significance. Sent K-cut are considered clinically significant if they can lead to chronic kidney disease, vesicoureteral reflux, urinary tract infections, hydronephrosis, or urinary incontinence. Sent signs that an underlying clinically significant K-cut may be present include: hydronephrosis on prenatal ultrasound. Copyright. Urinary tract infection in children. 4O. CE. Diagnostics. Ultrasound imaging of the kidneys and bladder. First-line imaging modality. Detects anatomical abnormalities. Renal ultrasound is warranted for all children with recurrent UTIs or UTI in children. Back collapse. Fine text outline. Diagnostics. Ultrasound imaging of the kidneys and bladder. First-line imaging modality. Detects anatomical abnormalities. Renal ultrasound is warranted for all children with recurrent UTIs or UTI in children. References to FU 5. Differential diagnoses. Floating kidney. Scent description. Downward displacement of the kidney due to reduced perirenal fat, thin individuals, anorexia nervosa, hypermobility of the kidney. Scent clinical features. Copyright flank and lower abdominal pain with exacerbation in upright position. Nephroptosis causes painful strain. Copyright alleviation of pain in supine position. Scent diagnostics. Renal ultrasound in upright and supine position. Copyright intravenous pyelogram in upright and supine position. Scent treatment. Copyright conservative, abdominal muscle training and stabilization with abdominal wall binders. Copyright surgical, laparoscopic nephropexy. References 3. The differential diagnoses listed here are not exhaustive. GVO 05. Treatment. Scent. The majority of cases do not require treatment. If there is vesicoureteral reflux, administer antibiotic prophylaxis. See vesicoureteral reflux. If there is vesicoureteral reflux with recurrent cystitis or pyelonephritis, perform surgical correction. Abnormalities of the ureter or its insertion into the bladder, example ureterocele, ectopic ureter, are treated with resection of the distal ureter followed by ureteral reimplantation. Laparoscopic nephrectomy may be indicated in cases with recurrent pyelonephritis and loss of kidney function. WA OIEEE. Sources. Last updated March 23, 2022. Back collapse. Fine text outline. \\pelvis XF cent euro IY X L 7 at I. Copyright 46/ copyright 2 ureteral ET orifices. Duplex collecting systems. Copyright Boss. Knock-McT. Overlay. Horseshoe kidney with hydronephrosis. VV intravenous pyelogram and scintigraph. 35-year-old patient with recurring urinary tract infections. Horseshoe morphology of the kidney. Red overlay, in scintigraphy, which is a predisposing factor for the hydronephrosis. Green overlay, seen in the pyelogram. Hydronephrosis may cause recurring urinary tract infections. Source, copyright IMPP. Knock-McT. Overlay. Horseshoe kidney with hydronephrosis. VV intravenous pyelogram and scintigraph. 35-year-old patient with recurring urinary tract infections. Horseshoe morphology of the kidney. Red overlay, in scintigraphy, which is a predisposing factor for the hydronephrosis. Green overlay, seen in the pyelogram. Hydronephrosis may cause recurring urinary tract infections. Source, copyright IMPP. Urocongenital anomalies of the kidneys, 3/6. Overlay. Horseshoe kidney. Mr. Angiography of the aorta, maximum intensity projection, MIP, a fusion of the two inferior renal poles is clearly visible, green overlay. In addition, an upper renal pole artery on the left side is shown as an anatomical norm variant. Source, Hyophysineaire 01, MRT, Mr. CE Angiography, MIP, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Congenital anomalies of the kidneys, 3/6. Copyright overlay. Horseshoe kidney. Mr. Angiography of the aorta, maximum intensity projection, MIP, a fusion of the two inferior renal poles is clearly visible, green overlay. In addition, an upper renal pole artery on the left side is shown as an anatomical norm variant. Source, Hyophysineaire 01, MRT, Mr. CE Angiography, MIP, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Overlay. Horseshoe kidney VV MRI abdomen, T2 weighted, transverse plane, a fusion of both kidneys ventral to the aorta can be seen, green overlay. Source, Huofizinier 01, MRT, T2 axial, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Copyright overlay. Horseshoe kidney VV MRI abdomen, T2 weighted, transverse plane, a fusion of both kidneys ventral to the aorta can be seen, green overlay. Source, Huofizinier 01, MRT, T2 axial, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes, this image is part of a series. Congenital anomalies of the kidneys, 5/6. Aorta celiac trunk superior mesenteric artery renal artery horseshoe kidney inferior mesenteric artery. Horseshoe kidney VV congenital abnormality of the kidney. Ventral view. Copyright Boss. Overlay. Horseshoe kidney VV. CT abdomen, with contrast, axial plane, the lower poles of the kidneys, green overlay, are fused across the midline by an isthmus of enhancing parenchyma, red overlay. Note the lack of parenchyma at the level of the left renal hilum, indicated by white arrow, which is directed anteriorly as a result of incomplete medial rotation of the kidney along its longitudinal axis. This is a classic appearance of horseshoe kidney. With contrast, source, Huofizinier CT axial by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Horseshoe kidney VV. CT abdomen, with contrast, axial plane, the lower poles of the kidneys, green overlay, are fused across the midline by an isthmus of enhancing parenchyma, red overlay. Note the lack of parenchyma at the level of the left renal hilum, indicated by white arrow, which is directed anteriorly as a result of incomplete medial rotation of the kidney along its longitudinal axis. This is a classic appearance of horseshoe kidney. With contrast, source, Huofizinier CT axial by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Congenital anomalies of the kidneys, 1/1. Overlay. Abdomen and pelvis VV. CT abdomen and pelvis, coronal view, H, esophagus, 1, spleen, 2, left kidney, 3, bowel, 4, psoas muscle, 5, right kidney, 6, liver. No pathologic features are noted. Source, copyright IMPP. X. Polycystic kidney disease. Polycystic kidney disease, PKD, is an inherited disorder characterized by the development of multiple cysts in the kidneys. It is classified into two distinct disorders, autosomal recessive PKD, ARPKD, and autosomal dominant PKD, ADPKD. ARPKD manifests with severe pulmonary insufficiency and progressive renal failure with onset during infancy or early childhood. If left untreated, ARPKD is typically lethal before adolescence. ADPKD manifests with flank pain, arterial hypertension, and progressive kidney disease with onset in adulthood. Early diagnosis and treatment may prevent or delay end-stage renal disease in both conditions, but kidney transplantation is the only curative treatment option. W.A.S.S. Epidemiology. Incidence copyright ADPKD, 1/1,000. Equals the most common inherited cause of chronic kidney disease. 2 equals responsible for 5 to 10% of end-stage renal disease, ESRD. 3 copyright ARPKD, 1/20,000. Number 1. Prevalence, 140,000 patients with polycystic kidney disease in the U.S., 5, plus sex, 7 equals 24. Epidemiological data refers to the U.S., unless otherwise specified. IEEE. Etiology. Plus ADPKD 71, East autosomal dominant inheritance county complete penetrance but variable expressivity copyright mutation in 8, L9, equals PKD1 on chromosome 16, 85% of cases, the gene that encodes polycystin 1 or equals PKD2 on chromosome 4, 15% of cases, the gene that encodes polycystin 2 copyright positive family history, 1 cent ARPKDO autosomal recessive inheritance O mutation in PKHD1 gene on chromosome 6, the gene that encodes for fibrocystin, a protein involved in the maintenance of primary cilia of the renal collecting duct and biliary epithelial cells. Pathophysiology. ADPKD. CENT2 hid hypothesis O inherited mutation in one allele of PKD1, polycystin 1, or PKD2, polycystin 2, genes, 1, 10 equals polycystin 1, involved in cell-cell and /or cell matrix interactions polycystin 2, a non-selective cation channel transporting Ca2** copyright additional second somatic acquired mutation in tubule epithelial cells abnormal cilia-mediated signaling pathways formation and expansion of cysts in the renal cortex and medulla compression of renal vessels with activation of the renin-angiotensin-aldosterone system, RAAS, ischemia, and destruction of the kidney parenchyma, 11, ARPKD. CENT inherited mutation in the PKHD1 gene defective fibrocystin, also called polyductin, cystic dilation of collecting ducts and bile ducts, intrahepatic and extrahepatic bile ducts, 12. WA. Back collapse fine text outline. Clinical features. ADPKD, 5. CENT symptom onset O symptoms usually occur after 30 years of age, but the disease may also manifest during childhood. 1O symptoms are less severe and tend to manifest later in individuals with the PKD2 mutation compared to those with the PKD1 mutation. 13 CENT renal manifestations O gross hematuria O flank or abdominal pain O recurrent urinary tract infections E nephrolithiasis O kidneys might be palpable and enlarged on abdominal exam, they are usually normal at birth, copyright signs of chronic kidney disease, example hypertension, fluid overload, uremia, plus extrarenal manifestations, O multiple benign hepatic cysts, prevalence increases with age, copyright cysts may also occur in the pancreas, spleen, ovary, and testicles. Copyright cerebral berry aneurysm, 8%. 14 equals the risk is higher in patients with a family history positive of ADPKD. Equals may rupture and cause subarachnoid hemorrhage, the risk for growth and rupture is the same in patients with ADPKD as in the general population. Copyright cardiovascular 1 equals signs of arterial hypertension, example morning headaches, through increased renin production equals heart valve defects, particularly mitral valve prolapse, equals left ventricular hypertrophy equals potential association with coronary artery aneurysm and aortic aneurysm copyright diverticulosis, abdominal or inguinal hernias. Rome. FA-WER. ARPKD. CENT symptom onset, symptoms most commonly manifest in infancy or childhood. CENT renal manifestations copyright protruding abdomen, non-tender abdominal mass, due to bilateral renal enlargement and /or hepatomegaly OC chronic renal failure, frequently hematuria, proteinuria, and oliguria e severe in utero renal impairment oliguria in utero maternal oligohydramnios Potter sequence equals craniofacial abnormalities, retrognathia, low-set ears, flat nose, and clubbed feet pulmonary hypoplasia respiratory insufficiency in neonates, extrarenal manifestation O. Hypertension / early manifestation, 4, equals often not responsive to monotherapy equals can result in complications if inadequately controlled, example cardiac hypertrophy, heart failure, cerebrovascular diseases, progressive renal impairment, copyright liver involvement, congenital hepatic and portal fibrosis, progressive liver failure and portal hypertension. WA. CES. Diagnostics. Imaging. Plus ultrasound 950 advocate in adults, enlarged kidneys with multiple cysts bilaterally of varying sizes, anechoic masses, equals in children, evidence of cysts in combination with a family history positive of advocate equals hepatic, pancreatic, and/or splenic cysts may be visible. ORPCADE equals enlarged kidneys with multiple cysts bilaterally of equal size equals diffuse increased echogenicity, despite the presence of liquid-filled cysts, anechoic, equals hepatic cysts equals hepatic and portal fibrosis CEO not the method of choice. Copyright should only be used if ultrasound findings are unclear, due to the radiation exposure of CT. Back collapse fine text outline. Not the method of choice. Copyright should only be used if ultrasound findings are unclear, due to the radiation exposure of CT, degree shows equals multiple cysts, usually hypodense, well demarcated, not septated, and thin-walled equals bilateral enlargement of the kidneys. Mr. Angiography, screening for Berry aneurysms in patients with advocate is recommended in the following scenarios. 16-0 family history of aneurysm. Copyright prior to extensive elective surgeries, example transplantation, degree occupations in which unconsciousness represents a public safety risk, example driver, the patient wishes to be screened. Further diagnostic tests. Scent genetic testing, DNA linkage analysis to identify advocate1 and advocate2, often not necessary. 9. Laboratory measures, to evaluate and monitor renal function. Copyright blood cell count, can show renal anemia, creatinine clearance. Copyright urinalysis, can show proteinuria, hematuria, scent, diagnostic laparoscopy and liver biopsy, in ambiguous cases. Pathology. Advocate. Copyright progressive cystic dilatation of the kidney tubular system. Copyright cystic dilation in other organs such as liver and pancreas. Left ventricular hypertrophy. Copyright vascular dolichoectasias, elongations and distensions of the arteries caused by weakening of the vessel walls. Cardiac valvular abnormalities, example defects of the mitral valve and the aortic root, annulus, and/or valve. Arpcade. Copyright cystic dilatation of the collecting ducts. Other nephron segments are usually not affected. Hepatic fibrosis, see pathology section in cirrhosis. Differential diagnoses. Renal cysts. See renal cysts. Acquired cystic kidney disease. Etiology. No gene mutation. Copyright typically seen in advanced chronic kidney disease, especially in patients on renal replacement therapy. Clinical features. Small, usually bilateral cysts. Copyright multiple cysts, 4 cysts per kidney. Back collapse fine text outline. Clinical features. Small, usually bilateral cysts. Copyright multiple cysts, 4 cysts per kidney. Small to normal size kidney. Complications, cyst infection or bleeding, renal cell carcinoma. Diagnostics, ultrasound. Treatment, see treatment in renal cysts. Prevention, prevent or delay progression to ESRD, see treatment below. Multicystic dysplastic kidneys. Definition, renal dysplasia with multiple cystic dilatations of nephrons during embryonic development. Etiology, predominantly non-hereditary. Pathophysiology. Copyright sporadic occurrence during embryonic development of the ureter and nephrons. Defective interaction of the ureteric bud and the metanephric mesenchyme. Non-functional kidney with multiple cysts and connective tissue. Clinical features. Onset, birth to childhood. Rarely symptomatic. Copyright large cysts might impair urinary output, due to constriction of the urinary tract. Usually unilateral cysts. In the case of bilateral involvement equals Potter sequence, due to oligohydramnios, equals spontaneous abortion in case of failure of amniotic fluid production. Copyright renal insufficiency is rare. Extrarenal manifestations, equals congenital heart defects equals esophageal or intestinal atresia equals spinal anomalies equals vectoral association. Scent diagnostics, ultrasound showing unilateral, rarely bilateral, cysts of varying size. Scent treatment e-surveillance in most cases copyright nephrectomy is indicated in severe cases, example hypertension, progression of cyst growth, scent prognosis OE most cases regress spontaneously copyright the non-dysplastic kidney usually functions properly and takes over the function of two kidneys. Autosomal dominant tubulointerstitial kidney disease, @CADE, 17. Scent definition, a group of rare kidney diseases characterized by tubular damage and interstitial fibrosis in the absence of glomerular lesions. Scent etiology. Copyright the three major genetic causes include autosomal dominant mutation of one of the following genes, 18UMOD, encoding uromodulin, 70% of cases, MUC1, encoding mucin 1, 30% of cases, 1-REN, encoding renin. Scent pathophysiology EO@CADE due to UMOD mutation accumulation of uromodulin within the cells of the thick ascending loop of Henle mitochondrial dysregulation tubular cell death chronic kidney disease uromodulin production apical expression of the NAK2Cl cotransporter T natriuresis compensatory proximal tubular sodium reabsorption secondary increase in proximal urate reabsorption, hyperuricemia EO@CADE due to MUC1 mutation, possible dominant negative or gain of function effect of MUC1 mutation OAT-CADE due to REN mutation, accumulation of preprorenin in the renal tubular cells apoptosis chronic kidney disease Scent clinical features O small to normal size kidney copyright signs of chronic kidney disease, example hypertension, fluid overload, uremia, OESRD usually develops between 30 to 60 years of age. Copyright occasional bilateral cysts, mostly medullary O absent or minimal proteinuria with a bland urine sediment. Co-at-CADE due to UMOD mutation, gout since the adolescence. Copyright clinical findings associated with low renin in at-CADE due to REN mutation equals low to normal blood pressure equals hypoproliferative anemia in childhood equals mild hyperkalemia equals hyperuricemia Scent diagnostics O ultrasound equals small kidneys in advanced stages of CKD equals medullary cysts can rarely be seen copyright genetic analysis provides a definitive diagnosis. Back collapse fine text outline. Scent diagnostics O ultrasound equals small kidneys in advanced stages of CKD equals medullary cysts can rarely be seen O genetic analysis provides a definitive diagnosis Scent pathology, tubulointerstitial fibrosis Scent treatment O curative, kidney transplantation O treatment of chronic kidney disease O at-CADE due to UMOD mutation, allopurinol for gout Co at-CADE due to REN mutation, fludrocortisone or high-sodium diet may be used for low blood pressure, hyperkalemia, and to potentially preserve kidney function. Prognosis, poor, due to progression of chronic kidney disease, FN7 medullary sponge kidney. Definition, calcified cysts originating from the collecting ducts and/or tubules in one or both kidneys epidemiology degree. 1/5,000 persons degree 12 to 20% of patients with calcific renal stones OFO the mean age of diagnosed patients is 27 years etiology most cases are sporadic some cases are attributed to genetic mutations, pathophysiology, disruption at the ureteric bud-met-nephric mesenchyme interface distal tubular acidification defect T urine pH and urinary stasis in the dilated ducts calcium phosphate and/or calcium oxalate lithogenesis clinical features usually asymptomatic. Incidental finding, copyright signs of nephrolithiasis, example colicky flank pain, copyright signs of urinary tract infection, example polyuria, dysuria, hematuria painful excretion of small stones with the urinary flow is common diagnostics ultrasound, dilatation of collecting ducts, cysts, and/or kidney stones, nonspecific, contrast CT urography, parallel striations from contrast which extend from the papilla to the medulla and persist on delayed imaging, papillary blush. IVP, irregular ectatic medullary collecting ducts, classic paintbrush-like appearance. Treatment copyright prophylactic treatment of kidney stones with thiazide diuretics, high fluid intake, and/or potassium citrate O extracorporeal shockwave lithotripsy for stones in collecting tubule O. In rare cases of kidney failure, renal dialysis may be required. Complications O recurrent UTIs can lead to renal obstruction. Copyright dilatation of the collecting ducts, impaired renal filtration plus metabolic acidosis O rarely, renal tubular acidosis, ESRD. Nephronophthisis, NPHP. Scent definition: a hereditary cystic kidney disease that typically manifests in childhood, characterized by renal ciliopathy, reduced renal concentration ability, and progression to ESRD plus epidemiology 2 degrees. Copyright incidence, 1/1,000,000 in the U.S. Copyright one of the most common genetic disorders leading to ESRD in children. Scent etiology O autosomal recessive inheritance pattern O mutations in genes encoding nephrocystin protein. Scent clinical features copyright similar clinical and histopathological features as ADCADE O renal manifestations equals multiple, bilateral, mostly corticomedullary, kidney cysts equals polyuria, polydipsia, due to impaired ability to concentrate urine, equals signs of chronic tubulointerstitial nephritis equals signs of chronic kidney disease, example hypertension, fluid overload, anemia, uremia, equals ESRD usually develops before the age of 20 years. 21 Copyright extrarenal manifestations, 10 to 20% of cases, include retinal defects, liver fibrosis, skeletal abnormalities, cardiac defects, or brain developmental disorders. Scent diagnostics. Back collapse. Fine text outline. Scent diagnostics. A renal ultrasound may reveal corticomedullary cysts. Copyright genetic analysis allows definitive diagnosis. Scent treatment. O treatment of chronic kidney disease. E curative, kidney transplantation. Obstructive cystic dysplasia. Scent definition: renal dysplasia and cystic dilatation secondary to obstruction in the urinary tract, example ureteral stenosis, urethral agenesis, during fetal development. Etiology O ureteral stenosis O posterior urethral valves O bladder outlet obstruction O urethral agenesis E duplex collecting system with obstructing ureterocele. Copyright congenital vesicoureteric junction obstruction. Scent pathophysiology, urinary tract obstruction, urine retention in functioning nephrons, formation of glomerular cysts in the nephrogenic zone. Scent clinical features copyright onset, birth to childhood. Copyright during pregnancy, oligohydramnios. Copyright the cause, the severity, and the timing of the obstruction determine the extent of symptoms equals asymptomatic in mild cases equals acute renal failure in severe cases. O extrarenal manifestations equals congenital heart defects equals CNS anomalies equals bacterial association. Scent diagnostics, ultrasound showing unilateral or bilateral cysts of varying size. Cysts are usually smaller than those seen in patients with multicystic dysplastic kidneys. 22 Scent treatment, elimination of the obstruction as a curative approach, example urethral valve ablation, von Hippel-Lindau disease. Scent C. von Hippel-Lindau disease. The differential diagnoses listed here are not exhaustive. WA. OES. Treatment. Scent treatment/prevention of renal dysfunction. ACE inhibitors, ACEs, or angiotensin receptor blockers, ARBs, to prevent/treat hypertension as well as to slow proteinuria and ESRD progression. Copyright tolvaptan. Equals indicated in patients with rapidly progressing ADPKD and mild chronic kidney disease. GFR equals 25 ml/min/1.73 m2 and/or chronic kidney function estimated between 30 to 90%. 23 equals slows down the growth of kidney cysts in ADPKD patients equals delays progression to ESRD. O early treatment of urinary tract infections, to prevent renal cyst infection. Copyright high fluid intake to prevent kidney stone formation and to possibly slow cyst progression. Copyright avoid nephrotoxic substances, example NSAIDs. Sulfonamide antibiotics, aminoglycosides. Copyright avoid ADH, vasopressin may stimulate cyst growth. Scent in severe cases, Example ESRD-OE hemodialysis or peritoneal dialysis. Copyright kidney transplantation is the only curative option. See also end-stage renal disease. Portosystemic shunting or liver transplantation may be required in ARPCADE patients with severe hepatic involvement. Copyright treatment of complications, example portal hypertension, subarachnoid hemorrhage, sent general measures. Regular sonographic monitoring and laboratory evaluation of renal function. Regular sonographic and laboratory monitoring of liver and treatment of hepatic failure. Genetic counseling. OOES. Prognosis. ADPCADE. Back collapse. Fine text outline. X. Polycystic kidney disease. Urethral agenesis. Duplex collecting system with obstructing ureterocele. Copyright congenital vesicoureteric junction obstruction. Scent pathophysiology, urinary tract obstruction, urine retention in functioning nephrons, formation of glomerular cysts in the nephrogenic zone. Scent clinical features. Copyright onset, birth to childhood. Copyright during pregnancy, oligohydramnios. Copyright the cause, the severity, and the timing of the obstruction. Determine the extent of symptoms. Asymptomatic in mild cases. Acute renal failure in severe cases. Extrarenal manifestations. Congenital heart defects. CNS anomalies. Bacterial association. Scent diagnostics, ultrasound showing unilateral or bilateral cysts of varying size. Cysts are usually smaller than those seen in patients with multicystic dysplastic kidneys. 22. Scent treatment, elimination of the obstruction as a curative approach, example urethral valve ablation, von Hippel-Lindau disease. Scent. C. Von Hippel-Lindau disease. The differential diagnoses listed here are not exhaustive. WZ. Degree IEEE. Treatment. Scent treatment / prevention of renal dysfunction. Degree ACE inhibitors, ACEs, or angiotensin receptor blockers, ARBs, to prevent / treat hypertension as well as to slow proteinuria and ESRD progression. Copyright tolvaptan indicated in patients with rapidly progressing ADPCADE and mild chronic kidney disease. GFR equals 25 ml min / 1.73 m2 n or chronic kidney function estimated between 30 to 90%. 23 equals slows down the growth of kidney cysts in ADPCADE patients equals delays progression to ESRD. Copyright early treatment of urinary tract infections, to prevent renal cyst infection. Copyright high fluid intake to prevent kidney stone formation and to possibly slow cyst progression. Avoid nephrotoxic substances, example NSAIDs, sulfonamide antibiotics, aminoglycosides. Copyright avoid ADH, vasopressin may stimulate cyst growth, in severe cases, example ESRD. Hemodialysis or peritoneal dialysis. Kidney transplantation is the only curative option. See also end-stage renal disease. Portosystemic shunting or liver transplantation may be required in ARPCADE patients with severe hepatic involvement. Copyright treatment of complications, example portal hypertension, subarachnoid hemorrhage. Scent general measures. Regular sonographic monitoring and laboratory evaluation of renal function. Regular sonographic and laboratory monitoring of liver and treatment of hepatic failure. Copyright genetic counseling. Fuonage. Prognosis. ADPCADE. 50% of ADPCADE patients have ESRD requiring dialysis by the age of 60 years. Copyright chronic hypertension and cerebral aneurysms, in particular, are associated with a poor prognosis. ARPCADE. Neonates with severe cystic dilatation have a poor life expectancy. Probability of death within the 1 degree year of life is 30%. 125-26. Copyright the majority of children who survive infancy have a life expectancy greater than 10 years. 25. Copyright the prognosis depends on the extent of renal and hepatic impairment, renal cysts and enlargement lead to systemic hypertension and progressive renal failure. Progressive portal hypertension and hepatic fibrosis lead to liver failure. Back collapse. Fine text outline. Polycystic kidney disease, 1/1. Autosomal dominant polycystic kidney disease extrarenal manifestations. Renal manifestations: flank or abdominal pain. Mitral valve prolapse. 7/enlarged kidneys with multiple cysts. Chronic kidney disease. Hypertension. Hepatic cysts. Degree: B. Recurrent urinary tract diverticulosis infections. Li. E. Gross hematuria. Autosomal dominant polycystic kidney disease. Copyright Boss. Uropolycystic kidney disease, 1/4. Overlay. Polycystic kidneys in polycystic kidney disease. VV. Ultrasound kidney, longitudinal view. Note that the poles of the kidney extend beyond this view. Multiple, sharply demarcated anechoic lesions, green overlay, have replaced the majority of the renal parenchyma. Part of the renal sinus, red overlay, is still visible. These findings are consistent with polycystic kidney disease. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Uropolycystic kidney disease, 1/4. Overlay. Polycystic kidneys in polycystic kidney disease. VV. Ultrasound kidney, longitudinal view. Note that the poles of the kidney extend beyond this view. Multiple, sharply demarcated anechoic lesions, green overlay, have replaced the majority of the renal parenchyma. Part of the renal sinus, red overlay, is still visible. These findings are consistent with polycystic kidney disease. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 2/4. DR60. Overlay. Liver involvement in polycystic kidney disease. VV. Ultrasound liver, transverse plane, of a patient with autosomal dominant polycystic kidney disease, ADPKD, multiple rounded, anechoic lesions, green overlay, are seen within the liver parenchyma. Hyperechoic posterior acoustic enhancement artifact, white overlay, is visible, indicating that the structures are fluid-filled. The findings are consistent with liver cysts. Polycystic liver disease is a major extrarenal manifestation of ADPKD. The cystic structures, which result from structural changes of biliary tree development, may not present until adulthood. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 2/4. Overlay. Liver involvement in polycystic kidney disease. VV. Ultrasound liver, transverse plane, of a patient with autosomal dominant polycystic kidney disease, ADPKD, multiple rounded, anechoic lesions, green overlay, are seen within the liver parenchyma. Hyperechoic posterior acoustic enhancement artifact, white overlay, is visible, indicating that the structures are fluid-filled. The findings are consistent with liver cysts. Polycystic liver disease is a major extrarenal manifestation of ADPKD. The cystic structures, which result from structural changes of biliary tree development, may not present until adulthood. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Uropolycystic kidney disease, 3/4. Overlay. Autosomal dominant polycystic kidney disease, ADPKD. CT abdomen, with contrast, coronal plane, both kidneys are markedly enlarged and feature multiple round to ovoid, hypodense lesions of various sizes, examples indicated by green overlay, compatible with cysts. Some smaller cysts are present in the liver, examples indicated by red overlay. Contrast-enhanced renal parenchyma is seen between the cysts, yellow overlay. The CT features are consistent with autosomal dominant polycystic kidney disease, ADPKD. B. Bladder, L. Liver, SB, small bowel source, CT scan autosomal dominant polycystic kidney disease by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. Uropolycystic kidney disease, 3/4. Copyright. Overlay. Autosomal dominant polycystic kidney disease, ADPKD. CT abdomen, with contrast, coronal plane, both kidneys are markedly enlarged and feature multiple round to ovoid, hypodense lesions of various sizes, examples indicated by green overlay, compatible with cysts. Some smaller cysts are present in the liver, examples indicated by red overlay. Contrast-enhanced renal parenchyma is seen between the cysts, yellow overlay. The CT features are consistent with autosomal dominant polycystic kidney disease, ADPKD. B. Bladder, L. Liver, SB, small bowel source, CT scan autosomal dominant polycystic kidney disease by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. Uropolycystic kidney disease, 4/4. Polycystic liver. Diagnostic laparoscopy of the liver. Numerous, variably sized, fluid-filled structures are seen on the surface of the liver. These findings are consistent with polycystic liver disease, which is commonly associated with polycystic kidney disease. Source: copyright IMPP. Polycystic kidney disease, 1/2. Hepatic cysts in autosomal dominant polycystic kidney disease (BV). Gross pathology: liver specimen, cross-section, multiple, variably sized, thin-walled lesions are visible within the liver parenchyma. These findings are consistent with polycystic liver disease, which is associated with autosomal dominant polycystic kidney disease. Source: copyright IMPP. Uropolycystic kidney disease, 2/2. Multiple cysts in the kidney in ADPKD. Macroscopic image of the left kidney, which shows numerous cysts. These findings are consistent with autosomal dominant polycystic kidney disease, ADPKD. Source: copyright IMPP. Polycystic kidney disease, 1/1. MI, 1. Overlay. Medullary sponge kidney VV ultrasound right kidney, longitudinal plane, there is dilation of the hypochoipapillary collecting ducts, green overlay, surrounded by hyperechoic renal pyramids, turquoise overlay. The renal capsule is defined by a spotted white line. These findings are consistent with a medullary sponge kidney. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 1/1. Copyright overlay. Medullary sponge kidney VV ultrasound right kidney, longitudinal plane, there is dilation of the hypochoipapillary collecting ducts, green overlay, surrounded by hyperechoic renal pyramids, turquoise overlay. The renal capsule is defined by a spotted white line. These findings are consistent with a medullary sponge kidney. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. X megaureter. Megaureter is defined as ureteral dilation 7 mm. Primary megaureter is due to obstructed or refluxing vesicoureteral junction, while secondary megaureter is caused by bladder outlet obstruction. Although rare, primary megaureter is responsible for up to 20% of hydronephrosis cases in neonates. About half of the patients with megaureter are asymptomatic. The other half may present with a urinary tract infection, abdominal pain, or features of uremia. Ultrasound, prenatal and postnatal, shows ureteral dilation, which may be accompanied by hydronephrosis. CT or Mr. urography shows a constricted terminal ureter with proximal dilation, while voiding cystogram detects vesicoureteral reflux in refluxing megaureter. Prophylactic antibiotics and regular follow UPS are sufficient in patients with primary megaureter and preserved renal function. Surgery, terminal ureter resection and reimplantation into the bladder, is indicated in patients with deteriorating renal parameters. Patients with Secondary megaureter require treatment of the underlying cause. Those who do not receive treatment can develop recurrent urinary tract infections, hydronephrosis, and obstructive nephropathy with permanent kidney damage. OES. Definition. Plus ureteral dilation 7 mm in children, 1. IOE. Epidemiology. Cent incidence, rare, 2, 4:1, 8 * occurrence, second most common cause of hydronephrosis in newborns, 20% of cases, -2 epidemiological data refers to the US, unless otherwise specified. OES. Etiology. Primary megaureter. Cent primary obstructed megaureter 1. Congenital developmental defect of the muscular layer of the terminal ureter 2. Distal upper ristaltic segment of ureter causing functional obstruction 3. Increased intraureteral pressure in dilation cent primary refluxing megaureter, dilation of the ureter secondary to primary vesicoureteral reflux, VUR, secondary megaureter. Secondary obstructed megaureter O bladder outlet obstruction, O high intracystic pressure copyright functional obstruction of the vesicoureteral junction, VUJ, O urine cannot pass into the bladder copyright ureteral dilation, 1. Secondary refluxing megaureter, bladder outlet obstruction with ureteral dilation caused by secondary vesicoureteral reflux. References 4. 4. VA. CE. Clinical features. Prenatal detection of hydronephrosis and dilated ureter on antenatal ultrasonography. Postnatal presentation 50% are asymptomatic, with normal renal parameters. Copyright often an incidental finding on ultrasound. 10 symptoms of urinary tract infection. Copyright abdominal/flank pain. Features of uremia. Back collapse. Find text outline. AQ. Clinical features. Prenatal detection of hydronephrosis and dilated ureter on antenatal ultrasonography. Sent postnatal presentation 50% are asymptomatic, with normal renal parameters. Copyright often an incidental finding on ultrasound. Symptoms of urinary tract infection. Copyright abdominal/flank pain. Features of uremia. VARO. Diagnostics. Ultrasound, best initial and confirmatory test. Hydronephrosis. Ureteral dilation 7 mm. Sent further evaluation. Copyright voiding cystourethropy, VCUG to identify retrograde reflux of urine into the ureters. 1. Copyright radionuclide renal scanning, to identify obstruction and evaluate renal function. WA. CO. XE. Treatment. Primary megaureter. Sent conservative therapy. Copyright indicated in children with preserved renal function. Copyright prophylactic antibiotics. Copyright regular follow-up surgery. Copyright indicated in children with deteriorating renal function. Copyright procedure, resection of the distal segment of the ureter and reimplantation into the bladder. Ureteroneocystostomy, secondary megaureter. Sent treatment of the underlying disease. WAA. Complications. Urinary tract infection. Sent hydronephrosis. Sent obstructive nephropathy. We list the most important complications. The selection is not exhaustive. I70CE. Sources. Last updated December 1, 2022. B. Back collapse. N. Find text. O. Outline. Megaureter, 1/2. Refluxing megaureter in avoiding cystourethrogram, 1/2, BB. Contrast filled, ballooning of the renal pelvic-calyceal system, left-right, can be seen, as well as a dilated ureter with numerous kinks. This finding indicates grade V vesicoureteral reflux. Source, copyright IMPP. Megaurator, 2 halves. Refluxing megaurator in avoiding cystourethrogram, 2 halves, VV. Contrast fill, ballooning of the renal pelvic calyceal system, left-right, can be seen, as well as a dilated ureter with numerous kinks. This finding indicates grade B vesicoureteral reflux. Source, copyright IMPP. X abnormalities of the male urethra and webbed penis. Abnormalities of the male urethra are common and the need for treatment depends on the condition and the symptoms. Epispadias and hypospadias may result in difficulty urinating and infections, and surgical repair is indicated for restoring functionality and reconstruction of external genitalia. Posterior urethral valves are the most common cause of urinary obstruction in newborn boys and can be associated with hydronephrosis, renal failure, and pulmonary hypoplasia. Early identification by prenatal ultrasound with diagnosis by voiding cystourethrogram allows for cystoscopic valve ablation and relief of the obstruction. However, despite treatment, many patients will develop chronic kidney disease. OE. Epispadias. Scent definition: EO, embryonic malformation due to malpositioning of the genital tubercle that causes incomplete urethral tubularization on the dorsal penis when associated with bladder exstrophy, although in an attenuated form 1O may also be due to chronic pressure, example as a result of a transurethral indwelling catheter eroding the urethra. Scent epidemiology: incidence is about 2.4 per 100,000 live births. Isolated epispadias, 1. Clinical features 2. Copyright cleavage and exposure of the urethra equals on the dorsal penis and associated with penile curvature equals between labia and clitoris or up to bladder o. Urinary incontinence, vesicoureteral reflux. Scent diagnostics, clinical diagnosis and treatment. Copyright in young patients, operative closure with urethroplasty and reconstruction of genitalia if indicated. Copyright in patients with long-term indwelling catheters, insertion of a suprapubic indwelling catheter, reconstructive treatment is usually not necessary. Scent complications. Copyright erectile dysfunction and infertility in males. OUTI. Hypospadias. Definition: common congenital malformation with incorrect positioning of the external urethral meatus, due to failure of urethral folds and foreskin to fuse on ventral penis. Epidemiology: incidence is 1 per 250 live births. 5. Etiology: genetic, example differences of sex development, endocrine, example 5-alpha reductase deficiency, and environmental factors have been implicated. Clinical features: O. abnormal foreskin, dorsal hood, ventral penile curvature, and 2 medial openings. O. proximal hypospadias are associated with bifid scrotum and penoscrotal transposition. Copyright associated with inguinal hernias, cryptorchidism, and chordee, a congenital abnormality characterized by an abnormal ventral curvature of the penis. Diagnostics, clinical diagnosis, treatment. Copyright mild cases do not necessarily require surgery. Copyright significant displacement or symptomatic micturition warrants surgical repair. Equals reconstruction of urethra, penis, and scrotum at 6 to 12 months of age, urethroplasty, and orthoplasty. 1 equals severe cases require 2-stage repair with correction of penile curvature first followed by urethroplasty at least 6 months later. Complications, following repair. Copyright urethral fistula. O. needle stenosis, narrowing of ventral meatus causes thin urinary stream and straining with urination equals most commonly caused by circumcision equals treatment consists of surgery. Metotomy, the meatus of the urethra is ventrally incised. O. urethral diverticulum, distinct outpouching of the urethral mucosa that most frequently leads to dribbling, dysuria, and dyspareunia. OUTIs. Circumcision is contraindicated in boys with hypospadias that includes the foreskin. In these cases, the foreskin may be needed for a skin flap when performing urethroplasty. Back collapse. Find text outline. WA. OE. Posterior urethral valves. Scent definition. Definition: congenital malformation in males where membranous folds of the urogenital membrane obstruct the membranous and prostatic urethra, posterior urethra. Scent epidemiology: incidence is about 1 per 4,000 live births. 4 * clinical features. 2 most common cause of urinary tract obstruction in newborn males. Copyright respiratory distress secondary to pulmonary hypoplasia in cases with severe obstruction. See Potter sequence. Abdominal distension due to bladder distension. Late manifestations equals difficulty voiding. Poor urinary stream equals UTIs. Urosepsis equals diurnal enuresis equals failure to thrive. Scent diagnostics. Copyright voiding cystourethrogram, diagnostic study of choice, demonstrates equals dilation/elongation of the posterior urethra during voiding equals signs of vesicoureteral reflux, if present. Prenatal ultrasound of the upper urinary tract may demonstrate equals distended and/or thick-walled bladder equals bilateral hydroureters equals bilateral hydronephrosis equals marked vesicoureteral reflux with medureter equals oligohydramnios and features of Potter sequence in severe urinary outflow obstruction. Scent treatment. Copyright temporary insertion of urinary catheter and correction of electrolyte imbalance. First line, primary valve ablation equals an endoscopic procedure that involves the transurethral incision of posterior urethral valves in the membranous part of the urethra equals performed during cystoscopy. Second line, vesicostomy, a surgical procedure in which a connection is formed between the bladder and the outside of the lower abdominal wall to allow for the drainage of urine, or if ablation is not possible, equals also indicated in patients with functional bladder outlet obstruction, example neurogenic bladder. Copyright close follow-up due to high risk of chronic kidney disease. Copyright renal transplantation may become necessary during the course of disease. Copyright fetal vesicoamniotic shunting is associated with procedure-related risks without evidence of long-term benefits for renal function. Scent complications, most common cause of chronic renal insufficiency or renal failure in boys. ICRE. Web penis. Scent definition. Definition. Copyright a congenital malformation with growth of the scrotum extending to the tip of the penis, usually only extends to the root of the penis. Copyright the urethra is typically not affected. Scent clinical features. Formation of webbing between the tip of the penis and the scrotum when erect. Copyright potential erectile dysfunction and ventral deviation. Scent diagnostics, clinical diagnosis. Scent treatment. Copyright early surgical correction with suturing of the scrotum to the penile shaft, generally for cosmetic reasons. Back collapse. Fine text. Outline. Hypospadias. Epispadias. Blind urethral pit. Partially formed foreskin, dorsal hood, displaced urethral, displaced meatus, urethral meatus. Urethra. Urethra. Partially formed foreskin, ventral hood. Hypospadias versus epispadias v. Copyright en Boss. Full term. Urethral meatus week 10 equals. And glands plus foreskin. Week 6 urethral, and genital tubercle groove penile shaft. Labia scrotal, swelling plus urethral fold urogenital fold and scrotum. Anus scrotal swelling A. Development of male external genitalia. Copyright en Boss. Eames trademark. Hypospadias. The external urethral meatus is located on the ventral aspect of the penile shaft instead of its normal location on the glans penis. Source: Hypospadias erect front view, Jurgen 88, Wikimedia Commons licensed under public domain. Hypospadias. Epispadias. Blind urethral pit. Partially formed foreskin, dorsal hood, displaced urethral, displaced meatus, urethral meatus. Urethra. Urethra. Partially formed foreskin, ventral hood. Hypospadias versus epispadias v. Copyright on Boss. Equals abnormalities of the male urethra and webbed penis, 3/3. Full term. Urethral imietis week 10 equals. Week glands plus foreskin. Week 6 urethral. A genital tubercle groove _ penile shaft. On labia scrotal swelling 4. Urethral fold - urogenital fold and scrotum. Anus - scrotal swelling. Development of male external genitalia yen. Copyright on Boss. Normal posterior urethral valves. Kidney. Hydronephrosis. Ureter. Ureter dilation. Bladder. Bladder distension and bladder wall hypertrophy. Urethra. Obstructed urethra due to posterior urethral membrane penis. Posterior urethral valves VV. Copyright on Boss. X anomalies of the female genital tract. Structural anomalies of the female genital tract may be present at birth or may be acquired later in life. Common congenital anomalies of the female genital tract are an imperforate hymen and anomalies of Mill-Ryan duct fusion. Impaired fusion of the Mill-Ryan ducts can result in duplication of the uterus, cervix, and/or vagina, while incomplete fusion results in an intrauterine and/or intravaginal septum. Rarely, the Mill-Ryan duct may be completely absent, Mill-Ryan agenesis, resulting in the absence of the uterus, cervix, and vagina. Acquired structural anomalies include intrauterine adhesions and labial fusion. Intrauterine adhesions occur following uterine curettage or as a result of pelvic inflammatory disease. Labial fusion is the result of estrogen deficiency during childhood. Most patients with structural anomalies of the female genital tract remain asymptomatic until puberty. While Mill-Ryan agenesis, labial fusion, and an imperforate hymen present with primary amenorrhea, intrauterine adhesions present with secondary amenorrhea. Infertility may be the initial symptom in all structural anomalies of the genital tract. The diagnoses of imperforate hymen and labial fusion are primarily clinical. Structural anomalies of the uterus and cervix are diagnosed with imaging such as transvaginal ultrasonography. Surgical reconstruction or resection is the main treatment for both the congenital and acquired genital tract anomalies. Labial fusion is treated with topical estrogen. OSECS. Anomalies of the uterus. Anomalies of Mill-Ryan duct fusion. Incidence 3-4/100 female individual sent pathophysiology. Copyright defective fusion of the Mullerian ducts during embryonal development. Copyright normally functioning gonads and female karyotype. Normal development of secondary sexual characteristics, example breast, pubic hair development. Anomalies of Mullerian duct fusion. Types of fusion. Relative S anomalies. Frequency. Ethophysiology. Cosent. Both of the Mill-Ryan ducts fail to develop, leading to the absent or hypoplastic uterus, absent cervix, and vaginal agenesis, but functional Mill-Ryan agenesis. Rare ovaries. Degree SE unicornuate uteru. One of the Mill-Ryan ducts fails to develop. Didelphic, OO, Co. Uterus. Complete lack of Mill-Ryan duct fusion. Double uterus, double cervix, double vagina. Incomplete fusion of the Mill-Ryan ducts to various degrees. Bicornuate uterus * 26%. Copyright uterus bicornus unicalis, double uterus, single cervix, and single vagina. Copyright uterus bicornus bicalis, double uterus and double cervix with / without a vaginal septum. Septate uterus, 35%. The Mill-Ryan ducts fuse, but the septa between the two ducts persists either partially, subseptate uterus, or completely, septate uterus. In utero exposure to diethylstilbestrol OE. Vagina, adenosis, adenocarcinoma-related abnormality. Rare. Copyright cervix, coxcomb cervix, cervical collar. Copyright uterus, T-shaped uterine cavity, hypoplasia, uterine synechii. Copyright fallopian tube, abnormal fimbriae, cornual budding. Scent clinical features O asymptomatic before puberty. Copyright infertility and dyspareunia, O in some cases, periodic lower abdominal pain, O menorrhagia. Milroyan agenesis, primary amenorrhea in a female individual with fully developed secondary sexual characteristics. Copyright increased risk of the following obstetric complications: cervical incompetence, ectopic pregnancy, preterm labor, malpresentation, 1 obstructed or prolonged labor, retained placenta, postpartum hemorrhage, recurrent mid-trimester abortions. Copyright associated with urological complications, example renal agenesis, pelvic kidney, horseshoe kidney, J and skeletal malformations, example cervicothoracic somite dysplasia. Diagnostics. Copyright screening tests transvaginal or abdominal ultrasound hysterosalpingography. Copyright confirmatory test, MRI. Copyright renal ultrasound should be performed in all patients to screen for renal abnormalities. 2. Scent treatment. Surgical treatment is usually not recommended in the following situations: another treatable cause of infertility coexists, the woman is asymptomatic. Back collapse. Fine text outline. C. Metroplasty, reconstruction of the uterus. O. Septoplasty, a type of metroplasty that only involves resection of the septum in a separate uterus. Registered in patients with infertility and congenital uterine anomalies, it is important to rule out other causes of infertility before surgical therapy is considered. Copyright. The mere presence of a Milroyan duct anomaly does not necessitate surgical therapy. Intrauterine adhesions, Asherman syndrome. Scent definition, endometrial adhesions or fibrosis. Scent etiology. Copyright following uterine dilation or curettage, most common cause, copyright post-inflammatory, example chlamydia. Scent pathophysiology, uterine dilation or curettage, endometrial basal layer damage. Scent clinical features. O usually asymptomatic. O abnormal uterine bleeding. Copyright secondary amenorrhea. Copyright infertility. O recurrent pregnancy loss. Copyright periodic abdominal pain. Scent diagnostics. 3. O negative progesterone withdrawal test, no bleeding after progesterone cessation suggests blockage of the outflow tract. O confirmatory test, hysteroscopy to directly visualize adhesions. Hysterosalpingography, honeycomb appearance of the uterus. Scent treatment. O hysteroscopic resection of the adhesions. Copyright treatment is only indicated if patients are symptomatic. B. Individuals with Asherman syndrome have intrauterine adhesions. References: 4IL5 IL6L. WA. CE. Anomalies of the vulva and vagina. Imperforate hymen. Definition: a hymen without an opening. 17. Epidemiology: 1:1000 2000 female individuals. Etiology: congenital defect. Pathophysiology: central cells of the Milroyan eminence in the urogenital sinus do not disintegrate. Imperforate hymen. Cryptomenorrhea at puberty, outflow tract obstruction leads to backup of menstrual blood, hematocolpo, accumulation of blood in the vagina, and/or hematometra, accumulation of blood in the uterus. Clinical features. O asymptomatic before puberty. At birth, vaginal secretions accumulate, may be detected as a swelling in the introitus. Spontaneous resolution. O primary amenorrhea with periodic lower abdominal pain. O possible urinary retention. Frequency: dysuria. Copyright possible palpable lower abdominal mass / copyright perineal examination, tense, bulging, bluish membrane in the vulva. O an expanding hematocolpo and/or hematometra may compress surrounding structures and cause constipation, urinary retention, radicular pain, and/or back pain. Scent diagnostics: primarily a clinical diagnosis. Imaging may be conducted to rule out transverse vaginal septum treatment, excision of the imperforate hymen, hymenectomy, and evacuation of the accumulated blood. Agenesis of the upper vagina. Scent definition: a condition in which the vagina is abnormally closed or absent. Plus epidemiology: 1/5000 female individuals. Copyright. Scent etiology: Mullerian agenesis. Scent pathophysiology: O agenesis or hypoplasia of the Milroyan duct, atresia of the upper third of the vagina, normally functioning gonads and female karyotype normal development of secondary sexual characteristics, example breast, pubic hair development. Back collapse fine text outline. Associated anomalies equals absent or malformed uterus and cervix, in almost all cases, urological malformations, 25 to 50% of cases single kidney, pelvic kidney, horseshoe kidney equals skeletal malformations, 10 to 15% of cases, scent clinical features EO asymptomatic before puberty O primary amenorrhea O infertility co-dyspareunia copyright perineal examination, vaginal dimple and a hymenal fringe scent diagnostics co-normal levels of LH, FSH, prolactin, estradiol, and testosterone O. Ultrasound absent or malformed uterus, example hemiuterus, rudimentary uterus, equals normal ovaries equals possible associated malformations of the kidneys or urinary tract O MRI to determine if functional endometrium is present scent treatment, vaginoplasty agenesis of the lower vagina. Scent etiology, abnormal development of the sinovaginal bulbs and vaginal plate scent clinical features O primary amenorrhea copyright cyclic pelvic pain scent diagnostics copyright vaginal dimple may be present on physical exam O palpable abdominal mass due to distension of the upper vagina copyright confirmatory tests, ultrasound or MRI equals normal ovaries, uterus, cervix, and upper vagina equals measurement of the distance from introitus to obstruction scent treatment, surgical pull-through procedure transverse. Vaginal septum. Scent incidence, 1/70,000 female individuals scent pathophysiology O failure of recanalization of the Mill-Ryan duct transverse septum in the upper third, 45%, lower third, 15 to 20%, and / or middle third, 35 to 40%, of the vagina copyright associated with cervical hypoplasia or absence O cryptomenorrhea hematocolposcent clinical features co-asymptomatic before puberty O primary amenorrhea copyright infertility copyright periodic lower abdominal pain copyright possibly, palpable lower abdominal mass E perineal. Examination, normal vulva and external genitalia scent diagnostics, transvaginal ultrasonography or MRI scent treatment copyright first line, non-surgical dilation over 6 to 12 months using graduated vaginal dilators copyright second line, vaginoplasty labial fusion. Scent definition, partial or complete adhesion of the labia minora scent epidemiology, occurs in 2 to 5% of female individuals up to 4 years of age scent etiology, O absence of estrogen predisposition to mild infection, local inflammation raw surface epithelium of the labia minora adhesions copyright in rare cases, trauma, sexual abuse, congenital defects scent clinical features O usually asymptomatic. O if external urethral opening is obstructed, recurrent attacks of UTI, vaginitis, vestibulitis copyright perineal examination equals a thin vertical midline fold in the perineum equals the labia, vaginal opening, and occasionally the urethral meatus are not visible. Scent diagnostics, primarily clinical diagnosis scent treatment, copyright application of topical estrogen. WA. O. Back collapse fine text outline. Uterus bicornus bicolus didelphic uterus, double uterus and double vagina. Anomalies of the uterus VV anomalies that arise from the defective fusion of the Mullerian ducts during embryonal development copyright en Boss. Anomalies of the female genital tract, 1/6. Unicornuate uterus. Rudimentary horn present, no endometrium. Non-communicating rudimentary horn communicating rudimentary horn and endometrium present and endometrium present. Anomalies of the uterus 2VV. Various types of unicornuate uteri. A unicornuate uterus is caused by complete or partial anaplasia of the Mullerian duct during embryonic development. In many cases, 70%, a second, rudimentary horn, which may feature functional endometrial tissue, is present. The rudimentary horn usually does not communicate with the fully developed horn. Copyright en Boss. Equals anomalies of the female genital tract, 3/6. RAB 48L/0B 1.2 13.6 cm 17 Hz TLS 0.11. Trit di har hokpa, ESPWR 100 WGNC 7 MP3/E. Overlay. Bicornuate uterus, uterus bicornus bicolus. Sonograph of a bicornuate uterus, U, of a pregnant woman in the first trimester. F, fetus, incomplete fusion of the uterine horns, CD, cornu dextrum/right horn, CS, cornu sinistrum/left horn. The placenta is attached to the posterior wall of the uterus. Copyright Boss. Equals anomalies of the female genital tract, 3/6. RAB 48L/OBMI 1.2 13.6 cm 17 Hz TIS 0.11. Trin har hok PWR 100 GNC 7 MP3/E. Copyright. Overlay. Bicornuate uterus, uterus bicornus bicolus, VV. Sonograph of a bicornuate uterus, U, of a pregnant woman in the first trimester. F, fetus, incomplete fusion of the uterine horns, CD, cornu dextrum/right horn, CS, cornu sinistrum/left horn. The placenta is attached to the posterior wall of the uterus. Copyright Boss. Bicornuate uterus VV. Source, bicornuateuterus.jpg, ed. Uthman, Wikipedia licensed under public domain. Subseptate uterus. Septate uterus anomalies of the uterus 3V overview of uterine deformities resulting from complete fusion of the Mullerian ducts with concomitant incomplete resorption of the uterine septum. Copyright Boss. Anomalies of the female genital tract, 6/6. Imaging of uterine anomalies VV. A1. Hysterosalpingography, HSG didelphys uterus. A2. CT, axial plane, bicornuate uterus. A3. HSG, bicornus unicalis uterus. B1. HSG, complete septate uterus and communicating septate uterus. B2. MRI, T2 weighted, coronal plane, septate uterus and cervix with single external OS. B3. HSG, subseptate uterus. Source, Figure 6, in, Diagnostic Imaging and Cataloging of Female Genital Malformations by Pedro Acien and Maribel Acien, Springer Link, licensed under CC by 4.0.